The biggest challenge for any educational institute is to equip the students with practical knowledge and The biggest challenge for any educational institute is to equip the students skills with effectively knowledge, and thus institutes are particularly
Anand sir, please start the program and chat.
A very good morning to one and all. I, Dr. Anand, Associate Professor from the Department of Oral Medicine, would like to extend warm greetings on behalf of VISHNU Dental College to our valued chairman,
Yeah, go ahead.
A very good morning to one and all. I, Dr. Anand, Associate Professor from the Department of Oral Medicine, would like to extend a warm greetings on behalf of VISHNU Dental College to our valued chairman, Shri Vishnu Raju sir.
Okay. Okay.
I would like to extend a warm greetings on behalf of VISHNU Dental College to our valued chairman, Shri Vishnu Raju sir, Vice Chairman, Shri Ravi Chandran sir, Secretary, Shri Aditya Visam sir, distinguished speakers, faculty members, and your postgraduate students to our VISHNU ADHYAAN 2022, an online review program on basic sciences. The faculty and administrators of VISHNU Dental College created VISHNU ADHYAAN. We launched this project a year ago. Many students were benefited out of it, and it was a major success. Consecutively, this year also, we have received a tremendous response from over 100 colleges with 577 registrations. This program has been created to help first-year postgraduate students before taking the university examination paper 1 in basic sciences. The main objective of these lectures is to provide students with the adequate knowledge and resources they need, giving them the chance to review crucial and relevant subject matter. It is a job eagerly volunteer to offer their extensive knowledge. We believe the upcoming 3 days will be a wonderful opportunity for learning, and we're honored to host and direct VISHNU ADHYAAN 2022. Now, we would like to begin the event with prayers and an invocation song with our heartfelt pranams.
It is off here.
Now I request Principal Dr. Suresh Sarjan sir to give welcome note on this program.
Yeah, namaskaram. Happy morning to all. Yeah. As Dr. Anand mentioned, this is basically focused on the first MDS students, since the part 1 applies to the applied basic sciences. It is very important in terms of foundation knowledge, not just writing the paper 1. So this program, we have made an attempt to recap some of the important topics for the first year students. The online platform has made it possible to reach out to a larger group of students by eminent faculty who are ready to share their knowledge. And it has also become very easy to share amongst the people all around the world, in fact. Now, on this occasion, we have our chairman, VISHNU ADHYAAN sir. We generally refer him as the wind beneath our wings. It is because of his vision and encouragement, along with Vice Chairman sir, Vice Chairman Ravi sir, and Secretary Aditya sir, and our beloved director, Dr. Anand sir, they have made this program possible. I welcome all the management team on this occasion to the platform. The Faculty of Oral Medicine, Oral Pathology, and Oral Surgery have put in enormous efforts to make this program to run smooth and effective. So I appreciate their efforts to make this very useful program. We have invited an eminent faculty to share their knowledge. Just to list up Dr. Darpan Bhargav, Dr. Nagavidya Lakshmi, Dr. Puneet, Dr. Kusum, Dr. Sendil, Dr. Prabhunath, Dr. Saumyam, Dr. Vandana Desai, Dr. Jambukeshwar, Dr. Arvind, Dr. Shweta, Dr. Vijayalakshmi, Dr. Uma Revati, Dr. Shivshankar, Dr. Shaila, Dr. Mala Dikshit, Dr. Anil Babu, Dr. Veera Varmal, Dr. Vinita, Dr. Swagatika, Dr. Madhusudan Reddy, Dr. Shrutima. All these people, all these doctors have put in a lot of efforts, and they are expertised in their own areas. So they are going to share their expertise today, and it will certainly be beneficial. I'll also feel proud to say some of the resource persons are our faculty, and some of the resource persons are also our alumni from VISHNU Dental College. Well, I welcome all the guest speakers for this occasion. The student delegates from across the country have registered. I appreciate their eagerness to learn, and I thank their faculty facilitating them to spare 3 days on this program to recap themselves. I'm sure the students will be immensely benefited by this program. I once again welcome all. Have a nice day. Thank you. Jai Hind. Namaste.
Thank you, sir, for your best wishes. Now I request our Honorable Chairman, Shri Vishnu Raju sir, to give message on this event.
I think there was some glitch. I think Chairman sir, now could you unmute yourself, sir?
Yes, sir, we can hear you, sir.
Chairman sir was unable to unmute himself, sir.
We can unmute, sir. I mean, we are not able
Dr.
to.
Sajjan, I'm not able to switch on my video because you're saying the host has to unmute it.
Audio, we can hear.
Okay, sir, we can hear you, sir. 1 second. Sir.
The video has been disabled, Dr. Sajjan. Can you hear my audio?
Yes, sir, we can hear you, sir.
Can you hear the audio?
Yes, sir, we can hear you, sir. We can see you now. Yes, sir, we can see you, sir. Please go ahead.
Dr. Sajjan, can you hear me and see me now?
Yes, sir, both, sir.
Can I go ahead?
Please,
Please, sir.
Dr. Sajjan, can I go ahead?
Yes, sir.
Yeah, I think I actually logged on almost 15 minutes back and I've been trying to contact you. I raised my hand also, but both the audio and the video have been disabled. So anyway, sorry for the delay. And good morning to all of you, and good morning to Dr. Sajjan and Dr. Anand for making the presentation in the morning. Also, I'm very happy that this type of a program is being conducted by VISHNU Dental College, basically to brush up on the fundamentals and like an online revision program for the PG students, the MDS students all over the country. I'm very happy that more than 100 colleges are participating across the country. And I was told that close to 600 students are participating. I would like to thank all the resource people, the faculty from different colleges across India, including some of our old alumni, for taking time off to sort of motivate the students and help them out. And I hope the students take full benefit of this 3-day VISHNU ADHYAAN program. In fact, I always tell Dr. Sajjan and others, Dr. Ramaraju in the dental college, that maybe the engineering colleges should take a leaf out of your procedures, because this is really good that someone is taking care of the PG students and these type of programs are being conducted. So I hope all the participants, the speakers, they're all keeping good health and they're safe. I wish the program all success. I once again congratulate Dr. Sajjan and his team from VISHNU Dental College, and thank all the resource people, the faculty who are actually taking these sessions. And I wish all the students take away a lot of benefit from these programs. And once again, thank you for inviting me. And in advance, I'd like to give all of you Diwali greetings. Thank you very much.
Thank you, sir.
Thank you, sir. Thank you for your best wishes. Now I'll introduce Dr. Shravani, an assistant professor in the Department of...
Dr. Sajjan, could you hear me, or was the audio not?
No, sir, it was good, sir.
We can hear you, sir.
We could hear you, sir.
Okay, thank you. Thank you.
Now I'll introduce Dr. Shravani, an assistant professor in the Department of Oral and Maxillofacial Surgery, who will serve as the moderator for the forthcoming scientific deliberations. Over to you, Shravani.
Thank you, sir. Good morning, all. Myself, Dr. Shravani, Assistant Professor from Department of Oral and Maxillofacial Surgery. I'm here to moderate scientific sessions for VISHNU ADHYAAN 2022. We will introduce the first resource person for the day. After the presentation, there will be a discussion regarding the topic. Dr. Darpan Bhargav sir completed his...
No, that's okay. You speak little louder.
Okay. Dr. Darpan Bhargav sir completed his bachelor's in dental surgery and master's in oral and maxillofacial surgery. He has been awarded PhD from Meenakshi Ammal Dental College and Hospital, Chennai. Sir has to his credit over 100 national and international scientific publications, He also successfully completed the Diploma of Membership from the Royal College of Physicians and Surgeons, Glasgow. He is the founder director of the TMJ Consultancy Services, and Sir is the author for the authoritative book Temporomandibular Joint Disorders, Principles and Current Practice, published by the Springer Nature, Singapore. So with this small introduction, I would like to invite the guest speaker with his scientific deliberation on the topic Functional and Biomechanics of TMJ. The platform is all yours, sir. Thank you.
Good morning, everyone, and today I'm here to throw some light into functional anatomy, biomechanics of temporomandibular joint and its clinical significance, and a little bit about muscles of mastication. So I'm Dr. Darpan, and before I start with this presentation, let me take this opportunity to congratulate and thank Vishnu Dental College on the whole and the members of the organizing team to take this endeavor forward as VISHNU Adhyaayan. And I would especially like to thank Dr. Kishore Muturi and Dr. Divya, who had been after me to get this presentation in order. I extend special thanks to both of them. And with that, when we go through and browse the question papers from previous years for basic sciences for post-graduation, these are the specific areas which have been touched and asked about. One is anatomy of the temporomandibular joint in general, then the surgical anatomy of the temporomandibular joint, and the muscles of mastication. These are the common questions in most of the universities. So I think by the end of this presentation, we should be in a position to answer most of them. Now, when we go through this presentation, you would see that it is not in exact order of biomechanics, anatomy, and muscle mastication, but it is a mixture, and we would be in a position to learn it in synchrony in a mixed manner. Now, once we go and think about temporomandibular joint, this is something which we had learned in during our initial days, where we had the mandibular condyle, we had the temporal bone forming the glenoid fossa, the articular eminence, and the articular disc in between. The entire system was attached, has attachments with lateral pterygoid muscle, and this is how it looked like. Now, once we have this basic knowledge and we are into our post-graduation and we are into a process of learning a bit extra, we should know a little bit extra about this area of study too. So when I see after so many years of R&D and look at the temporomandibular joint starting from its growing phase, so this is how I look at the temporomandibular joint during its initial growing phases, where I see the condylar bone. It is continuous with the hyaline cartilage here, which has a periosteal cover, a periosteum derived fibrous kind of a layer over it, and then you have the inferior joint space, then you have the disc in between, and the superior joint space, then you have the periosteum derived fibrocartilaginous layer just before the temporal bone articulation, and then you have the temporal bone forming the glenoid fossa. So this is how your temporomandibular joint would look like during the growing phases. Now, we should not get confused with the hyaline cartilage here. This is below the fibrous layer initially, and then fibrocartilage, which eventually covers the condylar head. This hyaline cartilage gives the growth potential to the condyle. Now, when we talk about, say, just this hyaline cartilage, you would see that during the growing phases, this hyaline cartilage in particular has so many layers in itself. So you have the fibrous layer on top, then you have the proliferative layer, then you have the chondrocytic cell layer, then you have the hypertrophic cell layer. So this is how the condyle is during the initial growing phases. And then once the condyle matures, you would see that you have the condylar bone, then eventually it is covered with periosteum derived fibrocartilage. You have the inferior joint space, you have the disc, you have the superior joint space, then again the fibrocartilage, and then again the temporal bone forming the superior articulating surface. So this is how your joint would look like. Now, the entire hyaline cartilage, which was present once upon a time during the growing phase of the condyle, on maturation of an individual, may be different for him or her at different ages. But once it happens, once your condyle matures, you would see that there is disappearance of hyaline cartilage, and there is the cartilaginous area which is converted into bone. So this is how your condyle matures, and this is how we should have a little bit of extra inputs or extra knowledge of the subject area we're studying into by now when we are in our post-graduation days. Now, when we talk about functional anatomy and biomechanics, let me throw a little bit of light into the condylar movement, which we already know that the temporomandibular joint is a gynecoarthroidal kind of a joint where it has two type of movements. One is ganglymus movement, which is the pure hinging movement, and then you have the arthroidal movement or the sliding movement of the condyle. Now, when we look into this particular video, you would see that the condyle initially rotates. If you look at the condylar movement in comparison to this yellow dot, you would see that initially the condyle just rotates, and then when compared to this red vertical line, you see that it translates forward or slides forward. So it initially hinges, gives a hinging movement or pure rotation, and then it slides forwards or translates forward. It is a combination of these two motions which give ultimate movement to the mandible. Now, when we talk about this phenomenon in a little greater details, you would understand that when you see the condyle rotate initially, as you see in this inset picture here, that condyle rotates in relation to the lower joint space. So the rotation is the movement between the condylar head and the inferior surface of the disc. So the lower joint space gives the initial rotation, and then eventually entire disc and the condyle complex translate forwards or come forwards, and that's what happens in relation to the upper joint space or the joint space above the disc. So you have two movements, the pure rotation, which is in relation to the lower joint space, and then you have the translation, which is in relation to the upper joint space. So when you have the initial rotation, it gives you the few initial millimeters of the mouth opening, whereas to attain the complete mouth opening, as you see in this second picture, you have the combination of initial rotation and then eventually the translation of the entire disc condyle complex, which gives you the maximal mouth opening. Now, once we understand this and look at this picture now, this makes some sense. When you see the actual anatomy, you have the retrodiscal area here, the superior joint space, the inferior joint space here, and then you have the intervening disc in between, you have the condyle, and then you have the glenoid fossa, and then you have the articular eminence, and then you have the initial rotation followed by translation of the entire condyle disc complex forth and back. So once you know the basic anatomy, you find with the actual anatomy in the body, and once you are fine with the actual anatomy in the body, you are fine with the normality, you can compare it with abnormal and diagnose the abnormal problems. Well, now in the first picture here, you would see that the condyle disc, initially there is condylar rotation, then the disc and condyle both translate. In the second one, the middle picture, you would see that there is slight folding of the disc, and then eventually the disc slides back onto the condylar head. So the condition, which is labeled as internal derangement with disc displacement with reduction, would look like this. So you can compare it with the normal, and you know the difference of the abnormal from the normal. This is the clinical significance of knowing your normal anatomy well and then comparing with something which is not normal. In the last picture, you see that the disc never slides back onto the condylar head and it's stuck in front of the condyle. So this is a condition where you have disc displacement without reduction. So once you've known all this, you know the normal anatomy, you know the superior joint space, the inferior joint space, the intervening disc, the condylar head, again the eminence and the temporal bone here, and you compare it with a radiological image here. Now, once you know the normal anatomy, you can understand it better on radiological images. You see the condylar head here, you see the disc on this MRI here well, and then you know where the glenoid fossa is and where the articular eminence is. So with your normal anatomy, when you're fine with that, you're thorough with it, then you can move ahead and correlate it with the radiological anatomy, and you would be in a better position to understand your radiological images. Now, once we know all this, we understand this, that the entire system of the joint gives movement to the lower jaw, the mandible, and this is controlled by the muscles of mastication and some of the accessory muscles which are involved in these movements. And this is the importance of learning the anatomy and the actions of the muscles in and around the jaw, which we would be learning shortly. Now, just to give a gist, because this was one of the questions of action of muscles of mastication. So when we talk about actions of muscles of mastication, just a hint to learn this, that you write elevation on top, then you write depression below, protraction in front and retraction behind, and towards the protraction end you take both your pterygoids, medial and lateral pterygoid, and along with the masseter. Now you go behind and put the temporalis at the retraction end. Along with this, get your digastric and genoid at the retraction, and these are the accessory muscles which are involved in the jaw movement, and then you keep your mylohyoid below. Now you mark the arrows front up, front down, front up, back, then down and back, and mylohyoid downwards. Now you, with this, you understand that masseter gives a movement of elevation and protraction, medial pterygoid gives elevation and protraction, lateral pterygoid protraction and depression, mylohyoid depression, then temporalis retraction and elevation, digastric, genoid as secondary muscles add in retraction and depression. So this is how you could learn this and keep it in your mind with some easier diagrammatic representation. For this, in case you want to read this in a greater detail, here's the reference which I have already shared with the organizers, so you would have a gist of it, and maybe you can have an opportunity to browse through the reference too. Now, when we talk about biomechanics a little further ahead, once we see the pure rotation of the condyles, although the condyles rotate around different axes, but it would be a pure rotation of the condylar head along its axis. When you see translation, then there is bodily movement of the condyle leaving its previous axis and coming forward to forming a new axis. Whereas if you look at this last picture here, you would see that when you have complex movements like chewing or grinding or the lateral movement of the mandible, you would see that there is rotation of one condyle along with translation of the other, giving side to side movement to the mandible. So these complex movements or the complex biomechanics of the jaw is because of the control of the muscles which give differential movement to the condylar heads and lets you move your lower jaw. Now, before we jump to the actual anatomy, let us learn a little bit about the innervation to the joint. Temporomandibular joint is majorly innervated by the auriculotemporal nerve along with some fibers of the messenteric nerve. The major vessels which are in relation to the temporomandibular joint are the superficial temporal and the lateral aspect, and the maxillary artery onto the medial aspect. And you would observe that the branches of the maxillary artery give supply to the temporomandibular joint. Now, moving on to the anatomical aspects of the temporomandibular joint, let us learn in these actual images from the video from the cadaveric sections. Now, when we start to learn about temporomandibular joint, you should understand that it is an articulation between the mandibular bone and the temporal bone. So, the condylar head is a part of the mandibular bone covered with fibrocartilaginous layer, and it articulates with the glenoid fossa, which is part of the temporal bone, again covered with fibrocartilage, and you have a prominence in front of it, the articular eminence. And the entire system is covered by a fibrous capsule. Note the external auditory meatus behind the joint. Now, lateral aspect of the capsule is enhanced by your lateral ligament, which is attached to the slope of the articular eminence and the condylar neck. Now, you have the intervening disc in between the condylar head and the temporal bone or the glenoid fossa. Now, the disc has got attachments along the periphery of the capsule. This disc is basically fibrocartilaginous disc. Now, we already learned that mandibular movement is the combination of rotation and translation. So, the initial rotation gives the initial mouth opening, and then the translation of the condyle disc complex gives you your maximal mouth opening. So, by now we know that the combination of movements give us the maximal or the desired mouth opening, which we would ultimately achieve by activating our muscles of mastication and the accessory muscles. Now, let us start to learn about the muscles of mastication. So, you know the lateral pterygoid plate. Let us start to learn about the lateral pterygoid muscle. Now, the lateral pterygoid muscle is attached to the lateral pterygoid plate, the lateral aspect of the lateral pterygoid plate in part of the sphenoid bone, and runs backward and lateral to give attachment to the neck of the condyle and the disc. Looking from the medial aspect, you would see that the muscle is attached to the neck of the condyle in the area called pterygoid fovea, or the depression at the neck of the condyle, and some of the fibers of this muscle do get attached to the disc itself. This is the disc. You see the superior joint space and the inferior joint space. Now let us go back and adapt your medial pterygoid muscle to this specimen. Now look at the attachments of the medial pterygoid muscle. The medial pterygoid muscle is attached here at the pterygoid plates, the medial pterygoid plate, and the medial aspect of the lateral pterygoid plate, and part of the tuberosity. That runs behind to the angle of the mandible and is attached on the medial aspect of the angle of the mandible here. Let us start to learn about the temporalis muscle. It is a large fan-shaped muscle. Here, note that the zygomatic arch is removed, and you see the attachment of temporalis muscle in the lateral aspect of the skull along the temporal lines. And from here, it goes downwards and gets attached to the coronoid process of the mandible. Now you would find this attachment onto the lateral aspect of the coronoid, anterior coronoid, and the medial aspect of the coronoid running downwards, and sometimes you would even find the tendons of the temporalis just distal to your last molar teeth. The entire temporalis system is enclosed in a layer of fascia, and you see that this muscle goes medial to the zygomatic arch to find its attachment onto the coronoid process of the mandible. Now, this is how it would look like when it is enclosed in the facial layer. Now, going on to yet another important muscle, the large, powerful muscle of the jaw, the masseter. The masseter is attached here at the lateral aspect of the zygomatic bone and the arch, and it also finds attachments to the medial aspect of the zygomatic bone and the entire length of the zygomatic arch. Now you would observe that the lateral fibers run from the zygomatic bone region till the angle, and you have some amount of vertical deep fibers of the muscle. Now this area of the lateral aspect of the ramus of the mandible gives attachment to this strong masseteric muscle, which eventually forms a attachment at the angle with the medial pterygoid, forming the pterygomasseteric sling. Now let us go on to the mandibular motion and ligaments, which control the excessive mandibular opening or limit the mandibular movements. Now these particular ligaments, when we talk about, are the one here, the stylomandibular ligament and the sphenomandibular ligament. Stylomandibular ligament is attached to the styloid process and the angle of the mandible. The sphenomandibular ligament is attached to the spine of sphenoid here till the lingula at the mandibular foramen region. Now let us learn about accessory muscles which control these mandibular movements. One is the mylohyoid, which we've seen that aids in depression of the mandible. It is attached through the mylohyoid line on the medial aspect of the mandible and is attached at the raphe in the midline and finds attachment to the hyoid bone posteriorly. Now this entire muscle forms the floor of the mouth, also aids in depression of the mandible. Now let us learn about geniohyoid. It finds the attachment from the genial tubercles to again the hyoid bone posteriorly. Now the stylohyoid muscle, from the styloid process to the hyoid bone, it has an opening for the bellies of digastric. The digastric muscle, posterior belly of digastric, the tendon of digastric, and the posterior belly is attached to this area medial to the mastoid process, runs downwards and anterior, the tendon of digastric is attached to the hyoid bone through a pulley, continuous with the anterior belly of the digastric muscle, which is attached onto the digastric fossa on the medial aspect of the mandible. So I hope that gives some light on to the basic anatomy of the temporomandibular joint and also the muscles of mastication. Now, with that, we learn the importance of the correlation of the normal anatomy with the biomechanics of the temporomandibular joint, along with the regional and surgical anatomy of the temporomandibular joint, associated muscles which help to move the lower jaw, along with the accessory muscles which aid in the movement of the lower jaw, along with the major muscles of mastication. And by now, I think we are in a situation to answer all the three questions which are commonly asked in most of the basic science papers. One is the anatomy of the temporomandibular joint. Second, the surgical anatomy of the temporomandibular joint. And third, the detailed anatomy and actions of the various muscles of mastication. So with that, I thank all of you for patient listening, and I would recommend that in case you want to read in further details about what I just spoke, you can go back and refer our manual, which I've already shared as links with the organizers in case you're interested. And with that, thank you very much for patient listening, and I think the floor would be open for questions shortly. Thank you. Thanks a lot.
Thank you, sir. Your presentation is very useful for first year postgraduates and covered all basic topics related to the TMJ. So we have few queries from the PG students. Sir?
Yes, Dr. Shravani, I'm there.
Queries from the PG students, sir. So question is, so what are the ligaments that helping in positioning the temporomandibular disc in the position within the glenoid fossa, sir?
Okay, now very good morning to one and all, and thank you for inviting me to this platform. I thank all the organizers on this outset, and especially Dr. Kishore, who was instrumental in getting me here and introduce me to all of you. Before I start now, let me start by saying that when it comes to post-graduation, some of it was taught to me by my great teachers, and some of it is added by me to this statement that when you are a postgraduate, you should have, it was specifically told for oral surgeons in particular, but I generalize it because it may be valid to your fields of study too, that when you are a postgraduate, you should have eyes of an eagle. You should see that sharp from that far end. You should have fingers of a lady. You should have a heart of a lion. You should be so daring, and you should have sleep and vigilance like a dog. So that was the purpose of adding that music to that video, that when you are interested in something very much, you add a nonsense distraction to that particular thing, and still you would be interested in the thing you are interested, and you would concentrate more. So when I could not actually, these are the live lectures and we could mute the music in the live lectures, but in the video it wasn't possible at that instance. So I just left it because I read somewhere in one of my son's online classes that you add a distraction which is nonsense will make you more vigilant. So I think you did the good job out of it. And when we talk about the ligaments in particular, you have certain collateral ligaments which are present, which control the discal movement. These collateral ligaments are continuous with the capsular ligaments onto the lateral aspect of the disc, which position the disc. Along with that, you have the anterior discal attachment and the retrodiscal attachment to the disc, which controls the movement of the disc.
Thank you, sir. What is the second question is, what is the role of accessory muscles in the TMJ function, sir?
I think we well demonstrated, and if you look at the diagram, the pictorial diagram, where we could easily learn how the muscles of mastication and accessory muscle act, they do aid and help in the normal mandibular position, number one, and second, the mandibular movement. So specifically the suprahyoid muscle group controls the inferior stretch to the mandible, that is the depression to the mandible, and some of the muscles do aid in lateral excursive movements to the mandible.
Thank you, sir. Now all other questions will be answered to you through the mail. Thank you.
Thank you very much.
Sir, certificate will be displayed to you, sir.
I am thankful for that honor. Hope the presentation is useful for the postgraduates.
Yes, sir. Thank you, sir. So now we will begin with the next introduction of the second presenter. After the presentation, there will be a discussion regarding the topic. Dr. Kanna Nagavidya Lakshmi ma'am, Associate Professor, Department of Anatomy. She completed her BDS in 2008 from Sibar Institute of Dental Sciences, Andhra Pradesh, and MSc Medical Anatomy in 2012 from Katuri Medical College and Hospital, Andhra Pradesh. She pursued MBA in Hospital Administration in 2021, ICFA University Tripura, and PhD Medical Anatomy in 2020 from Sarvepalli Radhakrishnan University, Bhopal. She has a professional specialization certification course in forensic odontology 2021 IFS Pune. She has a total 9 years of teaching experience in the field of anatomy with various publications on her name. She has been a reviewer for several international journals. Now, ma'am is going to talk on the topic blood vessel, venous and lymphatic drainage of head and neck. Ma'am, now you can start the presentation. Thank you.
Hearty welcome to all the postgraduates across the country on behalf of VISHNU ADHYAAN for the online revision program. Hope you're going to have a wonderful time with the 3-day session. Myself, Dr. Nagavidya Lakshmi, working as an associate professor in the Department of Anatomy, VISHNU Dental College. Today, I'm going to present a quick and brief review on blood supply and lymphatic drainage of head and neck. Blood supply includes arterial supply and the venous drainage, where the arteries carries the oxygenated blood to distant parts of the body, and in turn, veins will collect the deoxygenated blood from various parts of the body and is transported back to the heart. Always remember, artery is a vessel that carries the blood away from the heart. Veins are the vessels that brings the blood towards the heart. Not necessary, all the arteries carries the oxygenated blood and all the veins carries the deoxygenated blood. There are certain exceptions like pulmonary vessels and umbilical vessels. Instead of oxygenated blood in the arteries, deoxygenated blood will be carried. Instead of deoxygenated blood in the veins, oxygenated blood will be carried out. Anatomically, arteries were classified based on the size into larger artery, adventitia. In case of artery, the tunica media will be 2 times more than the intima and adventitia, whereas in vein, the tunica adventitia is more than tunica intima and media. And the basic difference between the large artery and the medium-sized artery is the presence of elastic tissue in the tunica media of large artery, while the medium-sized artery contains smooth muscles in its structure. Circulation. Heart plays a major role in being a central pumping organ to maintain the circulation. We have 3 different types of circulation. First one is the systemic or greater circulation that begins from the left ventricle through the aorta to various parts of the body and from the body to the right atrium through systemic veins, namely superior and inferior vena cava. This circulation from left ventricle to the right atrium is called systemic circulation. And the other variety is pulmonary circulation, which usually begins from the right ventricle. Through the pulmonary artery, the blood enters into the lungs, gets oxygenated. The pulmonary veins bring back the oxygenated blood into the left atrium. This circulation, which begins from the right ventricle and ends at the left atrium, is called pulmonary circulation. So again, always remember, artery is the vessel that carries the blood away from the heart. Vein is the vessel that brings the blood towards the heart. Take a minute, find out the odd one here, and please inbox which of the vessel is showing the odd flow here. Here is the answer. Instead of person diving out from the pulmonary artery, here it is happening in reverse. Now coming to the actual topic for today, that is the arterial supply of head and neck. As I mentioned earlier, systemic circulation always begins from aorta that arises from the left ventricle. Aorta has the ascending part, arch of the aorta, and the descending part. Ascending part of the aorta gives off branches, namely coronary arteries that supplies the heart itself. Arch of the aorta gives off 3 branches. On the right, it is the brachiocephalic trunk. On the left common carotid artery and left subclavian artery. Brachiocephalic trunk further divides into right common carotid artery and right subclavian artery. Right and left subclavian arteries supplies the upper limbs, while the common carotid arteries supplies head, neck, and brain. Observe the difference on the right and left side. On the right side, the right common carotid and the subclavian are not directly rising from the aorta, while on the left side, they are directly taking origin from the arch of aorta. The common carotid artery bifurcates into external and internal carotid artery within the carotid triangle near the upper border of the thyroid cartilage that corresponds to C3, C4 cervical vertebra. In children, this bifurcation is one level above the C3, C4 cervical vertebra. Near the bifurcation, we observe carotid bodies that act as a chemoreceptor, detecting the chemical changes in the normal environment, which will be transmitted to the central nervous system to restore the normal homeostasis. On the other hand, we can also observe carotid sinus near the beginning of the internal carotid artery, which acts as a baroreceptor or a mechanoreceptor, usually senses the pressure changes, which in turn regulates the blood pressure. External carotid artery is the chief artery of the face and neck, which is given off in the carotid triangle at the upper border of the thyroid cartilage. The external carotid artery ascends up by giving 8 branches in total. 3 were the anterior branches, namely superior thyroid branch, lingual branch, and the facial branch. 2 will be the posterior branches, posterior auricular branch and the occipital branch. 1 will be the medial branch towards the midline, that is the ascending pharyngeal branch. Then the external carotid artery passes through the substance of the parotid gland, where it terminates into superficial temporal and maxillary artery. We can use the mnemonic Sister Louis powdered face often attracts silly medicos to remember the branches of the external carotid artery. First letter of each word represents a branch of external carotid artery. Moving on to the facial artery, it is one of the chief artery of the face, given off within the carotid triangle from the external carotid artery. It passes for a while between the posterior belly of digastric and stylohyoid muscles. Then it curves from the submandibular salivary gland near the anterior-inferior angle of the masseter. The artery ascends up over the face. It reaches the corner of the mouth. Then it further ascends, passes over the lateral wall of the nose, finally terminates near the medial commissure of the eye. The branches given off from the cervical part of the facial artery includes anterior palatine artery, glandular branches to supply submandibular and sublingual glands, submental artery to supply the region near the chin, and tonsillar branch to supply the palatine tonsil. Over the face, the branches given off were inferior labial to supply the lower lip, superior labial branch to supply the upper lip, lateral nasal to supply the lateral part of the nose, and finally the facial artery terminates as angular artery by anastomosing with the branches of internal carotid artery. So facial artery, the course is remarkably tortuous to accommodate the movements of the facial expression as well as the deglutition movements. This is the cadaveric image showing the tortuous course of the facial artery over the face. We can also appreciate submandibular salivary gland, parotid gland, facial vein. This is the parotid duct and the upper buccal branch of the facial artery. Note, facial artery is also called as external maxillary artery. Maxillary artery is one of the largest terminal branches of external carotid artery given off within the parotid gland. It is divided into 3 parts, namely mandibular part, pterygoid part, and the pterygopalatine part by lateral pterygoid muscle. The first part runs between the neck of the mandible and the sphenomandibular ligament. The second part runs over the lower head of the lateral pterygoid muscle, while the third part runs between the upper and lower head of the lateral pterygoid muscle. And the third part reaches the pterygopalatine fossa, where it gives off further branches. So the mnemonic to remember the branches from the first part is MIDA. M stands for middle meningeal artery. A stands for accessory meningeal artery. Both the arteries supplies the meninges of the middle cranial fossa. Middle meningeal artery ascends up into the cranial cavity through foramen spinosum, while the accessory meningeal artery ascends upwards into the cranial cavity through foramen ovale. I stands for inferior alveolar branch, which further gives off an artery to the mylohyoid muscle. This inferior alveolar branch passes through the mandibular foramen, then through the mandibular canal by giving dental and incisive branches, and finally comes out as mental artery. D stands for deep auricular branch, which supplies the deeper surface of the external ear, and the anterior tympanic branch supplying the anterior surface of the tympanic membrane. The branches from the second part mostly supplies the muscles of mastication. The first one being the massetic branch supplying the masseter, temporal branches supplying the temporalis muscle, pterygoid branches supply medial and lateral pterygoid muscle, and the buccal branches supplying the cheek. The branches for the Before going to the branches for the third part, let's see the mnemonic for the second part. It is a BMOM. B stands for buccal branch. MOM means the muscles of mastication. The branches from the third part includes posterior superior alveolar artery, infraorbital artery, greater palatine artery, sphenopalatine artery, pharyngeal branch, and the artery to the pterygoid canal. Posterior superior alveolar branches supplies the molar tooth. Infraorbital branch passes through the infraorbital canal, comes out through the infraorbital foramen. On its way, it gives off middle superior alveolar and anterior superior alveolar branches to supply the premolars and the anterior tooth. Sphenopalatine branch and the greater palatine branch supplies lateral wall of the nose, greater part of the palate, and also the paranasal air sinuses, while the pharyngeal and artery to the pterygoid canal branches, they supply nasopharynx, eustachian tube, and the structures surrounding the pharynx. This is the cadaveric image showing the third part of the maxillary artery. So we can appreciate the posterior superior alveolar branches and also the branches from the second part, the temporal branches, buccinator branch, and the branch to the medial pterygoid, branch to the masseter. Which of the following branches arises from the second portion of the maxillary artery? And the answer is buccal artery. Not only the buccal artery, second part provides branches to the muscles of mastication. Maxillary artery gives rise to all of the following branches except. And the answer is submental branch, which is a branch of facial artery given off in the cervical region. Lingual artery is one of the anterior branches of the external carotid artery. It is given off between superior thyroid artery and the facial artery. Lingual artery is divided into three parts by hyoglossus muscle. The first part runs from the origin to the posterior border of the hyoglossus. The second part runs deep to the hyoglossus, while the third part begins from the anterior border of the hyoglossus. It ascends upwards, then passes underneath the tongue. The branches of lingual artery were suprahyoid branch, dorsal lingual artery, sublingual artery, and the deep lingual branch. It is recommended to ligate the lingual artery near the first part in case of any surgical interventions related to the tongue is involved. Superior thyroid artery, it is one of the anterior branch of external carotid artery. It supplies the thyroid gland above the level of the isthmus. As we can observe, superior thyroid artery and the external laryngeal branch of the vagus nerve both go in close conjunction. As they approach near the gland, they move apart. So it is always recommended to ligate the artery nearer the gland during the surgical procedures. The branches of the superior thyroid artery, this is the mnemonic to remember the branches: stainless steel, glass ionomer cement. So S stands for superior laryngeal branch, S stands for sterocleidomastoid branch, G for glandular branches, I for infrahyoid, C for cricothyroid branch. This picture represents the blood supply to the brain. Here we can observe the internal carotid artery is terminated into anterior and middle cerebral branches. On the other hand, there is a branch from the subclavian artery, which is called as vertebral artery, ascending through the transverse foramen of the cervical vertebra, entering into the cranial cavity through the foramen ovale. So as it continues as basilar artery, it terminates by giving posterior cerebral arteries. There will be a communication established between anterior cerebral, middle cerebral, and posterior cerebral branches, forming what is called as circle of Willis. It is important to know the pulse points where exactly to take the arterial pulses in the head and neck. Place a finger near the anterior-inferior angle of the masseter to feel the facial pulse. Below the angle of the mandible, we can appreciate the carotid pulse. In front of the trachea, it is easy to feel the pulse of the superficial temporal artery. Over the temporal bone, we can easily appreciate the pulse of anterior branch of superficial temporal artery. Since carotid pulse is the strongest, it is important to know how to check the carotid pulse by using the hand. We should place our index and middle fingers on the neck to the side of the larynx in the carotid triangle under the angle of the mandible. This is the exact location to palpate the carotid pulse. Arterial disease were majorly classified into coronary artery disease, peripheral artery disease, and the carotid arterial disease. There are so many risk factors that can lead to the vascular diseases. These risk factors include stress, sedentary lifestyle, diabetes, high cholesterol, high blood pressure, obesity, alcohol, smoking, age, gender, which cannot be controlled. All these are the risk factors pertaining to the vascular disease. If there is any abnormal aneurysm of the abdominal aorta, that can lead to severe back pain. Diminished blood supply to the lower limbs can cause swelling of the lower limb, coldness in the lower limb, as well as the cramps. Clot in the vessels of the neck can even result in blurred vision. There are certain terminology related to the vessels. Coarctation of aorta. This is the congenital anomaly observed where there is a abnormal constriction of the aortic wall, patent ductus arteriosus, in which the communication between the pulmonary artery and the aorta exists, aortic stenosis, abnormal narrowing of the aortic wall. Thrombus is the term applied to the blood clot that is attached to the vessel wall. Embolus is the free-flowing blood clot. Arteriosclerosis, where there is stiffening of the arterial wall as the age progresses. Atherosclerosis is the accumulation of plaque inside the vessel wall. Aneurysm is the abnormal dilatation of the aorta. Stroke is of three varieties. First one is the ischemic stroke, where there is diminished blood supply. Second one is the hemorrhagic stroke, where there is abrupt rupture of the blood vessel leading to stroke. Third one is the atherosclerotic stroke. Coronary artery disease or the ischemic heart disease, where there is diminished blood supply to the heart that can lead to chest pain, and the condition we call it as angina pectoris. Angiogram is the optical procedure used to visualize the blockage of the coronary arteries. Venous drainage of the head and neck. Veins are the vessels that bring blood towards the heart. Sinus is a sac or a cavity in any organ or the tissue. The brain and the meninges were drained by dural venous sinuses. These are the cavity that are filled with the venous blood associated with the dura mater. The veins of the scalp and face take the synonymous names of the arteries that accompany them, and they ultimately drain into internal and external jugular vein. The neck drains into anterior jugular veins. Let us see how the external jugular vein is formed. This is the superficial temporal vein, which is joined with the maxillary vein within the parotid gland to form the retromandibular vein. Near the apex of the parotid gland, the retromandibular vein divides into anterior division and the posterior division. The posterior division of the retromandibular vein joins with the posterior auricular vein to form the external jugular vein. On the other hand, supratrochlear vein and supraorbital vein joins to form the angular vein, which continues as the facial vein. Anterior division of the retromandibular vein joins with the facial vein to continue as common facial vein that will be drained into the internal jugular vein. We can also appreciate the formation of anterior jugular vein from the submental veins. Let us see how the internal jugular vein is formed. This is the superior sagittal sinus. This is the inferior sagittal sinus. This is the stride sinus. And this is the occipital sinus. All the four sinuses meet at a point which is called as confluence of sinuses. From the confluence of sinuses, the venous blood is drained into the transverse sinus. From there to the sigmoid sinus, where sigmoid sinus is joined with the inferior petrosal sinus to form the internal jugular vein near the jugular foramen. On the other hand, cavernous sinus receives tributaries from the orbit through ophthalmic veins, spinoparietal sinus, and facial vein. Cavernous sinus communicates with the sigmoid sinus through superior petrosal sinus, and through the inferior petrosal sinus, it drains into the internal jugular vein. Internal jugular vein also receives tributaries from superficial temporal vein, facial vein, superior and middle thyroid veins, ultimately poured into the brachiocephalic vein of right and left sides. From there, it is transported to the superior vena cava to right atrium. External jugular vein receives tributaries from occipital vein, posterior auricular vein, then drained into the subclavian vein. Through the subclavian vein, it reaches the brachiocephalic vein of right and left side. From there, it is poured into the superior vena cava to reach the right atrium. The veins of the head and neck are valveless since they are draining towards the gravity. The rest of the veins in the body do contain valves to prevent the backward flow of the blood. Try to think about the missing blocks. What are the sinuses that were missing here? What is the other sinus that forms the confluence of sinus? It is the occipital sinus. Here, cavernous sinus will be connected with the sigmoid sinus through superior petrosal sinus. Sigmoid sinus is joined with the inferior petrosal sinus to form the internal jugular vein near the jugular foramen. Here is the question for you. Which of the two dural venous sinuses unite to form the internal jugular vein? And the answer is inferior petrosal and the sigmoid sinus. One of the important venous plexus is the pterygoid venous plexus in the retromolar area, where three veins were joined into the pterygoid venous plexus. First one is the deep facial vein. Second one is the inferior ophthalmic vein. And the third one are emissary veins connecting cavernous sinus with the pterygoid venous plexus. All these three tributaries are joined into the pterygoid venous plexus. Pterygoid venous plexus will drain into the maxillary vein and through the retromandibular vein into the external vein. Since pterygoid venous plexus are present in the retromolar area, they should be considered to avoid bleeding during surgical procedures. So this is the mnemonic to remember the tributaries that join the pterygoid venous plexus. D stands for deep facial vein, I for inferior ophthalmic vein, and E for the emissary veins connecting cavernous sinus with the pterygoid veins. M is the maxillary vein into which the ultimate drainage happens. Applied anatomy relevant to the veins, jugular venous pulse. Only the jugular venous pulse is non-palpable and the jugular veins are readily uploadable. This pulse is located between the two heads of the sternocleidomastoid. This pulse usually drops during inspiration or while sitting erect, and this has a biphasic contour waveform in ECG. Normally, the venous pressure is not measured because the pressure exerted by the flowing blood in the veins is very low, less than 8 mmHg. That is the reason we always use arteries to measure the pulse. On the right hand side, we can observe the dilated vein where there is an abnormal blood flow and the deformed walls of the vein pertaining to the lower limb. So we can have the signs and symptoms like swelling, itchy skin, spider veins, varicosities, blood clots, discoloration and ulceration of the skin. Lymphatic drainage of the head and neck. Functions of the lymphatic include fluid recovery, immunity, and the lipid absorption. Lymphatics tend to remove the interstitial fluid from the tissues and helps in return of the protein, water, electrolyte that is lost in our daily life. Immunity. It transports the antigen presenting cell to the lymph nodes where immunological response is regulated. It absorbs and transports the nutrients, fatty acids and fats as chyle from the GIT. These are the components of the lymphatics, which include lymph, which is a clear, colorless fluid without plasma proteins, capillaries, joined to form the lymphatic vessels. The lymph will be transported through the lymphatic vessels. And there are lymphatic organs, which are subdivided into primary and secondary lymphatic organs, through which the lymph will be filtered. Lymph vessels join to form the trunks. Trunks lead to the ducts. Ducts will open into the veins, where the ultimate drainage happens. This is the image showing the drainage of the right side and left side of the body by the respective lymphatic ducts. The right lymphatic duct drains head, neck, upper thorax, and the upper limb of the right side. Rest of the body will be drained by the left lymphatic duct, that is the thoracic duct. This is the general classification of the lymphoid tissue, where the lymphoid organs are classified as primary lymphoid organs and secondary lymphoid organs. Primary lymphoid organs, also called central lymphoid organs, based on the placement, they are present in the center of the body. For example, thymus and bone marrow. Thymus is located in the anterior mediastinum in front of the heart and behind the sternum. Thymus brings about cellular immunity, and thymus helps in the production of T lymphocytes, while bone marrow brings about humoral immunity by producing B lymphocytes. Secondary lymphoid organ or a tissue is further classified into simple, intermediate, and organs. Under simple, we again have diffuse type, solitary type, aggregate lymph nodes. Intermediate, example, palatine tonsil, and the organs like lymph node and spleen. Under diffuse variety, we have mucosa associated lymphoid tissue and gut associated lymphoid tissue. Solitary lymph nodes, they are present in the mucous membranes of the intestine, whereas the aggregate lymph nodes are seen as the Peyer's patches in the ileum. Lymph nodes of the face and scalp are called as horizontal group of lymph nodes from anterior to the posterior. Here below the chin, we have the submandibular group of lymph nodes. Below the mandible, we have the submandibular group of lymph nodes. In front of the ear, parotid or the preauricular lymph nodes. Behind the ear, postauricular or the mastoid lymph nodes. And over the occipital region, we have the occipital group of lymph nodes. While the lymph nodes of the neck are called vertical group, they are further divided into superficial cervical group and the deep cervical group. Superficial cervical group of lymph nodes are placed along the external jugular vein, hence also called external jugular group. Deep cervical group is further classified into median or midline or the anterior group and the lateral group. Under median group, we have supra and infrahyoid group of lymph nodes, retropharyngeal nodes, prelaryngeal nodes, pretracheal and paratracheal nodes, Waldeus group of lymph nodes. Lateral group is made of 3 chains. First chain involves the internal jugular group, which is further divided into jugulo-digastric and jugulo-omohyoid group. Second chain of lymph nodes were transverse cervical group, and the third chain were spinal accessory group. Of all the lymph nodes that were present, deep cervical nodes is of clinical importance. Jugulo-digastric node, it is placed where the posterior belly of digastric is crossed by the internal jugular vein, while the jugulo-omohyoid node is at or just inferior to the intermediate tendon of the omohyoid muscle. This is the superior belly of omohyoid, and this is the inferior belly of omohyoid. Enlarged jugulo-digastric nodes are commonly found in tonsillitis. While any enlargement seen in the jugular omohyoid nodes is indicative of clinical relevance with the tongue as it receives the lymphatic drainage from the tongue. This image is showing the efferents draining into the respective lymph nodes. For instance, submental lymph nodes receives the efferents from lower lip, floor of the mouth, and the apex of the tongue. Submandibular nodes from the cheek, side of the nose, lower lip, gums, and the anterior tongue. Superficial cervical nodes receives the efferents from lower part of the ear, parotid, as well as the mastoid nodes. Remember, all the lymph from the head and neck will ultimately drain into the deep cervical nodes. The efferents from these nodes forms the jugular trunk. On the right side, the jugular trunk drains into the right lymphatic duct. On the left side, the jugular trunk drains into the thoracic duct. Virchow's node is an enlargement of the left supraclavicular nodes or the left scalene nodes, usually enlarged in the malignancy of the stomach. These are otherwise called Croiser's nodes. Lymphatic system plays a major role in the spread of the cancer cell from one region to the another region through a process called metastasis. Lymph node or the lymphatic system plays a major role in the metastatic spread of the cancer from one part of the body to another part of the body. Lymph node has to be inspected for presence of the swelling, number, size, surface, skin over the swelling, and the pressure effects. Number usually single or multiple. In few conditions, there will be generalized involvement of lymph nodes like Hodgkin's disease, tuberculosis, lymphosarcoma, and sarcoidosis. In acute lymphadenitis, the skin becomes inflamed with redness, edema, and a brawny induration is seen. Skin over the tuberculosis, lymphadenitis, and the cold abscess remains cold till they reach a point of burst. Over a rapidly growing lymphosarcoma, skin will be shiny with visible underlying subcutaneous veins. And for the pressure effects, we need to go for a careful inspection of the whole body to detect any pressure effect due to the enlargement of the lymph nodes, edema or the swelling of the upper limbs, enlargement of the axillary lymph nodes, edema or the swelling of the lower limb, enlargement of the inguinal lymph nodes, swelling, and the venous enlargement of face, neck may occur due to the pressure effect of the lymph nodes near the root of the neck. Hypoglossal nerve may be involved in case of upper deep cervical involvement. Lymph nodes has to be palpated for number and situation, local temperature, consistency of the lymph node, tenderness, surface and margins, and the fixity. The consistency is usually soft. It might be rubbery in case of Hodgkin's disease, stony hard in case of secondary carcinoma. These are the images showing how to palpate the regional lymph nodes. Submental nodes, we need to place our hand below the chin, and the clinician should stand behind the patient. For the submandibular nodes, the hand to be placed below the angle of the mandible. For the preauricular nodes, in front of the tragus of the ear. Behind the ear, mastoid nodes or the posterior auricular nodes can be palpated, and this image is showing the palpation of the occipital nodes, and this is the palpation for supraclavicular node. For radical dissection of the neck nodes were classified according to the levels. Level 7 is no longer used. The lymph nodes describe the neck dissection, and the neck is divided into 6 areas of the levels. These levels were identified by the Roman numerals, increasing towards the chest. Level 1A is the submental group, and 1B is the submandibular group. Level 2A and 2B belong to the upper jugular group, where 2A is present in front of the spinal accessory nerve and 2B is behind the spinal accessory nerve. Level 3 includes the middle jugular group. Level 4 is the lower jugular group. Level 5A and 5B are the posterior triangular group. 5B in specific, it is called as transverse cervical group. And sixth one is the midline or the anterior group or the median group, involving prelaryngeal, pretracheal, and the paratracheal lymph nodes. And the level 7, which initially called as nodes of the upper mediastinum, is no longer in usage by the American Oncology Association. Thank you very much. And the topic is open for discussion.
Thank you, ma'am, for your wonderful presentation. And now we have queries from the post-graduation students. Ma'am, what are the vascular complications that are occurring during the dental treatment? So we should have a proper history of the patient. If the patient is under any medication that has the antiplatelet activity like aspirin, so during there is a complication of bleeding or hemorrhage that can not be controlled during the surgical procedures. So we should have a proper history before undergoing any surgical treatment to the patient. Thank you, ma'am. And the second question is, so which cranial nerve may be involved when the deep cervical nodes are enlarged? Hypoglossal nerve is the nerve that is most commonly involved in case of enlargement of the upper deep cervical nodes. Ma'am, the next question is, what are the pressure effects in the lymph nodes? There will be pitting or indurations of the lymph nodes. And if the lymph nodes of the cervical region enlarge, it can cause pressure over the larynx, causing difficulty in breathing. The condition, we call it as dyspnea. The same pressure effect, if it is extended to the esophagus or the pharynx, that can cause dysphagia or the difficulty in swallowing. So cervical lymph nodes are considered. Right. So cervical lymph nodes, as the neck is the very narrow region and vital things passing through the neck like windpipe and the foot pipe. So we should be careful during the enlargement of the cervical lymph nodes that can cause the pressure and make it difficult to eat and breathe. That can be life-threatening even. Right. It can cause suffocation. Right. Thank you. Thank you, ma'am. Next, all questions will be answered through the mail to you. Thank you. Ma'am, this is the certificate of appreciation from the team VISHNU ADHYAAN, ma'am. Thank you. Thank you so much. Appreciation certificate from team VISHNU ADHYAAN, ma'am. Thank you. Thank you, ma'am. Now we will begin with the introduction of the next presenter. After the presentation, there will be a discussion regarding the topic. Dr. Puneet Wadhwan sir is an oral and maxillofacial surgeon in Gomti Nagar, Lucknow, and has an experience of 21 years in these fields. Sir completed BDS from DAV Centenary Dental College, Yamuna Nagar, and MDS Oral and Maxillofacial Surgery from Meenakshi Ammal Dental College and Hospital. Sir was awarded silver medal for standing first in aggregate of first professional BDS examination, DAV Dental College, and was awarded medal for best outgoing postgraduate in oral and maxillofacial surgery in the year 2003. Sir has many national and international publications to his academic credit. His areas of special interest are facial trauma, orthodontic surgeries, cleft lip and palate surgeries, TMJ surgeries, and dental implants. Now, sir is going to speak on the topic of anatomy of maxillary sinuses and its clinical relevance in dental practice. Over to you, sir. Thank you.
A very good morning to you all. At the outset, I would like to thank VISHNU Dental College and the organizers for organizing this online revision program for postgraduates. Today, I would be talking about the anatomy of maxillary sinus and its clinical relevance in dentistry. The maxillary sinuses were first illustrated and described by Leonardo da Vinci in 1849 and later documented by Highmore in 1651. The maxillary sinus consists of is pyramidal in shape, consisting of a base, an apex, and four sides. The base is formed by the lateral wall of the nose. The apex projects laterally into the zygomatic process of the maxilla. The four walls of the pyramid are formed by the anterior and the posterior wall of the maxilla, as shown here. The superior wall is formed by the floor of the orbit, which forms the roof of the antrum. And the inferior wall is formed by the alveolar process of the maxilla, and it forms the floor of the antrum. Coming to the anterior wall. The anterior wall of the maxillary sinus is formed by the facial surface of maxilla and is internally grooved by the canalis sinuses, which houses the anterior superior alveolar nerve and vessels. The anterior wall has three major landmarks: a thin canine fossa, the infraorbital foramen, located in the mid-superior region, and an infraorbital groove. The posterior wall is formed by the infratemporal surface of the maxilla. It forms the anterior border of the pterygopalatine fossa. The lateral apex of the maxillary sinus extends into the zygomatic process of the maxilla and can sometimes reach into the zygomatic bone, therefore forming the zygomatic recess. The medial wall of the maxillary sinus separates the sinus from the nasal cavity. It is smooth on the sinus side and carries the inferior nasal concha on the nasal side. The medial wall is rectangular in shape and is slightly deficient at the maxillary hiatus. This opening is partially closed by an articulated skull by sections of inferior turbinate, the uncinate process of ethmoid bone, the perpendicular plate of the palatine bone, the lacrimal bone, and the overlying mucosa to form the ostium as well as the anterior and posterior fontanelles. The term hiatus seminaris was first introduced by Zuckerkern to describe half moon-shaped gap between the posterior edge of the uncinate process and the anterior edge of the ethmoid bulla. The hiatus seminalis is important clinically because of its relationship to the drainage patterns of the frontal maxillary and the anterior ethmoidal sinuses. The superior wall is formed by the fragile triangular orbit floor with the infraorbital groove running through it. The roof of the sinus thickens towards the orbital margin with a mean thickness of 0.4 millimeters medial to the infraorbital canal and 0.5 millimeters thick lateral to it. The floor of the sinus is formed by the alveolar and palatine process of the maxilla and lies below the nasal cavity, which is usually located from the mesial part of the first molar, premolar, to the distal part of the third molar, with the lowest at the first and second molar. The floor of the sinus is separated from molar dentition by a thin layer of compact bone. The maxillary posterior teeth, root tips, are in close relationship to the floor of the sinus, with the root tips of the molar being close to the floor of the sinus than the premolars. CT studies have revealed the mean distance between the maxillary posterior teeth and the sinus floor to be 1.97 millimeters. CT studies have also shown that the roots of the first and second molars have been shown to have a significantly close relationship with the sinus floor in 40% of the cases and perforate the sinus floor in 2.2 and 2% of the cases respectively. The average dimensions of the sinus according to Turner in 1902 are approximately 3.5 centimeters anteroposteriorly, 2.5 centimeters in width, and about 3.2 centimeters in height. The volume is approximately 15 to 30 ml, and the ostium opens into the middle meatus and is about 3 to 6 millimeters in diameter. Coming to the sinus lining, the nose and the sinuses are lined by a pseudostratified columnar ciliated epithelium with numerous goblet cells supported by a vascular lamina propria containing serous and mucous glands and numerous thin-walled venules. Together, the epithelium and the lamina propria constitute the mucosa. Mucosa lining the nose and the paranasal sinuses is bound to the underlying periosteum, and this mucoperiosteum is commonly referred to as Schneiderian membrane. The Schneiderian membrane lines the inner wall of the sinus and in turn is covered by pseudostratified columnar ciliated epithelium. Normally, the thickness of Schneiderian membrane varies from 0.13 millimeters to 0.5 millimeters. However, inflammation or allergic phenomena may cause it to thicken either generally or locally in streaks. The mucociliary clearance is a primary defense mechanism of the respiratory tract to protect against inhaled pollutants, allergens, and pathogens. The functional components of the mucociliary apparatus include the cilia and a protective mucus layer, which is secreted by goblet cells in the epithelium and mucus glands in the lamina propria. Mucus acts like a flypaper, trapping airborne particles inspired through the nose. The mucus is in two layers, a thin and watery sol layer, which bathes the cilia, allowing them to move easily, and the superficial, thick, and sticky gel layer responsible for trapping the inspired particles. Osteomeatal complex is the final common pathway of drainage for the frontal maxillary sinus and anterior ethmoidal cells to the middle meatus. Blockage of the osteomeatal complex prevents effective drainage, thus leading to stagnation of secretions and therefore leading to recurrent or chronic sinusitis. The osteomeatal complex comprises of the maxillary sinus ostium, the ethmoid, the infundibulum, anterior ethmoid cells, and the frontal recess. It is the anterior drainage pathway of the sinuses. The maxillary sinus ostium and the infundibulum serve as a predominant channel linking the maxillary sinus with the nasal cavity. Cilia acts in a coordinated fashion to move the gel layer and trap particles at the rate of about 6 millimeters per minute superiorly against gravity upward course along the walls towards the sinus ostium, as shown in the arrow. In the in the superior medial wall. Drainage to the ethmoidal infundibulum to reach the middle meatus, as shown here. Mucociliary flow is carried to the posterior nasopharynx and inferiorly to eustachian tube orifice. Three arteries supply blood to the maxillary sinus: the infraorbital artery, the posterior lateral nasal artery, and the posterior superior alveolar artery. The veins accompany the artery and drain into the anterior facial vein and then to pterygoid plexus of vein. The lymphatic drainage of the maxillary sinus is through the infraorbital foramen and or through the ostium and then to the submandibular and deep cervical lymph nodes. This is a diagram showing the course of right posterior superior alveolar artery, and you can see that during a sinus lift, the diameter of this artery is shown, and it could be as large as 3 millimeters. Coming to the innovation, Last in 1959 described the nerve supply to the maxillary sinus. There is derived from superior dental nerve, that is the anterior, middle, and posterior, and the greater palatal nerve. These are branches of the maxillary division of the trigeminal nerve. Their pathway are of surgical importance as there is a possibility of damage to any of these nerves while doing surgical procedures on the anterior or posterior walls of the antrum. The anterior superior dental nerve is given off from the infraorbital nerve about 15 millimeters from the infraorbital foramen and courses down the anterior wall of the sinus. The middle superior dental nerve is probably present in more than 50% of the cases, and when present, it arises from the lateral aspect of the infraorbital nerve. Harrison in 1971 described in his view that it may run on posterior lateral or anterolateral wall of the antrum. The posterior superior dental nerve, by the same author, writes that there are two main offshoots of importance. The superior branch tunnels the lateral wall of the antrum and runs at the level of malar tuberosity, where the larger inferior branch is below and courses parallel to transverse facial part of the anterior nerve. Bony septa. Inside the maxillary sinus, bony septa originating in the sinus floor are often found, called underwood septa. They may divide the back part of the sinus into multiple compartments known as posterior recesses. They may often occasionally reach from the base to the upper sinus wall, creating two sinuses. Estimates of the prevalence of such septa have been ranged from 16 to 58%. The formation of underwood septa may be linked to the fact that teeth are lost at different times. The edentulous areas may resolve in a manner that results in a difference in level between the two adjacent portions of the sinus floor. It is thought that a bony septum may form in the area between the two regressing areas in order to transfer masticatory loads optimally. After the complete loss of teeth, the septa sometimes gradually disappear. This is again a revision of the various surfaces and what all the important structures that lie around the maxillary sinus. As you can see, the orbit forms the roof of the maxillary sinus. The base is formed by the lateral wall of the nose where the terminates are present. The floor is formed by the alveolar process of the maxilla. This is the lateral wall of the maxilla, and you can see in this diagram the anterior maxillary wall, the nasal septum, and the posterior wall. Coming to the radiology associated with maxillary sinus, basically the radiographs advised to see maxillary sinus can be broadly classified as extraoral views and intraoral views. In extraoral views, the commonly advised radiographs are the occipitomental view, the lateral sinus, the submentovertex view, OPG and CT scan. Whereas in the intraoral radiograph category, we have the occlusal, lateral occlusion, and the periapical. So let us look at this video describing each X-ray.
Picture showing your occipitomental, also called as waters. See here, radio-opaque maxillary sinus on the right side, and the radio-lucent maxillary sinus on the left side. Radio-opacity indicates that there may be any pathology related to your right maxillary sinus. Either it may be presence of fluid or any pus or any presence of any solid mass. band of reddish color shows your maxillary sinus. Which is your yellow color is your maxillary first. As the sinus is situated above maxillary first. The lateral skull showing your maxillary sinus, which is present above your maxillary. CT scan is the actual view. The CT scan. Here you can see the presence of bilateral maxillary sinus, which is present. That is not present. Another CT scan. The coronal view. Here you can see both the orbits, both maxillary sinuses, not palate.
So just to reiterate what you have seen in the video. So the most commonly advised view is the Waters view or the sinus view. This view was first described by Waters and Waldron in 1915. So this is the positioning, this is how you position the patient. So any fluid present in the sinus can be easily viewed by this view, or any pathology, any polyp can be easily seen. The other view prescribed is called the lateral view. So this view is useful for seeing the posterior surface of the sinus. Segmental vertex view also gives you a good orientation of the maxillary sinuses. Now coming on to the clinical relevance in dentistry. So, maxillary sinusitis is defined as inflammation of the lining of the mucous membrane of a sinus and nose as a result of infection, allergy, structural or mechanical abnormalities. Maxillary sinusitis can, based on the duration, can be classified as acute, subacute, and chronic. The etiology can be varied, can be odontogenic or non-odontogenic in origin. And the basic workup is based on anterior rhinoscopic examination and endoscopic examination, which may reveal the origin of the purulent discharge. And these are the list of investigations carried out to come to a diagnosis about maxillary sinusitis. And based on whether the sinusitis is acute or of chronic type. So acute sinusitis is usually treated with medicines. So the role of medicinal treatment overshadows the surgical protocol in acute sinusitis. So medical treatment comprises of nasal douching, antibiotic or antifungal depending upon the culture, decongestants, corticosteroids, antihistaminics, antileukotrienes. And once the sinusitis either resolves with medicine, so that becomes the end of the treatment, or it will convert into chronic sinusitis or not respond to medicinal therapy. In that case, the surgical treatment becomes the choice of line of treatment. So under surgical treatment, we have the option of functional endoscopic sinus surgery. We have the option of intranasal enterostomy or the option of Cadwell look surgery to directly intervene and treat the sinus. So this is the basic protocol. So based on the sign and symptoms and the workup, the sinusitis would be either acute sinusitis or chronic sinusitis. So first we would try to treat that with medicine. So either it would resolve or it would not resolve. So if it does not resolve, we then proceed towards antral regime enterostomy. And if there is no resolution, then we will move towards surgical intervention. Okay. Another common topic which is commonly associated with maxillary sinus is oral antral communication and fistula. So the first account of oral antral communication was published by Highmore in 1651. So there is a subtle difference between oral antral communication and oral antral fistula. So oral antral communication is an open communication between the oral cavity and the maxillary sinus, whereas oral antral fistula is a communication between the oral cavity and the maxillary sinus lined by epithelium. So communication is a fresh perforation where there is a communication created between the oral cavity and the sinus. So there is no epithelialization of this communication. So then it is called as oral antral communication. Once it epithelizes, it is called a fistula. So basic etiology of oral antral communication and fistula are listed in this slide. This is a recent inclusion in the etiology of oral antral fistula and oral antral communication. So we have encountered and seen a lot of cases of oral antral fistula secondary to COVID. The patient develops mucormycosis, osteomyelitis, fungal osteomyelitis called by the causative organism being mucormycosis, which leads to breakdown of the maxilla and subsequently an oral antral fistula. So this is a recent case which has come to our college, and we have just started the workup, and we are preparing an obturator, and then we plan to surgically intervene for closure of this oral antral fistula and rehabilitation of the patient. So based on the physical sign and symptoms, it can be oral antral communication and fistula can be divided into a recently created one or an established one. So in a fresh oral antral communication, always remember 5 E's. That is, you would experience escape of fluids. There will be some amount of epistaxis. There would be escape of air. There would be enhanced column of air causing alteration in vocal resonance, and there would be excruciating pain. Whereas in case of established oral antral fistula, always remember the 5 P's as mnemonics. So there will be pain present, there will be a persistent purulent discharge, there would be a postnasal drip, there will be a possible sequelae of general systemic toxemia like fever, malaise, headaches, and there could be a popping out of an antral polyp seen from the site of fistula. So how do you confirm the presence of oral antral fistula or communication? If the fistula is large, it can be assessed from inspection. In case its patency is not obvious, then you can perform either you perform a nose blowing test, which comprises of you compress the nasal anterior nares followed by gentle blowing of the nose, and this causes a rise in intranasal pressure exhibited by whistling sound as air passes down the open passage. The other test you can do is a cotton wool or a mouth mirror test, where the escape of air bubbles, blood or pus may appear at the oral orifice, and if you place a cotton wool, you can see that there would be a deflection by the air stream. A word of caution, do not explore with probe. It is important that a suspected antral defect at the site of recent extraction should not be explored with an instrument. Such a maneuver could lead to breakdown of the blood clot and the seal and result in a fistula. So this is a normal sequelae of a communication, that interference of normal healing process of the communication channel by infection, dislodgement of clot. And then how do you manage oral antral communication or oral antral fistula? So cases when the oral antral communication is recent and formation on a fistula is not established. So ideally, immediate surgery repair to achieve primary closure and simultaneous antibiotic prophylaxis to prevent sinus infection is the goal what we are trying to achieve. So what we need to do is we immediately do a primary closure, which can either be done by slightly mobilizing the buccal and the palatal flaps, or if it is not possible, you can slightly reduce the height of the sockets buccally and palatally, so that you can transpose these flaps and achieve a primary closure. Additional procedures such as you can reduce the height of the alveolar bone, as I just said, and you may use relieving incisions to mobilize these flaps in case you are not able to achieve a primary closure. The supportive measures, once you have primarily closed the flap, you need to put the patient on antibiotics. You need to give patients nasal decongestants, because you want that there should be minimal symptoms developing in the sinus. So various nasal decongestants are available. You can advise patient steam inhalations. Also, you can put the patient on analgesics. So patient is put on antibiotics, analgesics, decongestants. Patient is advised not to create any negative pressure, which will cause the breakdown of the recently sutured flap and will recreate the fistula. So patient is instructed not to smoke or blow or do anything which will cause negative pressure generation. So if we can just quickly summarize how to manage an oral antral communication, which is, so if there is no tear in the sinus lining, then you do not disturb the clot. You do not probe. You just suture the socket and you put the patient on medication and it will heal. If the opening is a little wider, you might have to mobilize both the flaps or may reduce the height of the alveolar bone to be able to achieve a primary closure. Now, if there is a tear in the lining, you need to ascertain whether there is any foreign body which has been displaced into the sinus, or it is just a simple tear. So if it is just a simple tear, again, it is almost similar to this, that do not disturb the clot, do not probe, suture the socket. If the opening is wide, then you can mobilize flaps and then close, or even if required, you can just reduce the height of the buccal and the palatal bone, and then you'll be able to get a primary closure. However, if there is a foreign body dislodgement suspected, then you first try to retrieve the foreign body by conservative approach, going through the socket, or if you can just manage if there is a small root which has just displaced. So you try to retrieve it through the socket, though it looks easy, but it is not easy. In that process, most likely you're going to push the root inside the sinus. But it should be tried before going on to the go-to procedure, which is the Cadwell look approach to retrieve the foreign body. And once the foreign object is retrieved, we close the oral antral communication with the flaps, which I'll be talking in detail. So this the other situation could be that you are looking at delayed cases. So there is a treatment of this patient has reported after 24 hours. So when a period of 24 hours has elapsed, the soft tissue margins of the fistula often get infected. It is preferable to defer the surgical closure until gingival margins show sound healing, that is approximately 3 weeks. So if the patient is reporting with an oral antral communication after 24 hours, so instead of trying to follow the protocol, what we just discussed of fresh oral antral communication, we defer it for 3 weeks, and now we treat this case as a proper oral antral fistula case. And in the meanwhile, we put the patient on antibiotic, analgesic, decongestants, because we want the sinus to be disease free. So when you are treating a oral antral fistula case, you are treating two situations. One is you are making sure that the sinus is asymptomatic, and then you are creating that barrier which is now being created of there's a communication between the oral cavity and the maxillary sinus. So you need to create that barrier by using various flaps, which I'll be talking subsequently. But if you just close the flap and you do not address the sinus, and if the sinus is infected, then that sinus infection will eventually trickle through the flap, and you will have a breakdown of the flap, and the procedure what you have done will fail eventually. So a clear sinus is mandatory for attempting any closure of oral antral fistula. So till the time we are going to proceed with the closure. So these are the temporary measures you can take. You can either patch that cavity with a gauze soaked in whitehead varnish, or you can use a denture plate or an obturator sort of thing. So now we are going to discuss about a frank oral antral fistula. So in this, the patient when the patient presents to you, you need to diagnose the condition of the sinus along with the planning for closure of the orolanteal fistula. The sinus needs to be clear. So the drainage of the maxillary sinus is established to the fistula by enlarging it surgically, and the sinus should be gently irrigated daily with normal saline. This is done when there is infection in the sinus. So when the acute condition subsides, then the surgical repair is undertaken. So for the closure of orolanteal fistula, you have local flaps and distant flaps. Under local flaps, you have buccal flaps, you have palatal flaps, you have combination flaps. So I'll just take you through some of these flaps. And under distant flap, you have buccal flap of pad and tongue flap. So buccal advancement flap was advocated by Rahman. So what you do is you need to, whenever you're treating orolanteal fistula, you need to de-epithelize this. Otherwise, whatever flap you use to cover this area, this tract will not heal. So the first thing is, after giving local anesthesia and raising the flap, you need to de-epithelize this entire tract so that you can have a uneventful healing. Then you raise the flap and then you score the periosteum with your blade. So this is a mucoperiosteal flap, and once you pass a blade, you are just cutting the periosteum. You're not cutting through and through, so your mucosa is intact. So what this does is, once you cut the periosteum, it allows your flap to be stretched. So then, if you can see here, initially this was your flap margin. After giving a incision or scoring the periosteum, now your flap has stretched almost to the palatal aspect of the fistula. So this is the purpose of giving this periosteal release. You can see in this as well. So orolanteal fistula, you de-epithelize the tract, you raise the flap, you do a periosteal scoring, and then you can passively stretch it and do a primary closure. Again, the same thing. So that was buccal advancement flap. These are the examples of buccal transposition flap, where you raise a flap, you give a periosteal scoring underneath, and you transpose it. So this flap was raised from the mesial aspect of the second premolar, and it has been transposed, and we are trying to close the orolanteal fistula in the first molar region. Then you have the options of palatal flaps. So there are a few modifications in this. So you can directly mobilize it, or you can give a V cut. So this prevents the kinking. This is based on your greater palatine artery. So we raise a flap, and sometimes we so there are a lot of variations where you can just rotate the flap, you can de-epithelize and use part of the flap, or you can design it in a different form to close the fistula. So this is a palatal rotation flap. Then you have combination flaps, where you can use both buccal and palatal flaps. So you do a double layer closure. So this is an example of combination flaps. So either you tunnel it or you mobilize the flaps from both ends, and then this is a releasing incision so that you can mobilize the flap more buccally and do a primary closure. So this is also an option of closure of orolanteal fistula. In distant flap, the tongue flap is very vascular and is used for closure. The disadvantage being that patient has difficulty in the flap is attached in such a way that he is not able to move and eat. So they can be anteriorly based and posteriorly based flap. So this is the design of the flap, where an anteriorly based flap has been raised. In this is a posteriorly based flap. So these are different variations. So this This is ideal for closure of oral antral fistula in the anterior region. So when you raise the flap, it is easy to suture and repair an oral antral fistula in the anterior region. Whereas this is useful in repairing the posterior fistulas in the molar regions and in the palate region. So these are different types of tongue flaps with different indications, as you can see. The buccal pad of fat is also used for repair of oral antral fistula. So you know buccal pad of fat has 4 processes. So there's a lot of mobility for buccal pad of fat. So you give a buccal incision and then you give an incision through the periosteum, and then you dissect out the buccal pad of fat, and then it is mobilized, and then you do a double closure with the underscoring of the buccal slab which you have raised. So you have a layer of buccal pad of fat over which you have a buccal slab. So there are some of the ways you can mobilize buccal pad of fat and use it. Also, alloplastic materials such as gold foil, tantalum, methamethacrylate, collagen have been used to treat oral antral fistula. Postoperative care, antibiotic analgesis, nasal decongestant, restriction to soft diet, then all instructions which will lead to any negative pressure has to be properly instructed to the patient. Then after 7 to 10 days, suture removal and review. So oral antral fistula, in summary, if the opening is small, without any foreign body, you diagnose whether it has acute sinusitis involved with it, or the sinus is asymptomatic. If the sinus is in a stage of acute sinusitis, you treat the sinus first, make it asymptomatic, and then intervene. So then in that case, you will, if the sinus lining is not healthy, you will remove the lining by Cadwell look and closure of the fistula by various flaps we have discussed. If there are signs of chronic sinusitis, so then again Cadwell look to remove the sinus lining and closure of fistula by flaps. If there is a foreign body along with oroantral fistula, then we need to retrieve the foreign body by Cadwell look. So using the Cadwell look, we are not only going to remove the unhealthy sinus lining, but also retrieve the foreign body which is causing all the problems in the sinus. Coming to this Cadwell look procedure. Cadwell look procedure was first described by George Walter in 1893, and Henry Look also described the same technique in 1897, and hence it is jointly called as Cadwell look procedure. William Robertson in 1892 entered the antrum through a hole made by chisel, and John Hunter originally suggested opening through canine fossa. So what are the indications for doing a Cadwell look procedure? Removal of any foreign body, removal of cyst, any malignancy in the sinus, closure of oral antral fistula, and various other indications. So how do we go about performing the Cadwell look procedure? So we can use a semilunar shaped incision in the canine fossa. So this is the canine fossa. We can use a semilunar incision or a U-shaped incision or a horizontal incision, and even a mucoperiosteal flap can be raised. And once the flap is raised, a window is created, and bony window is placed in the canine fossa above and distant 3 to 4 millimeters to the apices of adjacent molar and premolar teeth. So we have to keep in mind that when we are creating a bony window, it is above the apices of the teeth involved, so that we do not damage their nerve and blood supply. Then we create an adequate window of at least 1.5 by 1.5 centimeter, and then we irrigate and inspect the sinus and retrieve the foreign body, or if we have to remove the lining, we remove the lining, and then we pack a gauze in the sinus which is impregnated with bacitracin, and deliver that pack through a nasoantral window which is created, and then close the oral syringe. So the important thing is, once we clear the sinus of the lining or the foreign body, and we pack it with a bacitracin ointment soaked ribbon gauze. We do not bring the gauze out through this incision where we are going to close, because that will create a track through which the infection can travel to and fro from the sinus into the oral cavity. So we do a nasal enterostomy where we create an opening in the nasal, through the lateral nasal wall, and we bring the gauze out through the nose. And after 48 hours, we just pull out this ribbon gauze and the entire gauze comes out. And the purpose of placing this gauze is to create hemostasis, because once we remove the sinus lining and the foreign body, there is a good amount of bleeding from the walls of the sinus because it is highly vascular. So we do not want a hematoma to form, which will again lead to breakdown of the sutures and the oral antral repair what we have done. So we place a gauze for 48 hours, bring the end of the gauze out through the lateral wall of the nose, and after 48 hours, we just gently remove the entire gauze and it comes out without any problem. Post-operative care: avoid nose blowing, sneezing, smoking, basically anything to do with negative pressure. We advise nasal decongestants, antibiotic analgesics. As said, the pack is removed after 48 hours and future removal after 7 to 10 days. So with that, I come to the conclusion of today's lecture on maxillary sinus and its clinical applications. I hope this lecture would benefit you all, and happy learning.
Thank you, sir. Your presentation is very useful for the first year postgraduates. So here are the few questions from the postgraduate students. So, sir?
Yeah, hi, hello. Yeah, I've been seeing the questions on the chat and I've been answering it there itself. So if there are any other questions also, you can put it on the chat and I'll keep answering and it will not disturb your schedule.
Okay, sir. Okay, sir. Thank you, sir.
Pleasure.
Sir, here is the certificate of appreciation from Team VISHNU ADHYAAN, sir.
Thank you so much. Thank you.
Thank you, sir. Now we will begin with the introduction of the next presenter. After the presentation, there will be a discussion regarding the topic. Dr. Shrutima ma'am is currently working as professor in the Department of Periodontics and Implantology at VISHNU Dental College, Bhimavaram. Ma'am received her bachelor's degree from SDM Dental College, Dharwad, and master's from Ragas Dental College, Chennai. Ma'am has 23 international and national publications, and currently ma'am is the reviewer for Indian Journal of Dental Research, Journal of ISP, and Journal of Dr. NTR UHS. Now ma'am is going to speak on the topic infection control and biomedical waste disposal. Now you can start the presentation, ma'am. Thank you.
Good day to all the delegates and participants of VISHNU ADHYAAN and warm greetings from VISHNU Dental College. Today I am here to discuss the most important and critical step in any medical and dental practice, that is infection control practices. So before going into the various infection control practices, to keep the patients and colleagues safe, we must understand the potential role of healthcare environment in disease transmission. So in healthcare environment, there are a diverse number of microorganisms. They are present in our bodies and also in the environment. So the presence of a microorganism in a body and on the healthcare environmental surfaces does not mean that it will cause an infection. Most of these microorganisms are harmless, but some can cause disease in susceptible hosts. So the survival and persistence of microorganisms in the environment depends on various factors, including the type of the surface, the presence of organic matter in the surface, and also the bioburden, that means the number of microorganisms that are present, and also on the temperature and humidity of the environment. Because several common healthcare associated pathogens are known to persist on environmental surfaces for weeks and months together, it is likely that surfaces play a role in disease transmission. So here we can see a picture which illustrates the chain of infection. So for any infection to spread, all the steps in the chain must occur. So from this we can understand that the key to stopping the spread of infection is to break at least one link in the chain. So this chain of infection can be broken by limiting the surface contamination by the microorganisms, adhering to good personal hygiene practices, use of barrier protection wherever sterilization is not possible, and using disposable products wherever necessary to prevent the spread of infection, and also by undertaking risk minimization techniques. So how this can be achieved in clinical care is by using standard operating procedures for prevention of infection. So there are various standard operating procedures which are available for all the infection prevention procedures which are listed here. So in this presentation we'll have a look at the following. So the first and the most important or the basic step in infection prevention practice is maintenance of hand hygiene. So hand hygiene is a general term that applies either to hand washing, hand rubbing using an alcohol based hand rub, or surgical hand antisepsis. Now hand hygiene is simple, but it is a very important procedure. Yet its importance is often overlooked even by healthcare workers. Nowadays, because of the prevailing COVID pandemic, all of us are aware and are following the strict protocols of hand hygiene. So let us have a look into the various practices and its importance. So timely and effective hand hygiene protects the patient, healthcare workers and healthcare environment from being contaminated by microorganisms. So this timely management and hand hygiene could be very helpful in preventing the spread of harmful microorganisms. Health Organization has recommended 5 moments for hand hygiene. That means during any dental care, there are 5 steps or 5 areas where you have to perform hand hygiene. It's not just before and after the procedure, but during all these 5 moments, you have to perform the hand hygiene. So the first moment is before touching a patient. The second moment is before a clean or aseptic procedure. And the third is after the healthcare worker comes in contact with blood or body fluids. The fourth is after touching a patient, and the fifth one is after touching the patient's surroundings. So when you come across the patient at any of these moments, you have to perform hand hygiene. So let us have a look at the hand washing. So the main purpose of routine hand washing with soap and water is to remove dirt and organic material and microorganisms from the hands. Now, soap assists the mechanical removal of debris, loose adherent microbes, and substances containing fats and oils that are often present on the soiled hands. Now, plain soaps have minimal antimicrobial activity, and mainly they act by the frictional forces which are generated while rubbing the hands. So, plain soap and water can remove loosely adherent transient flora. It is important to spend the correct amount of time on hand washing. Now, washing hands for 30 seconds has been shown to remove 10 times the amount of bacteria as washing them for 15 seconds. So, the entire hand washing procedure, if done correctly, it should take 40 to 60 seconds. Now, washing hands with soap and water rather than using an alcohol-based hand rub is recommended in few cases where the hands are visibly dirty or soiled, and after using the toilet, and when you are exposed to spore-forming microorganisms. So in all these conditions, it is mandatory to go for a hand wash rather than using an alcohol-based. Now in this picture, you can see that there are a few pictures which explain the step-by-step procedure of hand washing with soap and water, which all of us know and we practice regularly. So after following all the steps of hand washing, it is essential that we dry our hands. So it is advisable to use a paper towel or single-use cloth to pat the hands dry. Towels should not be used multiple times or by multiple individuals because shade towels quickly become contaminated. And warm air dryers for drying hands are not recommended in health facilities, as forced air can result in spread of pathogens through water droplets. So the second method of hand hygiene is the use of alcohol-based hand rub, which we commonly call as a sanitizer. So alcohol-based hand rub is the preferred choice for hand hygiene if hands are not visibly soiled, because these alcohol-based hand rubs are most effective in killing microorganisms than plain or antimicrobial soaps and water, and it has other major advantages. The alcohol in the alcohol-based hand rubs, they kill the microorganisms by denaturing the proteins. That means they dissolve the microbial components. And it also has persistent activity. That means it takes longer for microorganisms to repopulate the hands. The hand rub technique is similar to hand washing technique, and it should take a minimum of 20 to 30 seconds for hand rubbing. So the various steps in the hand rubbing technique includes application of the product into the cupped hand and then rubbing the hands together palm to palm as seen in the second picture, and back of each hand with interlaced fingers, palm to palm with interlaced fingers, rotating the hands in a cupped shape and rubbing the thumbs rotationally and rubbing the tips of the fingers and nail beds in each palm until the hands are completely dry. To reduce the risks of skin reactions caused by frequent use of soap and other skin damages like contact dermatitis, it is important to promote the use of good skincare practices that help to maintain the integrity of the skin. Now, it is always advisable to discourage the concurrent use of soap and alcohol-based hand rub simultaneously. So that means the same time you need not use the soap as well as alcohol-based hand rub, and promote the use of alcohol-based hand rubs to protect the skin integrity as and when possible. As frequent hand washing, you might have observed that your skin becomes dry and there is cracks which might form, which might lead to contact dermatitis. So instead, provide alternate hand hygiene products for healthcare workers who have confirmed allergies or adverse reactions to the standard products. Also, before performing hand hygiene, make sure that the cuticles, or the nails, the hands and forearms are free of major lesions like ulcers, abscesses and tumors, and also cuts on the hands. So if there are any major and cuts and abrasions which are present on the skin or the palms of uh, the hands should be covered with waterproof dressings. And if you have any active lesions, do not provide direct patient care or participate in surgery until the lesions heal. So till now we have discussed about hand hygiene and the use of personal protective equipment. Now we go into the most important step in prevention of infection or spread of infection is decontamination or environmental infection control. Now this decontamination includes the decontamination of instruments, the surfaces or tabletops, the dental unit water lines, the radiographic units, and also the laboratory equipment. The term decontamination, generally in most of the countries, including the United States, refers to only disinfection or sterilization. The cleaning step is excluded, whereas in United Kingdom and Europe, decontamination refers to entire process, as well as WHO recommends the use of term decontamination for all the steps in the procedure, including cleaning, disinfection, and sterilization. So henceforth in the following presentation, decontamination will include cleaning, disinfection or sterilization. Now the first step in the decontamination process is cleaning, which is required to remove the contamination by foreign materials such as dust or soil. Now cleaning removes the organic material such as blood, secretions, excretions and microorganisms to prepare a medical device for disinfection or sterilization. Now you cannot perform proper disinfection or sterilization of any item without first doing a thorough cleaning. So the second step is either disinfection or sterilization. So disinfection is the process of reducing the number of viable microorganisms and on a less harmful level, and it not inactivate the bacterial spores and viruses. Next, coming to sterilization, it is the most validated process used to render an object free from viable microorganisms, including viruses, bacterial spores, but it cannot inactivate the prions. So whether to go for disinfection or sterilization after cleaning is mainly based on the risk associated with the use of the instruments or the equipment. So to assess the risk of reusing a medical device, there are 4 factors which should be considered. The first thing is the type of the item or device, whether it is a critical, semi-critical or a non-critical instrument. Next is the type of microorganisms, whether they are bacteria, spores, viruses or prions. The third is the presence of microorganisms in number, that is the amount of microorganisms and their availability to cause the infection. And the last condition is the patient susceptibility, whether the type of procedure is invasive or non-invasive and whether it makes the patient susceptible to disease. So all of you know that there is something called as Podling's classification, which was developed in 1950s to help people decide which method of decontamination is appropriate for different types of reusable devices based on the potential risk of infection posed to a patient. So Spotling divided medical devices into 3 different risk categories, that is high risk or critical device instruments which usually penetrate the tissues. So it is advisable to use single use disposable equipment or instruments wherever necessary, or these have to be definitely sterilized. The intermediate risk or semi-critical instruments are those which touch the non-intact tissues or mucous membranes, which have to be sterilized preferably if they are heat stable instruments. Or you can go for high level disinfectants. And the third category is the use of is low risk or non-critical equipment or instruments, which only come in touch with the intact skin. So these non-critical equipment or instruments can be cleaned and low-level disinfection can be used for disinfection. Before going into the sterilization process, let us look at the decontamination life cycle. So as we see in this picture, the life cycle of decontamination uh, has various relevant features, with each step being as important as the next step. So this cycle represents each stage of decontamination process, beginning from the point of use or acquisition of the instruments to decontaminate, followed by storage of the instruments. So this cycle is continuous and demands a minimum standard at every step to ensure the safe reuse and handling of the medical devices. So the first step in the decontamination process is cleaning. So cleaning is the physical removal of foreign material, including dust, soil, and organic material such as blood, secretions, excretions, and various microorganisms. So organic material which is left on a surface or a medical device can protect the microorganisms or neutralize the action of disinfectants. So it is very much mandatory that you do the cleaning process perfectly. And the cleaning of the instruments should be done in the dirty areas only. And the clean areas, dirty areas and sterile areas should be separate. It is a common practice to pre-soak the instruments before cleaning, but it is important to note that do not use saline or hypochlorite solution as a soaking solution, as this will damage some of the medical devices. And soaking devices in 0.5% chlorine solution or any other disinfectant before cleaning is not recommended, or it is strongly discouraged, as it may damage or corrode the devices, and the disinfectant may be inactivated by blood and body fluids, which could then become a source of microbial contamination and biofilm formation. And transport of the contaminated soaked instruments in a chemical disinfectant to the decontamination area may pose a risk to the healthcare workers and result in inappropriate handling and accidental damage. And also soaking in a disinfectant could contribute to the microorganisms becoming resistant to the disinfectant. And soiled medical devices should be opened and kept moist. Just soaking them in plain water is equally effective in cleaning rather than using a disinfectant. So coming to the cleaning process per se. So there are five main elements or five main things which have to be considered for effective cleaning, which includes the mechanical action or scrubbing of the instruments, the chemical action, contact time, temperature, and the type of solvent water that is used. Combined, all these five elements will result in more effective cleaning of the instruments. Now, solvent water, the availability of good quality water is essential. So the water should be soft with low mineral and salt content. And water softening systems may be used to reduce the mineral content in the water. The water alone is not an effective cleanser. So a detergent that attracts and holds the organic matter is necessary for cleaning process. So you should make sure that you use a detergent that is recommended for use with medical devices. A normal regular home use detergent cannot be used for cleaning the instruments. Now heat or temperature is necessary, or it improves the detergent performance, but not at temperatures over 45 degrees centigrade. So make sure the temperature is not too high, or it renders the materials with proteins to coagulate. So always maintain a temperature which is lesser than 45 degrees centigrade. And the recommended contact time for detergent to interact with the various surfaces must be adhered. So follow the manufacturer's instructions and make sure that the detergent remains in contact with the instruments for a sufficient period of time. And most importantly, mechanical action is essential for cleaning. So this is best accomplished by using either soft nylon bristle brushes which do not damage the equipment surfaces, or use wiping, flushing, brushing and spraying actions for mechanical enhancement of the cleaning process. After thorough cleaning with an enzymatic detergent to break down the proteins and help dislodge the debris, the instrument should be rinsed with water. You need not soak them in hypochlorites or any other disinfectant solution as process of cleaning. So a few important points to remember during the cleaning process is never use disinfectants as they are corrosive and may destroy the medical device. And never use water over 45 degrees centigrade as it coagulates the proteins and makes the devices difficult to clean. And never use a hard or abrasive cleaning instrument or equipment. And do not scrub under running tap water because this produces aerosols. So moving on to the next steps of decontamination, that is inspection, assembly and packaging. So in the decontamination unit, there should be an area for inspection, assembly and packaging. So this area is used for inspection and function testing of the cleaned medical devices before assembly and packing for sterilization. Now the purpose of packaging medical devices is to allow penetration of sterilizing agent, whether it is steam or gas. And also it helps in maintaining the sterility of the contents of the pack from the sterilization process until they are used for the various techniques. Before assembly, it is important to inspect all the devices to ensure that all of them are present, they are visibly clean and functioning correctly. Be sure to inspect the integrity of the instruments or equipment for any issue that may hinder the medical device from functioning properly. And during assembly, you should make sure that all parts are present and they are correctly assembled. So moving on to the packaging of the instruments. Most of the times either a paper or cloth is used for packaging of the instruments. Newspaper and brown paper cannot be used. The paper should be strong enough so that it can bear the weight of the surgical tray and it allows penetration of steam without becoming saturated. And it should not lint or shed onto the device. It is preferable to use a single-use paper and the equipment, if you are doing a double wrapping, you can use cotton as an internal wrap. But there are some advantages and disadvantages of using cotton in packaging. So the main advantages are that cotton can be used as inner wrapper or dust cover and it is strong, easy to work with and can be reused. The disadvantage of using cotton is that it does not provide an adequate microbial barrier and it can release particles or lint. So the lint from cotton wraps can be introduced into the wounds when it penetrates the tray or the cassette and it contacts the instruments. And this can cause serious infections or foreign body reactions in the patient. So till now we have gone through the cleaning process of decontamination. Now let us have a look at the sterilization. So that steam sterilization is the best method of sterilization. So steam sterilization is best sterilizer for heat stable devices. So this steam sterilizer reaches temperatures about 100 degrees centigrade by increasing the pressure of the device above that of the normal temperature at sea level. And by removing the air from the chamber, that is by either gravity displacement or creating vacuum, the chamber gets pressurized and the pressure is retained for a sufficient period of time, which is called as holding time. So there are three things that have to be maintained. One is the temperature above 100 degrees centigrade, increase in the pressure by gravity displacement or vacuum, and holding the instruments or the pressure and temperature for sufficient period of time. Now, whether the device can be steam sterilized or not will depend on whether it has been cleaned before sterilization, whether the instruments are tolerant to heat, moisture and pressure, and the type of material that is used for wrapping. So other than steam sterilizers, there are something called as non-vacuum autoclaves. These non-vacuum autoclaves include both non-vacuum benchtop sterilizers and pressure cookers, both of which are not recommended. Pressure cookers, they do not remove the air, so uniform penetration cannot be achieved in the pressure cooker. This is especially true when items are wrapped. The limitations of using non-vacuum autoclaves are they lack a downward displacement which is usually present in a steam sterilizer, and they lack penetration, that means they are not suitable for solid items like scissors or any other surgical instruments. And once the instruments are now removed from the sterilizer, the instruments become non-sterile because they are not wrapped. And there is no drying cycle in the autoclave. So this makes the non-vacuum autoclaves not usable for medical. So steam sterilization, though we know that it is the most effective and advisable type of sterilization, it may not be possible always. So there are other low pressure sterilization methods which are available. So these low temperature alternatives require additional special handling for safe use. For example, sterilization with gaseous chemical methods like ethylene oxide should be carried out in chambers with automated cycles that provide safety for the user and guarantee sterilization. So these are the various low temperature sterilization methods which can be used as an alternative in case if there are no availability of steam. Dry heat sterilizer is a suitable option for sterilizing medical devices that may be damaged by steam. So it is suitable for use with glassware, metallic items, heat stable powders and non-aqueous liquids like Vaseline, kerosene and grease. Though hot air ovens are convenient, they are not suitable for most of the medical items, including aqueous fluids and materials which are made of plastic, rubber, and paper. One disadvantage of using hot air oven is that the decontamination cycle is very long, and preheating is essential prior to sterilization, similar to our microwave ovens. And post-sterilization cooling of the instruments is lengthy. So another disadvantage is that the dense loads often cause a problem, as the convection or conduction method used to heat the chamber does not allow proper penetration in tightly packed items, and there is lack of fan within the sterilizer which causes poor heat distribution. So items cannot be wrapped in a hot air oven. So there is a risk of fire, and also there is difficulty to keep the items sterile once they are removed from the hot. So to achieve effective sterilization or disinfection using various heat methods, we should understand the time and temperature relationships. And this time and temperature relationship should be maintained, and the process must be validated. Now, when you can see the table which shows the time and temperature relationship in the various sterilization process. And you can observe that using dry heat, there is maximum amount of temperature that is required for sterilization process. And you have to observe that this is the minimum temperature that is required, that is 160 to 180 degrees centigrade is the minimum amount temperature that is necessary for dry heat sterilization. And also while using boilers, this is the temperature, that is the 100 degrees is the temperature used in boilers when it is at atmospheric pressure. As the altitude raises, the temperature also should raise. So let us have a look at the various instruments or equipments or the dental instruments which come under the various risk categories. So the mainly surgical instruments and periodontal scalers fall under the critical instrument category. Whereas mouth mirrors, amalgam condensers and reusable impression trays, also hand pieces and digital sensors fall under semi-critical items. So special consideration should be taken while using dental handpieces and digital lasers. Always you should follow the manufacturer's instructions and then clean and heat sterilize the dental handpieces between the patients, which is routinely not followed. It is always advisable to heat sterilize the handpieces. Do not subject the handpieces to high level disinfection or just wiping with a low level disinfection. And for digital sensors, it is advisable to use a barrier protection followed by cleaning and heat sterilization or high level disinfection between the patients. The non-critical instruments or equipment in dental health facilities are mainly X-ray head or cone, space balls and blood pressure cuffs. Now these can be disinfected by using either barrier protection or low-level disinfection. Most of the times we go for single use or disposable devices, and these items are intended for use on one patient during a single procedure, and usually these are not heat tolerant and they cannot be reliably cleaned, so never process single use devices. So the examples of these single use devices are mainly syringe needles, prophylaxis cusps and plastic orthodontic brackets. So for all the decontamination procedures, it is necessary to validate the measurements. So now let us find out what needs to be measured and how often for each process. So for cleaning of the instrument, all the instruments should be validated or inspected by either visual inspection or cleaning test on a daily basis. For disinfection and chemical sterilization, it should be done on a daily basis or per load. And you should observe the time of exposure for a disinfectant for validation. For chemical sterilizers and steam sterilizers, validation should be done by either biological, chemical or physical indicators on a daily basis. Or per load, you can use a bovidic test kit to examine the or validate the sterilization process. When you're using hollow lumen instruments, it is advisable to go for a helix test to validate the sterilization process. Bovidic test can be used for air removal. If there are patches, it means that the steam has not penetrated the load uniformly. So sterilization is not fully achieved. And for biological testing, you can use Bacillus stereothermophilus in cases of steam and chemical vapor sterilization, and Bacillus subtilis for dry heat and ethylene oxide sterilization. After sterilization, the instruments have to be stored. Without good storage, that is protection from contamination, disinfection and sterilization of medical devices will not matter. So decontaminated medical devices should be stored in dry, clean and dust-free environment. with no water tapping points. And the room temperature should be 20 degrees centigrade. So store the devices away from direct sunlight and label them well. To allow air to circulate, we should never pile the devices on top of each other. And medical devices should not touch the ground, walls or ceiling and should not be placed on wooden shelves. During all this process of decontamination, the environmental controls should be checked. The air supplied in the central sterile supply department should be of medical quality. That means it should be free of bacteria, chemicals and spills. The quality of water should be integral to the cleaning process. The dirty area should be under negative pressure ventilation in relation to the clean areas. The clean areas usually should be under positive pressure ventilation. And the recommended relative humidity level is 40 to 50%. And you can use a thermal hygrometer facility which is more accurate for monitoring the environmental controls. So next, let us move on to the management of surface contamination. So managing the high-touch surfaces or the tabletops are those surfaces which cannot be sterilized. For example, the dental chair unit can be done by pre-cleaning and disinfecting the surfaces between patients and also by use of barriers. For environmental cleaning, either can use cleaning solutions or disinfectants. The cleaning solutions mainly they contain detergents that remove the dirt and debris from the surfaces. Detergents do not kill the pathogens but rather they assist in removing them from the surfaces. And disinfectants inactivate or kill the microorganisms on the surfaces that have been cleaned. They are not intended to be used as antiseptics. So there is a difference between disinfectants used to clean the surfaces and antiseptics. Now commonly used disinfectants are hypochlorites. So hypochlorites can easily be found in any low resource settings. If you are using hypochlorite, prepare a fresh solution every day using a standardized dilution protocol and keep the prepared solutions in a labeled container with a lid to protect the liquid from sunlight and debris and discard the remaining hypochlorite solution at the end of the day if you have not used it. And hydrogen peroxides can also be used as disinfectants. So here you can see that an image which is taken from an actual disinfectant. So before starting to use any disinfectant, you should read a few things which are present on the label of the disinfectant, which is mainly the indications for use. Here we can see that the indication for use of this disinfectant is for disinfection of hemodialysis equipment. And the other things which have to be considered are the active ingredients which are present in the disinfectant, the health warnings or precautions that have to be taken, the biological activity that the product claims, the manufacturing date of the disinfectant, the quantity of the disinfectant, and also the disinfection time or the contact time that is required for activation or killing of the microorganisms. Now next let us see about the management of different spills. Now usually we come across management of spills, either blood or body fluids which spill on the surfaces. So let's see how to manage these spills. For smaller spills, first thing is you have to wipe the area immediately with the paper towel or an absorbent cloth and then disinfect the area with 10,000 ppm, the highest concentration of the hypochlorite or bleach solution that is available, and dry the surface with disposable paper towels. After drying, discard the gloves and paper towels as infectious waste and then perform hand hygiene, preferably with soap and water because the risk is with the. Next is management of large spills. For example, in the operation theatre, if there is any cut in the vessel or there is any dropping of the blood on the floor which is of greater quantity, then how do you manage it? So the first thing that you have to do is block off the area so that the others do not step through it, and cover the area of the spill with disposable towels or cloth which is soaked in 10,000 ppm of hypochlorite and leave it for 3 to 5 minutes. And don't pour the solution directly onto the spill as it causes splashing and widening the area of contamination. Now pick up the soiled paper towels or cloths and discard them into the infectious waste bin. Clean the area with the detergent solution and then wipe the area with the lower concentration of hypochlorite, that is 1000 ppm of hypochlorite, to disinfect the area, and rinse the area with water as hypochlorite is corrosive, and then dry the surface with disposable paper towels. Next, perform hand hygiene as always. So whenever we are using a disinfectant, we should consider a few things like the purpose of using the disinfectant. That means the level of decontamination that is required depending on the type of microorganism you are intending to kill. So this table shows the type of disinfection that or decontamination that has to be done depending on the type of microorganism that you are aiming to kill. Coming to the different types of disinfectants, in this picture you can see that hypochlorites, hydrogen peroxide and glutaraldehyde have highest antimicrobial activity and they are effective against all the microorganisms. And so depending on the advantages and disadvantages of the solution, you have to select the type of disinfectant. To summarize, the use of hypochlorites at different concentrations for different indications. The highest concentration, that is 10,000 ppm, is used for blood spills, and the lowest concentration is used for disinfection or cleaning the instruments. So the next thing is to protect the laboratory personnel. The impressions, gypsum casts, fixed and removable prostheses, the wax rims and bite registration records, which are commonly done in the dental laboratory, should be appropriately disinfected before sending to the laboratory. So the dental prosthesis, impressions, orthodontic appliances and other prosthodontic materials should be thoroughly rinsed under gentle running water to remove the blood, saliva and debris. And then the disinfection can be done by short-term immersion of these materials in 0.5% to 1% sodium hypochlorite. So next, moving on to the very important part, which is more found to be a common cause for spread of infection, is injection safety and needle stick injuries. Now, many studies have shown that blood-borne pathogens, including the HIV virus, hepatitis B and C viruses, and other life-threatening bacterial infections, have spread due to unsafe injection practices. So reuse of may either directly via the contaminated injection equipment or indirectly via the contaminated medication vials expose the patients to infections. So to better understand the pathways of disease transmission due to unsafe injection practices, we'll go into detail about how a needle can become contaminated. So in this picture, we can observe that in the first picture, a new needle and syringe are used to draw the medication. So when the needle is used on a HCV, for example, a HCV infected patient, black flow from the injection contaminates the syringe. Now, changing the needle does not prevent contamination of the syringe. So when reused to obtain medication, the contaminated syringe can contaminate the complete medication vial or the LA vial. So if the contaminated vial is used for other patients, then the second person can become either a HCV or HBV or infected with any other blood-borne pathogen. Now this table shows the estimated risk of disease transmission using for various blood-borne pathogens. Now here we can see that the estimated risk of disease transmission for reused needles is greatest for hepatitis B. Though for HCV and HIV it looks less, that is 3% and 0.3%. But the damage that is caused due to this transmission is very high. So It is always advisable to avoid using syringes and follow the prevention protocols for transmission of disease. So for prevention of transmission risk, it is always to advise to go for appropriate sharp disposal, which mainly includes the immediate disposal of the syringes and uncapped needles into the sharps container, and never recap a needle. In case you have to recap a needle, always use one hand scoop technique to prevent any injury to the hands. So needle stick injuries can occur in your facilities in many ways. So certain situations increase the risk of injury to the healthcare workers. So what should be done in cases of a needle stick injury? The first thing is wash the wound with soap and water and immediately inform your supervisor. Now be sure to follow the needle stick injury reporting protocol for your health facility. And if possible, identify the source patient and test for HIV, hepatitis B and hepatitis C after providing counseling and obtaining informed consent from the patient. And if, though it is not recommended or not mandatory, you can go for immediate HIV, hepatitis B and hepatitis C testing. So in case of an exposure to hepatitis B, there are three factors which determine whether hepatitis B has been contacted. The first thing is the degree to which the person struck has come in contact with the blood, whether it is minimum or greater, and the amount of hepatitis B antigen which has the highest risk of infection. And the third is the hepatitis B surface antigen. If the surface antigen is present, the risk of infection is significantly lower. So post-exposure prophylaxis is not necessary for those vaccinated against hepatitis B virus. So if an injured healthcare worker has not been vaccinated, then the worker must receive an initial vaccination dose immediately after exposure. And all scheduled doses of the vaccination series should be completed even if the source of infection is hepatitis B negative. So the most effective post-exposure prophylaxis regimen for hepatitis B virus is a combination of hepatitis B immunoglobulin and vaccine series. So 2 doses of either hepatitis B immunoglobulin alone or hepatitis B vaccine alone are about 70 to 75% effective. So the next is exposure management for hepatitis C virus. So the chance of becoming infected following exposure to hepatitis C is very low. So that means the average seroconversion rate after a sharp injury exposure from a hepatitis B source is only about 1.8%. And one study suggests that transmission can occur only from hollow bone needles and not the regular needles. So while the risk of exposure of hepatitis C is low, the consequences of infection are high. So though there is no recommendation for post-exposure prophylaxis for HCV positive blood, there are no immunoglobulins and antiviral agents or vaccines against hepatitis C virus. So the patient, in case if the healthcare worker gets infected, he has to go for hepatitis C virus management. Exposure management of HIV virus mainly depends on the HIV status of the source. So if the HIV status of the source is positive, then a 2-drug regimen is recommended for any percutaneous injury or severe blood splash. And if the HIV status of the source is unknown, consider the HIV prevalence of the population, and based on that you can either give post-exposure prophylaxis or not give a PEP. And no post-exposure prophylaxis for HIV is recommended if the time of needle prick injury has passed 72 hours from the time of injection. And the exposed individual, if he is already HIV positive, then there is no requirement of PEP. And the source of the body fluid, if he is HIV negative also, there is no requirement for post-exposure. So let us move into the last aspect of infection prevention and management, which is the waste management. So healthcare waste is broadly divided into two main categories, hazardous and non-hazardous. About 85% of the generated healthcare waste is considered as non-hazardous waste, which is similar to domestic waste. So if waste is not segregated correctly, the hazardous waste can contaminate the non-hazardous waste. So this can make the collection, transport, treatment and disposal of the waste difficult and hazardous. So also treating non-hazardous waste as though it is hazardous results in wasted resources and efforts. Next is the sharps waste is used or unused sharp items that could cause cuts or puncture wounds that can lead to infection. Mainly this sharps waste include the instruments such as scalpels and blades, needles, syringes and broken glasses or ampoules. And then the pathological waste. It is from the human tissues or fluids or placenta, fetuses and unused blood products. And other infectious wastes are soiled gloves, gauze, bandages that are contaminated with blood, body fluids, viruses and parasites. Now, pharmaceutical waste is used, expired or no longer needed pharmaceutical products such as vaccines and drugs. And chemical waste includes chemical substances like disinfectants, solvents and waste with high heavy metal content which are disposed. Next is the genotoxic waste which is harmful to the human genes. And then the radioactive waste which is generated from the radioactive substances. So all these come under hazardous waste. And the second category is non-hazardous waste which can be uh, managed along with the general waste. So all of you must have seen in your healthcare facility this colored chart near the disposal area. So mainly it describes the segregation of waste. So the disposal of hazardous sharps waste such as syringes, scalpels, suture needles and glass should be done in a puncture resistant sharps container to prevent needle stick injury and cuts and punctures of the uh, operator or any person who is responsible for segregation. Now, hazardous non-sharps waste such as pathological and infectious waste should go in separate containers that use leak-proof and puncture-resistant bags, and they should be covered with a lid. So all these should be appropriately labeled with the biohazard symbol. And other hazardous waste like chemicals, pharmaceutical and radiographic waste should be packaged and labeled with the appropriate hazard symbol, and they should be discarded separately and not with the regular hazardous waste. So whenever we are handling with hazardous or infectious waste, always wear PPE. Now PPE should include the utility gloves, not the regular gloves or the nitrile gloves, a heavy duty apron, boots or closed toe shoes, eye protection or face mask, and remember to remove PPE and perform hand hygiene after handling the waste. So while general non-hazardous healthcare waste can be disposed of without treatment, hazardous waste should be treated prior to final disposal. So the healthcare facilities should conduct a risk assessment based on the type and quality of waste and access to the resources available, and choose the method that will pose the least risk to the community and the environment. Basically, there are two methods which include thermal methods and chemical methods. Now that we have gone through all the infection control practices starting from hand hygiene and personal care to biomedical waste management, there are two universal precautions that have to be followed for every patient. So the following this universal precautions should render everyone free from the disease, which are mainly treating every individual as if they are carrying a pathogenic microorganism, and handling every contaminated item as if it is carrying a bloodborne infections agent. So finally, to conclude, there were a few questions which were asked earlier in the paper one in various universities regarding infection prevention and control, which mainly includes the standard or universal safety precautions that have to be taken to prevent disease transmission, the post-exposure prophylaxis or management of various bloodborne pathogens, the method of sterilization and disinfection, and biomedical waste management. So I hope this presentation will be useful to answer your questions, and thank you once again for your patient listening.
Thank you, ma'am. Your presentation is useful for first year postgraduate students. Ma'am, we have few queries from the postgraduate students, ma'am. First question is, so what are the side effects of the excessive usage of the disinfectants?
So, always steam sterilization is the best method of sterilization. And wherever it is not possible to go for sterilization, you can go for disinfection. Like if you go for excessive use of disinfectants, it might lead to corrosion. And also repeated use of disinfectants might lead to resistance to microorganisms. So whenever it is possible for small instruments, it is always better to go for sterilization.
Thank you, ma'am. And the second question is it necessary to sanitize the hands with sterilium after short scrub?
So already I have discussed this in the presentation. Actually, nowadays we are very commonly using both hand washing and use of sterilium for hand hygiene, but it is not advisable to use both simultaneously. Either do hand washing or use a sanitizer. Because if you do repeatedly both the procedures, it will lead to contact dermatitis. Mostly because of the dryness which is caused on the hands, it might lead to lesions on the hands, and it might cause skin lesions and erosions. So avoid using both at the same time. Whenever the hands are soiled or there is visible dirt, you can go for hand washing. And if there is no visible dirt, you can go for use of sanitizer. But don't use both the things simultaneously.
Ma'am, another question is that most of the dental practices outside follow the boiling water sterilization. How far it is safe?
Use of boiling water is no more recommended by any of the organization, either WHO or CDC. It is always better to avoid boiling water sterilization. But in cases if you require or there is no facility for steam sterilization, then you can do boiling water sterilization, but the instruments have to be used immediately because these instruments are not packed in the boiling water sterilizer. So they don't remain sterile after you remove from the sterilizer. So if it is required for immediate use, you can use boiling water, even though it is not recommended by any organizations.
Thank you, ma'am. Here is the certificate of appreciation from the team VISHNU ADHYAAN, ma'am.
Thank you.
Now we will begin with the introduction of the next presenter. After that, after the presentation, we will have a discussion regarding that topic. Dr. P. Sandil Murugan sir is currently working as Associate Professor and as Consultant Cleft and Craniomaxillofacial Surgeon in Savita Dental College and Hospital. Sir finished his graduation from Ragas Dental College and post-graduation from the Savita Dental College. Sir has completed his fellowship in cleft lip, palate and craniofacial surgery from CCI Swiss and Meher. Sir is having around 10 years of experience in cleft surgeries and many publications to his credit, and presented papers and was also as a panelist, moderator, chairperson of the scientific sessions in many conferences. His fields of interest are cleft and craniofacial surgery, distraction osteogenesis, facial asymmetry, cosmetic and orthodontic surgeries, and TMJ disorders, head transplantation. Sir is now going to talk on the topic 5th and 7th cranial nerves and its applied aspects. Sir, now you can start the presentation. Thank you.
Yeah, good afternoon, one and all. I'm Dr. Senthil from Savita. So I'm going to talk about the facial nerve and trigeminal nerve and its applied aspects. So before going on to today's topic, I think the previous speakers has already explained about muscles of mastications and TMJ. With that, you will know, I think you would have some idea about the trigeminal nerve also and TMJ surgeries. So you will have some ideas about the facial nerve also. So with that introduction, I'm moving on to both facial nerve. We'll start with facial nerve first and then move on to trigeminal nerve. So before starting, I want to just say that what my professor used to say for my both UGs and PGs. They used to ask about us what are only the two nerves that we are going to concentrate as a maxillofacial surgeon or dental surgeon is. So at least you have to study the two nerves compulsorily rather than going through all the nerves. We have to study, but you have to concentrate or you have to just focus on only the two nerves that is at least facial nerve and trigeminal nerve, which as a maxillofacial surgeon or dental surgeon or any other branches of dentistry that we mostly frequently deal with. So you may think that you can ask about, we are also dealing with, as a maxillofacial surgeon, I may deal with orbital fractures also. So I may also encounter optic nerve or trochlear nerve or oculomotor nerve, or as an ancho surgeon, I may encounter hypoglossal nerve and spinal axillary nerve. So, but those are the things I want to say is that we rarely encounter. Okay. So, and those are the super specialties, onco surgeries and all. So commonly day-to-day practice and most of the trauma and other aspects, we will just encounter the facial nerve as well as the trigeminal nerve that we are going to deal today. So moving on to the topic. So I'm going to just give brief introduction because of embryology and the functional components, course and relationship, and mainly focus on to the branches and applied aspects. So I will just, due to shortage of the time, 45 minutes for the two nerves. So I will just run on to the simple procedures and focus mainly on the applied aspect. So coming on the small introduction of the facial nerve, it is a seventh cranial nerve and it is called as queen of the face. And it is also called as mixed nerve because it has both sensory and motor supply. So coming into the embryology, during the third week of this gestation, the facio-acoustic primordium gives rise to both 7th and 8th cranial nerve. And during the 4th week, it moves laterally and the cauda tympanic branch descends. Okay, then it moves laterally and terminates near the branch of the 5th cranial nerve, otherwise called as trigeminal nerve. So during the 5th week of intrauterine life, geniculate ganglion, nervous intermediates, and get petrosal nerve forms. In the 7th and 8th week, the second branchial arch gives rise to muscles of the facial expressions that you must be knowing well. And the 11th cranial, mostly the facial nerve has been arborized, and it has 10,000 neurons, out of which 7,000 are myelinated and 3,000 are somatosensory. So what are the functional components? So it has all the components: special visceral afferent, special visceral efferent, general visceral afferent, general visceral efferent, as well as the somatic afferent. So the special visceral or branchial efferent, the muscles of facial expressions and elevation of the higher bone are responsible for that. Coming into the nuclei of the facial nerve. So the motor nuclei or bronchiomotor nucleus gives rise to muscles of the upper part of the face and motor cortex of the both right and left sides. Whereas the lower part of the face receives fibers from the opposite cerebral hemisphere, where we can see with the lower motor neuron lesion causes the lower part of the face, the Bell's palsy or whatever we call it, is the lower part of the face. Is that I will move on to later when we are going into deeper discussions. So it has the superior salivated nucleus, which gives rise to, which is responsible for the parasympathetic systems, and the lacrimal nucleus and nucleus of the tractus salitoris. So this is the picture showing that it is mainly arises from the pons part of the brain, where the 7th and 8th cranial nerve exits and will. So coming on to the intracranial course, if you can see clearly, it is very close to the facial nerve, close to nervous intermedius and vestibular 8th cranial nerve along with the labyrinthine vessels. So what happens in this intracranial course? So it runs through the canal of the facial nerve. That is called the first part, which runs laterally. Then takes a sharp bend here. That is called a genome, which has the geniculate ganglia. And the second part runs downwards and backwards, okay, and through the promontory, okay, promontory, and it enters through the middle ear, mostly into the middle ear. Then the third part comes downwards and exits through the stylomastoid foramen and comes out as the extracranial course. So in the extracranial course, you can see directly the facial nerve comes out through the stylomastoid foramen and enters into the parotid and divides into the branches. Okay, that we can call it as the terminal branches. So before it comes out to the, it gives one more branch that is called as posterior auricular branch. Okay. So what are the branches in the intracranial course or intratemporal course? That is in the facial canal, I already told the greater petrosal nerve, nerve to stapedius and cauda tympani. Cauda tympani, I think it has the both relationship with the trigeminal nerve also, that we will move when we are discussing about the trigeminal nerve. So as a extratemporal course, after exit from the stylomastoid foramen, it gives, I told you, posterior auricular nerve to digastric stylohyoid. The terminal branches, it has, I told, 5 branches. So there are communicating branches of which has motor nerves of the 1, 2, 3 branchial arches. Coming into the ganglion, okay. So I told there is a geniculate ganglion, and this is the superior salivatory nucleus and nucleus of the tractus salitaris, and it has the sensory root. It goes into the internal acoustic meatus, which gives the greater petrosal nerve, geniculate ganglion. There it goes to the nerve to stapedius. Okay. So the greater petrosal nerve comes out through the lacrimal, responsible for the lacrimations and other things, and the cauda tympani, which joins with the lingual nerve of the trigeminal 5th cranial nerve and supplies the tongue. Okay, and submandibular. After exit from the stylomastoid granule, it gives the terminal branches, okay, cervicofacial and temporofacial branches, which again divided into temporal, zygomatic, buccal, marginal mandibular, and cervical. So this diagram clearly explains the distribution and the supplies of the facial nerve to the facial muscles. Okay. So in the sensory root and motor geniculate area supplies the auricular muscles, and stapedius, nerve to stapedius is coming here again, cauda tympani, again same diagram. Okay, so the frontal belly of the occipito frontalis, corrugator supercilii, orbicularis oculus are supplied by the temporal branches, zygomatic branch. Okay, and zygomaticus minor, major, and levators are supplied by the upper buccal branch. Okay, lower buccal branch supplies the buccinator and orbicularis oris muscle. Okay, the marginal mandibular muscle branch supplies the muscles of the lower lip and chin. Okay, then the cervical branch supplies the platysma. Posterior belly, there is a nerve to stylohyoid and posterior belly of digastric. And I already told there is a posterior auricular belly which supplies the occipital belly of the occipital frontalis. So these are the 5 to 7 anatomical variations of the terminal 5 branches where it decussates within the branches. Okay. So most of the decussations takes place between the upper and lower buccal branches. I already explained about the geniculate ganglion, submandibular ganglion, and pterygopalatal ganglion of the facial nerve. So the greater petrosal nerve, I told you, geniculate ganglion, which has greater petrosal nerve, and the pterygopalantal ganglion supplies along with the mandibular, yeah, the pterygopalatal ganglion is located on the first sensory ganglion, and the submandibular ganglion is tomographically related to the lingual nerves. Okay, submandibular lingual nerve. Okay, and the pterygopalantal ganglion is tomographically related to the maxillary nerve. That's what I want to say. So artery is mainly supplied by the cerebellar artery and middle meningeal artery and posterior auricular artery. The venous supply is from the same artery. No, I told the cerebellar artery, cerebellar vein, anterior, inferior cerebellar vein, middle meningeal vein, and posterior auricular vein. So how to examine clinically the muscles of the facial expressions? I think you will all read about the cranial nerve examinations in third BDS itself. Okay. So we have to observe for the wrinkles of the forehead. Okay. Then we have to all the expressions, anger, furious, smiling, whistling, blowing, clenching, grinding, grinning, all the expressions, whistling, we can ask the patient to do, and we can able to appreciate whether the muscles of facial expressions are completely functioning or properly functioning or not. So this is the patient with who has come with the facial palsy, where you can able to see his eyes are unable to close. Okay, he can able to close the left eye completely, whereas the right eye is not completely closed, and there is flattening or spasticity on the complete right side, where you can see the movement of the muscles of the buccinators and the perioral muscles on the lower part of the face. So if facial nerve is affected, what will happen? Okay, so if it is affected or got injured in the internal auditory meatus, okay, so there will be loss of lacrimation, loss of stapedial reflex, loss of taste of the anterior two tether of the tongue because of the there is lack of salivation, and paralysis of the muscles of the facial expression, because all the other greater petrosal nerve is responsible for the lacrimations. Okay, chorda tympani is responsible for the taste sensation and auditory to the tongue. Muscles of the facial expressions all are getting affected. So if the nerve is injured before the internal auditory meatus, all the 5 will be affected. Whereas if it gets below in this level, just above the branches of nerve to stapedius, only the second stapedial, taste, salivation, and muscles of facial expression will be affected. So what happens if it get affected in near just above the chorda tympani? So all these branches are getting spared, so it will not be affected. It will not get affected. That is, lacrimation will not get affected. Okay, and this thing, nerve to stapedius reflex will not get affected. But whereas if it get affected means only there will be lack of salivary secretions and paralysis of the muscles of the facial expressions. Okay, if it comes out from the stylomastoid problem, and if there is a injury in this level, okay, only the muscles of facial expressions are getting affected. So what is the problem with the facial? The main thing that will happen is facial palsy. Okay, so what is facial palsy? The lower motor nucleus of all the cranial nerves except trochlear nerve do not cross the midline. That this point you have to keep it in mind. Okay, so what happens in case of facial palsy? So the lesions of the lower motor neurons causes paralysis of all the facial muscles on the same side, whereas the upper motor, because of the I told you there is a get fibers from the opposite cerebral hemisphere that the first few slides you would have seen. So the upper motor neurons, if that it is getting affected, then there will be palsy of the lower part of the facial muscles only. So this is one of the landmark classifications for facial nerve grading or facial nerve So House Brackman grading, he grades from grade 1 is very mild weakness, whereas grade 2 there will be slight facial asymmetry with a minimal degree of synkinesis. In grade 3 there will be obvious facial asymmetry, but it will not cause disfigurement. Whereas in grade 4 and 5 there is this is obvious disfiguring facial asymmetry along with the motion of the eye, and whereas in case of the worst weakness or most affected case grade that we can grade as grade 6, there is where there will be complete absence of tone of the muscles, and there will be the complete absence of movement of the muscles of the facial expressions. So what we called it is a Bell's palsy. It is called as a unilateral seventh nerve weakness. Okay, what are the causes or etiological factors for Bell's palsy? Is any kind of chronic inflammations like a sarcoid or granulomatous disorders, leprosy, infections of the middle ear, otitis media, and herpes zoster, which we call it as a Ramsay-Hunt syndrome, and any neoplasm of the parotid, meningioma, or any hemangioma, or any Paget's disease, or where if there is any tumor location in the geniculate ganglion, middle cranial fossa, or any trauma, okay, trauma to the or lacerations of the face causing injury to the facial muscles, or surgery, that is TMJ surgeries, condyle fracture surgeries, and middle ear and mastectomy surgeries, parotid surgeries may cause the facial palsy. Okay, so that is unilateral. So in case of bilateral Bell's palsy, it is very rare. It is mostly common in Wilkinson's syndrome, myasthenia gravis, and myopathies also. So it is how to define Bell's palsy. It is a unilateral weakness of all the facial muscles of the face with sudden onset, and it is possibly associated with any viral prodromal syndromes. So what is the incidences? It is usually it increases. It affects mainly the older persons, but there is no significant site that male. We cannot say that whether the male or female are more affected. It is equally for them. It is equally affected. Recurrence rate is less than 7%, and right side is more affected when compared to the left side, and mainly common in diabetes and pregnant males. So what are the clinical features? We can say facial weakness, all branches of the nerve, both the upper and lower part of the face are affected, unilateral mainly, bilateral in less than 1%. So the degree is partial weakness in 30% of the patients and complete weakness in 70% of the patients. Whereas in stapedius dysfunction, that is hyperacusis, and lacrimations is minimally affected. Taste is, there is no clinical significant affection, that is that taste is affected, and the sensory loss is also minimal. So what are the signs? I already told: facial asymmetry, absence of wrinkles on the forehead, nasolabial folds, and eyebrow drop. Okay, and you cannot able to, okay, absence of able to close the eyes, okay, which may lead to redness or conjunctivitis, okay, drooping of the corner of the mouth, and uncontrolled tearing because the conjunctiva is open to environment. Okay, and you cannot able to keep easily tight, like whistling and blowing. Okay. If you ask the patient to blow like this, he will blow like this with the escape of air through the mouth. Like this, where there is affected side, we cannot able to take. And whistle also, if you ask to smile, he will smile like this. Like this. Okay. So how to treat? Mainly nowadays, it is sometimes because of the when some you may encounter that some of your neighbors or relatives suddenly came with mainly in the winter season, they may complain of sudden weakness of the facial face, and we may think that what happened, nothing is happened, but the patient is having some sort of facial nerve. Because I have experienced when I was doing or my internship or something like that, one of my relatives or neighbor had the same experience. He traveled in the late night, and the next day morning he came and complained of inability to close the eyes. I immediately think of how come he can have the facial nerve injury or facial palsy. Then I went and discussed with my staff and professor. Then he told, because of the winter season, if somebody is traveling at heavy cold conditions, some air may got blocked in the middle ear cavity, which may give the transient Bell's palsy. Okay, that is also one of the things that you have to keep it in mind. So we are for him. So he got just relieved with physiotherapy only. So physiotherapy will be the first and the foremost step in the management of the treatment of Bell's palsy. And medications we can give, steroid and antiviral drugs we can give, and eye closer, if it is not there, then we cannot be able to leave the eyes open, because it may lead to the dryness of the eye, conjunctivitis, and so what we have to do, we have to apply some cold gauze pack or tapping of the eye, and some lubrication fluids for the eye, okay, tearing solutions. And if there is severe permanent loss, then we can think of some surgical procedures, like placing some small cold plate for the corrections of doses of the eye. Whether it is usually placed between the superior tarsus, okay, just outer, upper eyelid and superior tarsus, so that because of the weight, he can able to close the upper eyelid correctly. But what are the problems with that? There is an incomplete closure and migration of the gold plate due to its weight. The body reacts because of the foreign body reaction. So what is the surgical management that we can do is, we can do the nerve anastomosis end-to-end anastomosis, or we can do anastomosis with graft, or crossover facial nerve graft from the opposite side, or sural nerve. Other thing what we can do is muscle transposition, masseter muscle transposition, temporalis transposition, digastric transposition, or free muscle transposition, like gracilis, pectoralis major, minor, and serratus, latissimus dorsi, etc. So what is the indications for masseter transposition is, mainly it is indicated in the paralysis of the upper lip and commissure. So what are the disadvantages is, it will not interfere with the seventh nerve, but it can be combined with other restoration of the seventh nerve functions. So This is the muscle nerve. So opposite side, if it is transposed, okay, then we can compromise or camouflage, okay, with the other affected side facial expressions. Okay, what are the disadvantages in this case is there is infection, bleeding, and masseter is difficult to expose intraorally. Okay, so what is the other options? That is nerve reanimations. That is reanimation with the crossover face nerve graft followed by neurovascular bundle transfer. Okay, so this is the crossover nerve graft and anastomosis with the facial artery, vein, and nerve. Okay, so these are the slings that taken from the forearm and inserted into the face, affected side of the face. Or we can do the commissuroplasty or Z-plasty to bring back the normal commissure. So the future will be the tissue engineering. So how to avoid this is the main applied aspect. Now I am coming into applied aspects. Okay, so what is the how to locate the facial nerve? There are 3 points. Tragal cartilage pointer. So from here the nerve lies 1 to 1.5 centimeter below the inferior tip of the tragal nerve pointer. Okay, and the incision of the posterior belly of the digastric muscle into the mastoid tip, and the junction of the cartilaginous and the bony external artery. This is where the nerve lies between 1 to 1.525 kilometers. So again, this diagram showing the tympanomastoid suture. From here, it is 6 to 8 millimeter where we can see the exit of the facial nerve. Okay, and 2.4 to 1.3 centimeters where we can see the bifurcation between the cervicofacial and temporofacial division. And from the external acoustic meatus and up to the zygomatic arch from 0.8 to 3.5 centimeters where we can see the temporal branch. So 5 layers. Mostly, if we are want to preserve the facial nerve, so we have to know the 5 layers. That is skin, subcutaneous tissues, mass, fascia, and facial nerve. So muscles of the facial expressions within the mass area. In the temporal region, the mass is represented by the superficial temporal fascia. This is this one. Okay, it lies, the facial nerve lies deep to the superficial temporal fascia. So if you are doing any surgery, mainly in case of a condyle fracture and temporomandibular joint fracture, so we have to be very careful because alkayat, Bromley incision, preauricular incision, submandibular incision, retromandibular incision while elevating. So we have to reflect completely the temporal, superficial temporal fascia, musculoaponeurotic system, so that the nerve moves along with the fascia rather than it is getting entrapped. Okay, so I told already. Okay, so preauricular approach. Okay, after preauricular approach, mainly in case of TMJ ankylosis surgery, where we will do both alkayat or modified alkayat or Popovich incision and preauricular or endoauricular incision. So we will be exposing the zygomatic arch, we will expose the contact segment. So while moving on to the zygomatic arch, just be careful, go subperiosteal dissection with mosquito or hemostat. Move along all the tissue and move the entire periosteum laterally. Okay, even the nerve traction in this region may cause temporary weakness. Okay, so you have to take the facial nerve temporal branch along with the mass layer or superficial temporal fascia. The same thing I don't know. So in case of marginal mandibular division, okay, so always mark the angle of the mandible. Okay, submandibular incision, sorry. Always mark the angle of the mandible, and it is better 2 centimeters from the angle down, so that both, this is the marginal mandibular branch. Okay, this is how it is prevented. So we have to identify the tail of the parotid. Okay, 2 centimeters below the angle of the mandible, it is always safe to protect the marginal mandibular nerve. Okay, in case of submandibular approach also, again, it is better to go 2 centimeters below the lower body of the mandible. Okay, so that all the marginal mandibular division is completely preserved. Retromandibular approach in case of condyle fracture, where we will be doing and we will be giving retromandibular incision, expose the parotid and blindly dissect into the parotid. So always while going that, we have to be very careful by doing blind dissection and preserving this thing, cervical and marginal mandibular branch of the facial nerve. So in case of the parotid, okay, so parotidectomy surgeries, parotid is divided into 2 parts. Okay, that has to be not completely excised as a whole parotid. Always remember that it has to be excised as a superficial parotidectomy and deep lobe parotidectomy. Okay, first we have to do superficial parotidectomy, wherein the superficial lobe of the parotid is removed. So for doing that, what we have to do is we have to identify the facial nerve, the main trunk of the facial nerve from here, or what we have to do is we have to identify any terminal branches, okay, and go behind. So if you identify the main trunk and go anteriorly, it is called as anterograde, or if you are identifying the terminal branches and go behind, means it is called as retrograde. Okay, so then the superficial lobe is completely dissected from the facial nerve and excised. Then facial nerve is completely protected with nerves, identifier or nerve stimulator, and then the deep lobe is excised. So with this, we can able to, I think you can able to come to the conclusion where and all the things that we have to be very careful, like in case of condyle fracture, like exposing the preauricular retromandibular incisions, and in case of TMJ ankylosis surgery, and in case of CA surgery, like wherein we will be doing damaging the marginal mandibular nerve. So coming into the next nerve is fifth cranial nerve, trigeminal nerve. Okay, in this we will just move on to the intracranial course. It exists from the foramen oval, foramen rotundum, and superior orbital fissure. It has 3 components: sensory and 2 nucleus. Sorry, it has 2 nucleus: sensory nucleus, motor nucleus, and 3 divisions: ophthalmic division V1, maxillary division V2, and mandibular division V3. So coming on to the small brief, I will just move on to due to time consistent. Ophthalmic or V1 is the smallest of the 3 branches of the trigeminal nerve. Okay, it has terminal branches called the lacrimal branches, lacrimal nerve, frontal nerve, and nasociliary nerve. This is the diagram showing all the nerve and its branches. So coming into the maxillary nerve, so it has 3 branches that gives through the middle cranial fossa, branches in the pterygopalatine fossa, and branches in the pterygopalatine ganglia. Okay, so these are the diagrams showing the branches, the pterygopalatine fossa, okay, zygomaticofacial foramen, and the pterygopalatine ganglion, and other things. So the main nerve that is we encounter regularly is a mandibular nerve. It has both divided and undivided branches. Sorry. And it has 2 divisions: anterior division and posterior division. Okay. I will give this presentations, and you can go in deep this diagram. You can able to understand the branches. So it comes from the foramen oval, okay, and from foramen oval, nervus spinosus, okay, goes through the foramen spinosum and supplies the dura. Okay, this is the undivided nerve, and it divides into anterior and posterior division. Okay, here you can see the long buccal nerve comes. Here the lingual nerve comes, and here the inferior alveolar nerve comes. Okay, inferior alveolar nerve from the mandibular foramen. Okay, and down it is the mylohyoid, nerve to mylohyoid. Now we can able to understand the trigeminal ophthalmic division V1, maxillary division, and mandibular division with this otic ganglion. Okay, this comes under these are the greater petrosal nerve. I told you long back. It has inferior ganglion. It supplies the tympanic membrane, and cauda tympani. I told it unites with the lingual nerve. Okay, cauda tympani comes from here. Okay, and unites with the lingual nerve and supplies the anterior to of the tongue. Okay, and submandibular ganglion. Okay, and submandibular gland. So where and all we will encounter the trigeminal nerve, or where and all we will encounter or damage the trigeminal nerve. Mainly the inferior alveolar nerve getting damaged during the third molar surgery, during local anesthetic injections, or any kind of orthodontic surgery, maxillofacial trauma, endodontic therapy, and dental implants. So incident of third molar injury to the inferior alveolar nerve is and lingual nerve ranges from 0.4 to 22%. So mainly results in general paresthesia. Okay. So this is the landmark article published in 1990 regarding the radiological prediction of the inferior nerve injury during third molar roots. Okay, he told that there is a darkening of the root. Okay, and a deflection of the roots, narrowing of the root, and bifid root. So again, I told the incident of lingual nerve also it ranges from 0.5 to 22%. Okay, so this is the diagram showing the close proximity of the lingual nerve to the third molar. This is the third molar region. So if you imagine how close it is, okay, so during third molar surgery, we have to be very careful or in elevating the lingual flap. Okay, that's why the lingual split technique itself is avoided due to damage to the lingual nerve. Okay, so even when you are doing suturing also, if you take a bite from buccal and too much deep into the lingual tissue, like this, you can able to damage. This is the third molar surgery where you can see you can able to see, see how close the lingual nerve it is. So from buccal flap to the lingual flap, you are going too deep. You can take a bite along the nerve, okay, which may results in paresthesia of the one side of the tongue. So after third molar surgery or infections, the patient will come after 2 days or 1 day next day saying that it's still I am having numbness of the tongue. So in that case, if you have to realize that if your sutures are very tight, just remove the sutures. Okay, within few days, the patients, if it is due to the suturing, then the paresthesia will be relieved. Okay. And sometimes if you are elevating, in case of third molar surgeries, if you are drilling too much, so we have to, while drilling, we have to completely avoid too much drilling on the lingual aspect, the lingual part of the crown. Okay, that has to be fractured through this thing, couplings only, not through and through burrs should not be used too much on the lingual side, which may when you have to be very careful in elevation. Too much pressure on the lingual plate can lead to damage or fracture of the lingual plate, which automatically damages the lingual nerve. So these are the 3 points that you have to be very careful in third molar surgery. So endodontist, if they are here, they may mainly injure due to the irrigating solutions like hydrogen peroxide, sodium hypochlorite, or pharmacrosol they use. Okay, or epicotomy they will use to do in the lower molars, they may danger. In case of dental implantations, if they place close to the place implants close, or they long implants without, now there are many softwares that we can avoid the inferior nerve damage. In olden days they used to, we may not have any proper x-rays that time, so only with IOPA we can able to see. Sometimes there may be injury if they place the implants very deeply like this. Okay, in case of maxillofacial trauma, because of the trauma itself, may, because of the fracture of the segments, itself may cause the mental nerve injury in case here. So the nerve get avulsed due to the fracture or due to iatrogenic injuries during open reduction and internal fixation. Okay, this is the nerve damaged by the fracture itself. Okay, sometimes we may place screws into the inferior lower nerve canal. Okay, so sometimes in the mental foramen, the nerve get damaged due to retraction of the instruments. So in case of OKC, where you use a carnage solution, no, too much of carnage solutions may completely cause necrosis of the inferior nerve, OKC of the mandible. After enucleation, okay, chemical cauterization with the carnage solutions, where we may encounter or damage or the necrosis of the inferior nerve. In case of pre-prosthetic surgeries, where in atrophic mandible, where we will encounter the complete inferior nerve and damage. Sometimes we may damage also during ridge augmentation. In those cases, we have to do nerve lateralization procedures. Okay, in case of orthodontic surgeries, the main nerve that is getting damaged is mainly due to the both inferior nerve and the lingual nerve in case of bilateral sagittal split osteotomy. So what we have to be very careful is after doing before elevation itself, so we have to identify the lingual nerve first, retract and protect it, then go up, okay, through the pterygomastoid sling. After dissection of the pterygomastoid, we have to identify the inferior nerve. Keep one periosteal retractor, okay, inside, and one periosteal retractor for the lingual nerve. Protect nicely, then do the osteotomy cut. Okay, after doing osteotomy cut also, so after the segment is osteotomy and split, okay, check for the inferior alveolar nerve on the proximal segment or the condyle segment. Okay, it should not be in the proximal segment, it should always lie within the dental segment, okay, or called as distal segment. So make sure that the nerve is not in the proximal segment, because this segment we may are getting advanced. Okay, that we have to be very careful. Okay, so it should always be in this. So if you are able to see the nerve, just mobilize with small periosteal elevator or Mitchell trimmer or Watt's incision, then push it into the dental segment. And here, mostly it is not visualized because the lingual nerve. So unless just to keep this word in mind, if you are not visualizing any nerve, then no problem in case of this. Only if you are visualizing, then see where it is, and if you want, you have to relocate it. That's it. Okay, this is that we may damage because of placing screws in the BSSO or lag screws or plates, which may damage you may do nice osteotomy cuts, no damage to the nerve. But while plating, if you are not careful enough, then we may just place a screw on the inferior nerve itself, which may again causes the paresthesia. But inferior nerve paresthesia, because being it is sensory, the patient may regenerate. Okay, but whereas the lingual nerve paresthesia, being it is a motor, so it may take time. Okay, sometimes the local anesthetic injections also give. So coming into the classifications, Sedan's classifications, that is neuropraxia due to traction injury, axonomatosis because the axons are getting damaged, complete neurotemesis is complete severing of the nerve into two bundles. So Sunderland classified into first degree, second degree, third degree, and fourth and fifth, according to the penetration of the wound from pericranium, perineurium, epineurium, and endoneurium, and through the axons. So how the get nerve repaired by himself? After injury, the cell body started swelling. Okay, the Schwann cells produce nerve growth factors. So the Schwann cells align into bands, and then axonal sprout, and then the nerve regenerate. Okay, whereas in non-surgical treatment, we may do, this is the protocol, okay, whether we have to do the immediate decompression, debridement, or we have to do re-anastomosis, okay, nerve to nerve anastomosis. So approximation we can do if it is inferior nerve less than 5 millimeters, lingual nerve can be approximated less than 10 millimeters, okay. Whereas in those cases we can do the nerve graft with a sural nerve, greater auricular nerve also we can be used. So this is the I told that diagram, proximal and distal segment of the lingual nerve, and whereas here the sural graft is placed in between. Whereas this is called as cooptation, that is the process of aligning both the proximal and distal nerve to premorbid, that is before pre-existing cross-sectional orientations. So neuroraphy is just the nerve anastomosis, that is epidural suturing, okay. If neuroraphy is not possible, then again I told we have to look into we have to take the help of nerve graft with the sural nerve and greater auricular nerve. So we can do the entubulation technique, okay, where the nerves are getting anastomosed with the sural nerve graft or greater auricular nerve graft. Another one applied aspect of trigeminal is trigeminal neuralgia, which is called as paroxysmal lancinating pain. Mostly it is unilateral, very rarely bilateral. It is, the etiology is mainly what they nowadays they call it as a vascular compression of the trigeminal root, okay, or any irritation of the trigeminal nerve root, okay. So what happens is there will be sudden lancinating pains, and there are aggravating factors like touching the face on that regions, then it will aggravate severe sharp lancinating pain will be there, okay. So there are trigger points in that. So from the history itself we can able to differentiate, because I have seen most of the patients who have come with the trigeminal neuralgia, but when we examine the dental conditions, most of them will not have the lower molar teeth at all. So we have to distinguish between the dental pain and the neurologic pain, okay. Mostly the trigeminal neuralgia patients will have typical character of the pain, that is lancinating pain, and the trigger points. If you touch itself, they will jerk, okay. So they will, you have to eliminate the history, okay, get the history that while they are washing the space or when they are shaving also, they used to say they will have pain, so that their face is grimning face. With that itself we can able to identify. And how to diagnose is, we can give diagnostic nerve plus, give if the patient is having some mental division, means take a plain nerve block, okay, give the nerve block, okay, in this region, so the patient will not have pain at all for short duration. Call the patient again and ask when he gets the pain back, okay. And we can treat the trigeminal neuralgia with both non-surgical and surgical. Non-surgical is with conventional drugs, okay, like carbamazepine, and nowadays gabapentin is also there. But the problem with the carbamazepine is the patient used to go for a deep sleep, okay. One of my patient daughter, okay, she came and told me that she took the tablet, and we are all keeping for waking her up, pouring water, knobbing the door for long duration. She is not at all responding. We all thought that she would have died, and suddenly after some time she is getting up, okay. So that is the one of the major drawback of carbamazepine. So tegretol, okay, we can start with the lower doses and slowly increase, or gabapentin also we can try. If it is not getting resolved, then we can do the surgical treatment with both intracranial and extracranial surgical surgeries. Like extracranial means we will do peripheral neurectomy, okay, or cryotherapy, okay, alcohol ablation, or radiofrequency ablation, or thermocoagulations, okay. Peripheral neurectomy may be with the mental nerve is the cause, means when we do mental neurectomy, or supraorbital infraorbital nerve is the cause, means we can just excise or completely remove the part of the infraorbital nerve, lingual nerve or inferior nerve. Okay. Whereas in case of intracranial course, that we have to able to clearly distinguish. So if it is due to intracranial course, then nothing will help except for this thing, Gasserian ganglion block, okay, or radio frequency thermocoagulations, okay, rhizotomy, and this thing, microvascular decompression of the trigeminal ganglion, okay, because it is what they used to call it as the mainly due to the anterior cerebellar artery pulsation. So what they will do is microvascular decompression. So microscopically, they used to place small strings-like structure between the vessel and the nerve, so that any emphysema or some aneurysm of the anterior cerebellar artery may cause the trigeminal neuralgia. So they will just decompress the trigeminal nerve from the artery or vessels with a Teflon sling or any other sling material, or we can give rhizotomies, Gasserian ganglion block, okay, or glycerol ablation or balloon decompression, or heating electrode radio frequency rhizotomy can be done, or microsurgical technique. Okay, so that is the thing that we have to be keeping in mind. From this, I think we can able to avoid in future by applying this applied aspect, mainly in case of trauma, OGS, okay, especially in BSS4, as well as we have to identify the facial nerve or prevent the damage to the facial nerve in case of when you are doing condyle fracture or TMJ surgeries, okay. And trigeminal neuralgia, we have to distinguish between the dental problem as or it's a neurologic problem. So in case of impactions, very careful not to damage the inferior nerve or lingual nerve by avoiding the too much drilling with the burr on the lingual aspect. Okay, just keep only the wall of bone crown, okay, on the lingual to be intact, just to fracture with movement of the couplets, and don't push too much pressure on the lingual plate to elevate the deep horizontal impactions, so that may fracture the lingual plate, which may cause the lingual damage. Apart from that, if the lingual plate is fractured, sometimes the root may go into the lingual pouch, which is very difficult to retrieve it. So we can avoid that. And while suturing also, don't take too much deep bite on the lingual aspect in case of the third molar surgeries. BSSO, I told, try to avoid, okay, try to look for, don't search for the nerve. If you are not able to see the nerve, then it is good, leave it, okay. Any traction injuries, it may be a transient one, so don't worry for that. In case of facial nerve or any condyle fracture, preauricular alcoiath or Popovich incision, when you are going for the dissections just above the zygomatic arch, don't cross the mid too much anterior of the zygomatic arch, okay. Just stop in the midpoint of the zygomatic arch, and whatever you do with dissection with the blunt instruments, no traction, no sharp instruments or periosteal elevator in those directions. Thank you so much. Thank you for the opportunity. I thank Vishnu Dental College and the organizing team for this opportunity. Thank you.
Thank you, sir. It is a very useful presentation for the first year post-graduation students. Here is the certificate of appreciation from the team, Vishnu Adhyaayan, sir.
Thank you. Thank you for the organizing team.
Thank you, sir.
Thank you, one and all.
Sir, your appreciation certificate, sir.
Yes. Thank you. Thank you so much.
Thank you, sir.
Thank you. Some doubts they asked. Yes, mostly the upper motor neuron has lesion as the most commonest prevalence. Okay, I think nerve regeneration techniques I have already explained from the beginning, using that Suranda graft also, mostly how to repair the lingual nerve also. I have shown with the diagrams and everything. And the role of steroids in peripheral nerve injury, actually during peripheral nerve injury, the nerve will go for dysfunction easily following any injury. So what happens because of lipid peroxidation, so the nerve will go for dysfunction easily. The steroids prevents that lipid peroxidation, thereby preventing or inhibiting the nerve dysfunction. Another way of how steroids are getting used in case of preventing nerve injury, not treating nerve injury, preventing nerve injury, thereby reducing the inflammation. As you all know, the role of steroids, the main role of steroids in reducing the injury. Thank you one and all for this opportunity. Have a wonderful day. Well organized.
Thank you, sir. Now we will have a short lunch break for a half an hour. And I request all the delegates to be logged in. We will have interesting lectures awaiting for us at 2 o'clock. Thank you.
morning to everyone. Vishnu Dental College and Hospital is in Bhimavaram, West Godavari district of Andhra Pradesh. Established as a teaching institute and service-oriented hospital in 2002, it renders the best quality oral health care to the population in and around the Godavari Delta. The students learn in small groups, enhancing their focus of attention and encouraging proactive participation using e-learning facilities. Well-equipped simulation labs expose the students to practical hand skill proficiency using simulation models and dental mannequins. A wide variety of multi-speciality, inpatient, outpatient, and emergency oral healthcare services are provided with stringent infection control protocols. A state-of-the-art comprehensive clinical setting facilitates multidisciplinary treatment approach under one roof. Students are exposed to world-class dental instruments, instrument tracking system, digital radiography, and many more. Dental Hospital has employed electronic dental record system for a centralized patient data management. Specialty-wise services rendered include oral medicine and radiology, equipped with digital radiography and the dental CT scan facility to obtain 3D radiographic images. This department also supports 30+ rural dental clinics through teledentistry facility. Oral and maxillofacial surgery section that has advanced surgical care facilities to perform a variety of minor and major oral surgical procedures. A well-equipped 20-bedded inpatient facility includes operation theaters, intensive care unit, and wards. Emergency services are also offered 24/7. Restorative dentistry and endodontics housed with dental operating microscopes for high-quality care, anticipating the best possible treatment outcomes. Orthodontics and maxillofacial orthopedics that provides various types of braces for the correction of irregularly placed teeth and also smile correction for all age groups. Department of Pediatric Dentistry provides wide range of dental treatments to children with special emphasis on prevention of oral diseases in a child-friendly ecosystem. It has the facility to treat children with special care needs and highly anxious children under sedation. Periodontology section takes care of tooth supporting structures with advanced surgical and non-surgical approaches. It also provides fine gum surgeries using lasers and surgical microscope. The Department of Prosthodontics rehabilitates patients' lost teeth and damaged facial parts using novel jaw tracking methods, electromyography, and tech scan to achieve promising reconstructive outcomes. Implantology section performs surgeries with various implant systems. This section also offers basic and advanced implantology training program for dental graduates. Oral and maxillofacial pathology section supports diagnosing wide array of oral and jaw diseases at cellular level to identify the root cause and treat them appropriately. The department has high-end equipment like the research microscope and the pentahead microscope to facilitate research and academic activities. The institution has a novel proprioceptive derivation clinic which fosters ergonomic principles among students to inculcate working in stress-free postures during early stages of their clinical training. The Central Dental Laboratory is well organized with unidirectional workflow design for fabrication of high-quality dental prostheses. The lab has CAD/CAM facility which includes the laboratory model scanner, 3D printer and a high-end Ivoclar PM7 for 5-axis milling. The institution runs a unique dental technology twinning program in collaboration with the University of Bolton, United Kingdom. The Central Library facility provides unrestricted access to national and international dental journals, books, reviews and magazines with e-borrowing option. A state-of-the-art 3-tier Central Sterile Supply Department CSSD facility is established for reprocessing and uninterrupted supply of sterile instruments to all the clinical areas. World-class instruments from Finland-based company LM Dental are a part of the centralized instrument repository. The RFID technology is used for instrument tracking. VDC employed high-capacity centralized suction system from Germany for efficient liquid biomedical waste disposal and aerosol control in the clinics. The medical center provides 24/7 medical support with a well-equipped clinical laboratory and pharmacy facilities. The outreach wing at VDC actively engages in conducting free community screening and treatment camps using mobile dental unit to reach remote, rural and tribal places. There are various program initiatives developed as per the oral health needs of the area, including free preventive dental treatments to the needy. The service orientation of Vishnu spreads beyond the boundaries to 8 districts of Andhra Pradesh and 1 district of Telangana, with 32 satellite clinics offering basic and expert consultations to the rural areas. In brief, Vishnu Dental College is an epitome of transformation in dental healthcare education and service provision towards realizing their vision, oral healthcare for all, on par with the global standards.
The biggest challenge for any educational institute is to equip the students with practical knowledge and skills effectively. Thus, institutes are particularly emphasizing on curriculum process characterized by approaches to teaching and learning which are both experiential and engaging. VISHNU Dental College, one of the leading dental institutes in India. The institution is making sustained efforts towards consolidation of these state-of-the-art infrastructural facilities for teaching and learning.
As you know, dentistry is both an art and a science, and that's where right from the beginning we were wondering how to bring in technology into dentistry.
We always believe in the motto, strive for excellence. In this process, we update ourselves to the current trends.
In this endeavor, we have partnered with Apple by introducing their iPads and their proprietary educational software in both classroom as well as at patient care.
VISHNU Dental College e-learning team has customized a system which promotes flipped class learning methodology for undergraduate students using their iPads. Students will come prepared with the basic concepts to the class. The professor will facilitate learning by conducting activities and instantly evaluate if the student's learning is adequate and competent.
The Apple iPads had really provided us a great platform for classroom activities. VISHNU Educational Resource for NEET aspirants, we call it as Varna in our VISHNU Dental College, is to provide coaching for the competitive examinations. In this system, we use iPads for conducting online examinations and retrieve the results instantly.
We are utilizing iTunes U, iBooks and other third-party applications from the iPads to gain access to the academic data in the form of lecture keynotes, PDF handouts, supporting videos, images, charts, etc. Apps like BoneBox, Dental Anatomy Mastery are providing us with a 3D or micro scan of all the teeth with a comprehensive explanation.
Although using technology in education is beneficial, it has its share of cons. To curtail any limitations, we have employed a mobile device management solution that monitors any irrelevant usage of the iPads. To facilitate the ease of instructing students, the teachers of VISHNU Dental College are being trained in Apple technology adaptation in a novel approach.
Now it's not just enough for the students to have an iPad, it's extremely important that all the faculty, the 100 faculty we have in our dental college also are on board.
When we are in the clinics, especially the comprehensive clinical setup, we use these iPads to secure the data digitally. And these iPads help us to record the data into our patient management system.
We are probably the only dental college in India which is running a chain of 25 hospitals in the rural parts of Andhra Pradesh, predominantly in the Godavari districts, and we have a plan to take it up to 100 hospitals throughout coastal Andhra Pradesh.
We conduct various community outreach programs in remote areas, and these iPads are very useful in collecting data instantaneously.
In case of difficulty in diagnosis, we connect to our remote management system that connects to our closest satellite clinic doctor.
When you have these number of hospitals, you generate a large volume of data. And one of the things we generate a lot is radiographs. And that's where again we use the iPads, we use the Apple iPads to actually transmit these radiographs through teledentistry to our main hospital. And one new project which is very close to our heart is using artificial intelligence and then analyzing all this data which we are generating from all these clinics to come out with a product which will enable a doctor, mostly in the rural areas and the remote areas, to actually look at those templates to actually diagnose an oral health problem.
I would like to thank Apple for providing all the resources
and support in our journey to provide oral health care for all.
Concur and Apple have supported us in taking a lead towards the digitization of our teaching and learning process.
I'm very happy to see our students and faculty all carrying iPads. They go to the classroom, they go to laboratories, they go to the satellite clinics, and we see a lot of efficiency in the system.
VISHNU Dental College and Hospital is in Bhimavaram, West Godavari district of Andhra Pradesh. Established as a teaching institute and service-oriented hospital in 2002, it renders the best quality oral health care to the population in and around the Godavari Delta. The students learn in small groups, enhancing their focus of attention and encouraging
Good afternoon, everyone. Dear participants, kindly log into the session. Thank you.
A very good afternoon, dear participants. Kindly start logging in because you have very interesting upcoming lectures. All the guest speakers are waiting. Kindly start logging in.
Good afternoon, everyone. We will begin the session with the introduction of the next presenter, Dr. Yoita Prabhanathan sir, obtained bachelor's degree and post-graduation in the subject of oral pathology and microbiology, and doctoral PhD 2022 from Annamalai University. His core interest is cancer, inflammation, and odontogenic tumor. He has presented more than 15 scientific presentations, delivered many guest lectures, and honored as scientific chairperson and judge in various state dental conference and national specialty conference. Sir has been awarded 5 times with Best Paper Award under Original Research category in international and national conferences, and was awarded as Young Oral Pathologist of the Year 2018. Sir was also awarded with Research Excellency Award in 2019 by Institute of Scholars. 2 times recognized as guide by ICMR for mentoring students under ICMR Short-Term Student Scholarship. Sir has more than 40 publications in international and national indexed journals and contributing as editor in various esteemed journals. Sir is going to talk on the topic inflammation, cellular and vascular events. Sir, now you can start the presentation. Thank you.
Good afternoon. Thank you for that nice introduction. Greetings from Vivekananda Dental College for Women. Before I start with my presentation, I would like to thank the management and the head of the Institute of VISHNU Dental College, Bhimavaram, and the entire organizing team of this pioneering event, VISHNU ADHYAAN 2022. My special thanks to my senior and my good friend, Professor Dr. Shweta Ramesh ma'am, for introducing me to this platform. And I believe this is the 3rd time in this last year I'm getting associated with this meritorious institution for like chairing the session or delivering a guest lecture. I'm very happy to be associated with your institute, and I feel humbled and honored to share this digital platform with so many elite stalwarts of our dental fraternity, and I'm so happy that I am sharing this platform with one of my teacher, my UG and PG teacher, Professor Dr. Veeravarmal ma'am. So, moving on to my presentation, the topic given to me is inflammation, vascular and cellular events. So 45 minutes won't be enough to complete entire inflammation, and I really appreciate the organizing team for bringing out the crispy topics where we can focus in exam point of view. So as we all know, this inflammation is a fundamental process which is a protective response which happens in our body 24/7 without our knowledge. So whether we want it or not, the inflammatory mechanism is going on inside our body to protect us. So many a times we wonder about this inflammatory mechanism, and if it is not regulated, it can be disastrous also. Even it can lead to death. And today my topic is only going to highlight the vascular and cellular events of inflammation, and to an extent I try to cover the phagocytosis part also. So coming to the definition Inflammation is a local response of vascular tissues to injury or harmful stimuli, such as those caused by pathogens, damaged cells, or irritants, that is marked by capillary dilatation, leukocytic infiltration, redness, heat, and pain, and that serves as a mechanism initiating the elimination of noxious agents and of damaged tissue. I am a slow learner, so I cannot understand if I see such a big uh, definitions. So I always simplify things for my and better understanding. So I try to put it or split it in 4 different parts. So where inflammation is happening, so it's a local response of a vascular tissue to injury or uh, harmful stimuli. So who are that harmful stimuli? They are pathogens, damaged cells, or any irritants, physical or chemical irritants. And the third part, what is happening there? So there is capillary dilatation, leukocytic infiltration, redness, heat, and pain. And why all these things are happening? Because they serve as a mechanism initiating the elimination of noxious agents and of damaged tissue. 4 W's: where, who, what, and why. And we all know inflammare means to set on fire. Coming to the brief introduction part, the history of inflammation is long and colorful, with descriptions of this process dating back to the ancient Egyptian and Greek culture. So the term like edema, which are still used to describe inflammation, were introduced by Hippocrates in the 5th century BC, where he told that the inflammation as an early component of healing process after tissue injury. So Celsus came out with the 4 signs of inflammation: rubor et tumor, cum calor et dolore. That means redness and swelling with heat and pain. Later, the 5th sign of inflammation was introduced, that is loss of function. And in 1793, the Scottish surgeon, he described this inflammation as a response, but not a disease. And in 1980, a Russian geologist, he identified the phagocytosis process. So what caused this etiology? Any microbes, allergens, drugs, genetic disorder or immunologic disorders, any injury, physical injury, thermal injury or chemical injury, or even sometimes necrosis due to ischemia or any physical and chemical injury also can lead to inflammation. Recently, in past decades, they came out, the researchers came out with a strong evidence that even stress, being overweight, vitamin deficiency, and even lack of sleep can cause inflammation. So exam going PGs, have a good sleep before exams. That means you should be well prepared before the exams, not during the time of exams. So what is this inflammation and what it involves? So it involves the response of the blood vessels and leukocytes, which helps in getting rid of the primary cause of insults. So the insult can be microbes or necrotic dead tissues. So what is happening in this inflammation? It is a body's response to deliver leukocytes and plasma proteins to the site of injury by remodeling vascular architecture, so the offending agents could be removed. So inflammation could be acute or chronic based on the duration of the response. So acute response, they are the acute inflammation or the rapid response responding within minutes last up to few hours to few days, whereas chronic inflammation comes into light when the acute inflammation is prolonged and the duration is days to months. So what are all the events happening in this inflammation? First thing, there is a vascular change, and there is a cellular change, and there is a chemotaxis and phagocytosis. So in vascular change, the blood flow increases and the fluid and the plasma proteins leak into the inflamed tissue. In cellular infiltration, leukocytes adhere to the vascular endothelium and migrate through the endothelium to gain access to the surrounding tissue. So in chemotaxis, this leukocytes will follow the chemical gradients to the site of insult and unleash the potent killing mechanism. And what is that killing mechanism? That is phagocytosis. Promotes pathogen elimination and inhibits the pathogen growth by specialized cell called as phagocytes, and it engulfs the pathogens and it kills with the help of free radicals. What are the three stages of inflammation? Acute, which is a swelling stage, and subacute, which is a regenerative stage, and finally chronic, where the scar tissue maturation and remodeling stage happens. So we have to keep in mind that 5 R's are happening in this inflammatory process. The first R is recognition. So any invaders or foreigner should be identified promptly. So in inflammatory mechanism, the first step is recognition of the injurious agent. So this happens with the help of the pattern recognition receptors. Second thing, recruitment of the inflammatory cells. So this inflammatory process should recruit the inflammatory cells to that site of interest for the inflammatory process. Thirdly, after recruiting the inflammatory cells, that inflammatory cells has to remove that injurious agent. And after that, this inflammatory process doesn't stop there. The inflammatory site has to be regulated. Otherwise, it will be a mess, or it could be sometimes disastrous also. So regulation or the control of the inflammatory response should happen. And finally, resolution or repair, the final mechanism. So the inflammatory process starts with the recognition of the injurious agent, and finally, after killing also, this continues till the repairing of that particular place. So what is the process happening here? So when there is an insult, so insult means any invasion, so it can be exogenous or endogenous. So if it is a cell damage, so the cell damage will release this DAMPs, that is DAMP associated molecular patterns, which in turn attracts the leukocyte, that is macrophages and dendritic cells, with the help of, as I already mentioned, so the pattern recognizing receptors present in the leukocytes, that is macrophage and dendritic cells, will be attracted towards the molecule DAMP, which is secreted by a damaged cell or dead cell. So this attachment will help in the secretion of pro-inflammatory cytokines. In case of microbes, so this microbes will secrete the molecule called as pathogen associated molecular pattern, which in turn again identified by the receptors of the leukocyte, After the attachment, the pro-inflammatory cytokines will be released, and along with that pro-inflammatory cytokines, lymphocyte activating cytokines also released. So this is the pictorial representation of DAMP and PAMPs. That is, if it is microbes, this microbes can be identified with the help of DNA, RNA, cell wall or flagella. So if it is a damaged cell, it can be identified by mitochondrial DNA release, which is seen in the plebs or the apoptotic bodies or damaged cell. Sorry, it should be a damaged cell, which is recognized by the TLR9, that is toll-like receptor 9, and FPR1 receptors, which in turn can take the neutrophils towards mitogen activated protein kinase pathway, which in turn helps in the release of the chemical mediators. So this mediators of inflammation can be derived in two ways. One is plasma derived, or else it can be cell derived. Even in cell derived, it can be preformed or it can be newly synthesized. How this preformed or already existed chemical mediators are secreted? So as we saw, this mast cell is a granulocyte. When this mast cell is stimulated, it consists of this granules inside. It gets degranulated and it secretes or releases the histamine, which in turn it activates the inflammation. In the case of non-granulocytes, you can able to see the receptors which we mentioned in the last slide, that is that TLR receptor, G protein receptor. They helps in the formation of the chemical mediators, which is cytokines. They not only produce cytokines, they also helps in the amplification of the inflammation. So if you see this picture, you can able to see there is a damaged cell is there, or in the other terms it can be microbes also. So this damaged cell can secrete the molecule called as DAMPs, which is recognized by the PRR, that is pattern recognition receptors, which is present in the dendritic cells and the macrophages, which secretes this cytokines or the inflammatory mediators. Likewise, the microbes will be recognized by the PAMPs. Again, the toll-like receptors, they identifies this PAMPs, and once they get identified, so they secrete inflammatory mediators. Not only inflammatory mediators, in case of microbes, they also secrete pro-inflammatory cytokines. So all this mediators, it goes towards the blood vessels. So this chemical mediators, they can be produced by the leukocytes, and there are certain chemical mediators which can be produced within the endothelium by this endothelial cells. So exam going PGs, you can note down this articles which has a very good information or simplified information, and many tabular column and pictorial representation is there, so you can use it for your exams, especially oral path, oral medicine and perio PGs. Definitely in previous year question papers you can encounter questions from inflammation. So before going into the details of this chemical mediators, let me start with this. What is this brief introduction on this chemical mediators? So as we all know about this chemical mediators. They can be vasoactive amines, they can be peptides or eicosanoids like leukotrienes and prostaglandins. These chemical mediators are short-lived. So once its work is done, they either decay or inhibited after the functions. So these are all the cell-derived chemical media, inflammatory mediators, and there are certain plasma-derived mediators like complement product, that is C3A, which is very commonly involved. So what is the role of this mediators? For example, if histamine, serotonin and leukotriene is secreted, it increases the vascular permeability. So it releases, there is a vascular permeability which causes the plasma leakage here. And as I already told, some of the endothelial cells also can produce this cytokines like tumor necrotizing factor alpha, which acts on the endothelial cells, which can secrete this interleukin 1. At the same time, this complement C3A and leukotriene can induce this mast cells or this uh, uh, macrophages, through which the histamines are released, and finally there is an endothelial gap. So to better understand about this chemical mediators, these two articles, they got a very good detail on this chemical mediators. So coming to this acute inflammation, two things are happening. One is vascular change and another one is cellular changes. So in vascular events, there will be an increase in the blood flow to bring down the cells and the protists to the site of injury, and by vasodilatation and increased vascular permeability. In cellular events, leukocytes are recruited to that area, and activation of leukocytes is happening there by this chemical mediators, and finally end up with this phagocytosis. So in vascular change, what is happening? 4 steps are happening. So temporary contraction of the microcirculation system followed by the immediate vasodilatation is happening. This temporary contraction and immediate vasodilatation, it makes the erythrocytes to migrate to the center of that vessel and leukocytes to the periphery of that vessel. Now the histamine induced contraction of this endothelium causes the appropriation of the cracks in the vessel wall, and you can able to see the plasma leakage. So when there is a plasma leakage is happening into the adjacent connective tissue, it can compress the nerve endings, which can cause the pain. That is why there is a pain in inflammation. So in vascular changes, 2 events are happening, that is changes in the vascular flow and caliber and increased vascular permeability. So when the chemical mediator like histamine is released, it initially helps in the vasodilatation of the arterioles. Once there is a vasodilatation, there is an increased blood flow, which results in the heat and the redness. So when there is the heat and redness, the further histamine secretion, as we saw already in that previous picture, it increases the vascular permeability, which results in the fluid into the plasma fluid escape into the extravascular space. So both this events, that is change in the vascular fluid flow and caliber and increased vascular permeability, together causes the slow blood flow and concentration of RBCs to the center and the neutrophils to the periphery, and it increases the viscosity and engorgement of the small vessels, which finally results in the stasis of this blood vessels, that is the slowdown process. To summarize, there is a degranulation of mast cell is happening, which in turn chemical mediators are released. Chemical mediators like histamines, prostaglandins, leukotrienes, and more pro-inflammatory cytokines, which causes vasodilatation, which again causes vascular permeability, and more amount of histamines and leukotrienes results in the retraction of endothelial cells. So there is a vascular permeability, at the same time there is a retraction of endothelial cells, which results in the plasma leak, that means exudate. So when the plasma leaks enters into the adjacent connective tissue, plasma enters into the adjacent connective tissue, that is called as plasma leak, and it is called as exudate. So this exudate inside the connective tissue causes edema, that is swelling. So they disturb the axial blood flow, and it increases the blood viscosity, and blood flow slows down. As we previously saw, it became stasis, and the concentration of RBCs will become goes towards the center, and the leukocyte at the periphery. So this process of the leukocytes getting into the periphery, it is called as marginization or margination. So in this picture, you can able to clearly see, so there is the vasodilatation and increased vascular permeability with the help of the histamines and other chemical mediator release. So once this happens, what happens in the blood, inside the blood vessels? So this RBCs are concentrated towards the center, and this leukocytes goes towards the periphery, and when the leukocytes goes towards the periphery, towards the endothelial cells, that is called as margination. So at the same time, you can able to see the leakage of the plasma fluids into the adjacent connective tissue, which is called as exudate. So this mechanism of increased vascular permeability can happen with 4 different processes. One is due to the contraction of endothelial cells, which again is due to the histamine release, or the direct damage to the endothelium or endothelial injury, or else endothelial injury due to leukocytes or transcytosis. So this is a beautiful histopathological picture where you can able to see the margination of the leukocytes here. You can able to see beautifully, and in center there is a red blood cells. So this margination is happening towards the endothelial cells, and you can able to see few cells which escapes into the connective tissues also. Now neutrophils, first they are the first to get recruited cells, and hours later monocytes goes to that site, and cytokines like interleukin 1 and tumor necrotizing factor alpha cause expression of adhesion molecules on the endothelium, that is selectins and leukocytes. So this leukocytes as silyl Lewis proteins, we can able to see here the silyl Lewis proteins, and these are all the selectins, and integrin selectins and immunoglobulins helps in the adherence and the rolling of this leukocytes. After the margination, it has to adhere with the endothelial cells, and it has to roll out. So mechanism of mediating leukocyte endothelial adhesion is redistribution of p-selectin, cytokine activation of endothelium, and increased binding of avidity of integrins. And endothelial neutrophil recognition is happened by initial adhesion via selectins and the activation of leukocyte by mediators, which is causing increased avidity of integrin, and later firm adhesion and transmigration, that is diapedesis via integrin ICAM1. So this interleukin 8 leukotrienes and complement system, it helps in the diapedesis, that is transmigration, coming out of the blood vessel into the adjacent connective tissue. So this happens with the help of chemokines. So after this diapedesis process, so this process is called as cellular events. So previously, till the exudate release into the adjacent connective tissue, it is vascular event. After that, this margination this adherence, rolling, diapedesis, that is transmigration, and chemotaxis, they are called as cellular events. So in chemotaxis, this released neutrophils, it goes towards the site of injury according to the concentration of the gradient. So this is the clear picture. You can able to see how the leukocytes with the help of silyl Lewis protein and the integrin comes and attaches with the selectin adherence molecule which is present in the endothelial cells, and after margination and adherence it keeps on rolling, and after that slowly there is a transmigration, that is diapedesis, and after this diapedesis it is attracted towards the site of injury with the help of chemokines. Now what is phagocytosis? Phagocytosis is an important process for nutrition in unicellular organism, while in multicellular organism it is found in specialized cell called as phagocytes. So this phagocytes can ingest microbial pathogens, but importantly also apoptotic cells. So what it does, it clears billions of cells that are turnover every day in our body. Thus, phagocytosis become essential not only for the microbial elimination, but also to maintain tissue homeostasis. Professional phagocytes are monocytes, macrophage, neutrophils, dendritic cells, even osteoclast and eosinophils. They are in charge of eliminating microorganisms and presenting them to the cells of the adaptive immune response. But fibroblast epithelial cells and endothelial cells can also perform phagocytosis. These non-professional phagocytes can ingest microorganisms but are important in eliminating apoptotic bodies. So this phagocytes initially it gets attached with the receptors like mannose and scavengers, helps in binding and engulfment, and in case of microbes, opsonine receptors where bind to opsonine coating microbes. This happens with the help of immunoglobulin G and complement 3B. After that, the attachment of the dead cells or microbes with the receptor. So this plasma membrane throws the pseudopods around its target. So it forms a phagosome here. So after that, the lysosomes comes in contact with the phagosomes. Finally, they result as phagolysosomes. So inside this phagolysosomes only, this killing event happens. After that, it is released with as a soluble debris. So when the killing is happening, that results in free radicals. So free radicals is also one of the important short notes we can frequently encounter in our exams. So what are free radicals? So elimination of microbes are accomplished by the chemicals called as free radicals, reactive oxygen species ROS and reactive nitrogen species, that is RNS. So that is when reactive oxygen species, what happens here? The reduction of oxygen is happening here. So NADPH, when it translocates from the cytoplasm to the phagosomes membrane, it reduces the oxygen to superoxide anion, which in turn it becomes the hydrogen peroxide, and later it can be converted into hypochlorite. So when this hydrogen peroxide combines with myeloperoxidase, it becomes hypochlorite, and this hydroxyl radicals, both together, hypochlorite and hydroxyl radicals, they helps in the elimination of microbes. Similarly, this reactive nitrogen species, it combines with the superoxide. This nitrous oxide combines with the superoxide with the help of arginine, and it forms peroxynitrate, which in turn this also helps in the elimination of microbes. So this process is called as this free radicals. So these free radicals are the class of components characterized by high reactivity due to unpaired electrons in their molecules and are generated in a variety of chemical and biological systems, including the human body. The oxygen free radicals, more usually known as ROS, that is reactive oxygen species, along with the reactive nitrogen species, are well known for playing a twofold role as both lethal and valuable species. According to the free radical theory of aging, age-related impairment is caused by oxygen-derived free radicals through oxidative damage to biomolecules, with mitochondria being the main target of free radical attack. So that is why when there is more inflammation is there, there will be a more production of free radicals. So what happens, this free radicals, it damages the organ or the tissue where it is present. It is now well known that the activity of the immune system in general declines with age, with the most prominent alteration in the cell-mediated immunity, especially in the T lymphocyte functions with decreased proliferation. So what are all the internal sources of free radicals? So one among the internal sources, inflammation. So these are all the list of internal and external source of free radicals, which causes the oxidative stress on the cell or on the tissue or the organ, which causes the damage to that particular organ. So that is why we have to take more antioxidant in a natural way. So what this antioxidant does, it neutralizes the free radicals by giving up some of their own electrons. It making this sacrifice, they can act as a neutral off switch for the free radicals. So these are all the articles where you can get a very good points on phagocytosis, free radicals and antioxidants. To put everything in a nutshell, like after the neutrophils is targeted towards the site of injury, so this neutrophils, this phagocytes that insult that area insult, and it releases the soluble proteins. Similarly, longer duration, which attracts the leukocytes and help with opsonization. It kills the microbes or it punches the microbes, and later this happens with the help of this dendritic cells, T lymphocytes, and when this inflammation is considered, so inflammation and immunity should be studied together for better understanding. So after this inflammatory phagocytosis mechanism, this regulatory mechanism, as I already mentioned, there should be repair process should happen. So the wound closure will be done by the platelets and the clotting factor. So this tissue repair is happen with the help of neoangiogenesis. They will be temporary, and later, so this newly formed blood vessels, once its work is done, it get a reduction, and if the wound is too large enough, there will be a non-functional fibrous scar will be formed during the tissue repair. So I hope I have covered a little on this vascular and cellular events which is taking place in this inflammation, and I just highlighted the phagocytosis events, formation of free radicals, and to an extent the antioxidant. So if I have seen further than others, it is by standing upon
Thank you, sir. It is very useful presentation to all the first year postgraduates. Sir, we are having few queries from the postgraduate students, sir. Sir, can you hear?
Yeah, I can hear you, ma'am.
Sir, the question is, so how inflammation in immunocompromised patients is different from the normal patients, sir?
So that's what I already mentioned. This immunity and inflammation should go hand in hand. Not only we should read together, but this inflammation and immunity should go hand in hand. So normally in immunocompromised patient, so we'll always treat it with anti-inflammatory, that it is immunosuppressant. At that situation already, there won't be an adaptive immune response. So already there will be a compromised immunity response. In last few slides, I have correlated how the adaptive immunity and the inflammation comes together. So that is where I always say that this both always goes together. So definitely there will be a difference between the normal inflammatory process and with the immunocompromised patient.
Thank you, sir. Sir, here is the certificate of appreciation from team Vishnu Adhyaan.
Thank you very much. Thank you, organizers, for this wonderful opportunity. And I learned a lot while preparing for this session. And I wish all the postgraduate and happy learning in upcoming days also. Thank you.
Thank you, sir. Now we will begin with the next introduction of the next presenter. Dr. Soumya Verma, sir, graduated from CSS University, Meerut, post-graduation from JSS University. Sir is working as a professor in Department of Oral Medicine and Radiology, Hazirabad College of Dental Sciences and Hospital, Jharkhand, and also shouldering additional responsibilities as member secretary in DHR, Government of India Registered Ethics Committee and NAC coordinator. Presently working as an assistant editor for Journal of Indian Academy of Oral Medicine and Radiology. Till date, more than 10 Best Faculty Paper Awards to his credit and more than 20 national and international publications, including books. Sir is going to talk on the topic pain physiology and its applied aspects. Now you can start the presentation, sir. Thank you.
Good afternoon, dear students. I wish you a very warm good afternoon. I know that since morning you're having continuous lectures, and now at the V end of the afternoon, you might be a little tired, but bear with me and with us for another 1 or 2 hours. And I hope the following lecture on pain physiology and its applied aspects will be beneficial for you. So I am Dr. Soumya Verma, Professor, Department of Foreign Medicine and Radiology, Hazaribagh College of Dental Sciences and Hospital, Jharkhand. I'll be starting with my lecture today. So on pain physiology, first of all, before starting, we need to know the definition of pain. So pain, as it is written, is an unpleasant sensory and emotional experience associated with actual or potential tissue damage or described in terms of such damage. Now, before going into the other aspects of pain, let's have some knowledge about the taxonomy of pain. So first of all, we read about allodynia. Allodynia is nothing but pain due to stimulus that does not normally produce pain. That is allodynia. And next is hyperalgesia, increased response to a stimulus that is usually painful. The next is hypoalgesia, pain response to a normally painful stimulus is diminished. Then neuralgia, we know, all of us know very well, it is pain in the distribution of the nerve. And neuropathy is pathologic change in a nerve. Now, what is paresthesia? It is abnormal but not unpleasant sensation. It could be either spontaneous or evoked. And dysesthesia, it is an unpleasant abnormal sensation. Now, what is hyperesthesia? It is increased sensitivity to stimulation. Hypoesthesia is diametrically opposite to hyperesthesia, that is decreased sensitivity to stimulation. So proceeding forward, now on your screens, my dear students, you can see the figure of a primary sensory nerve. Okay, so here we can make out very clearly, this is the epineurium. It surrounds the whole nerve. Now, in the epineurium, we have the nerve fasciculi, small nerve fasciculi, which are surrounded by the perineurium. And in the perineurium, we have the neurons, which are separated by the endoneurium. Now, moving on to the next slide, this is a figure showing a solitary neuron. Now, as you can see very well, this is at the top left-hand corner. You see the cell body, also called the carrion of the nerve, which has got the nucleus in the center. And you have various protoplasmic processes, also called the dendrites. And another single cytoplasmic process which arises from it, it is called the axon, which is covered by the myelin sheath here. Okay, myelin sheath. And finally, it ends into axon terminals. Okay, so this is the structure of a nerve. Now, proceeding forward, we should first have some idea about the types of neurons. How many neurons are there? So you have an afferent neuron. So what is the function of afferent neuron? Afferent neuron relays impulses from the periphery to the central nervous system. Let me give you an example. It relays impulses, howsoever impulses they may be, like touch, pain, pressure, temperature, okay, cold, okay, heat, from the skin to the central nervous system. And now what is efferent neuron? Efferent neuron is those neurons which transmit impulses from the central nervous system to the peripheral tissues. Okay, that is efferent neuron. Okay, now there are another type of neurons. They are called the interneurons. Okay, now the interneurons they don't relay any information. They lie totally within the CNS. No part of them is outside the central nervous system. Okay. So now you can see first sensory neuron is called the primary or the first order neuron, and it lies outside the central nervous system. Okay. And what is the first sensory neuron? We'll see in the next diagram there. Then the second and the third order sensory neurons, they are the interneurons, and they lie entirely within the central nervous system. Now, why am I telling you all this is that until unless we don't know how many different types of neurons are there, what is the meaning of first sensory neuron, primary or first order neuron, what is the meaning of second and third order sensory neuron, we would not be able to understand the next part of the lecture, which would be excuse me, utilizing these terms very frequently. Now, the next figure which you see in front of you all is a figure of the skin with the epidermis and all. So you see the free nerve endings, okay, arising from here, and you see a lot of other receptors, the Merkel endings, the mucinous corpuscles, the Ruffini's corpuscles, the cross corpuscles, and cross corpuscles are receptors for cold. The Pacinier corpuscles and the Merkels, they are for pressure and temperature and so on and so forth. So this is a diagrammatic representation of that. Moving on. On the screen, we have what looks like a very absurd diagram, but don't be fooled by it. This diagram is of a homunculus, okay, homunculus with 45% of the sensory cortex dedicated to the face, mouth, and throat. Okay, so if we start thinking in terms of the importance, the importance of face, mouth, and throat in the normal person's life, if any kind of pain, any kind of discomfort a normal person has, in the normal day-to-day life, 45% of the brain would be challenged because of that, challenged, and the person won't be able to carry out the daily activities comfortably. So we oral physicians should be proud of the fact that we have the opportunity to address pain of persons and alleviate it, and make their life easier. So moving on from there, first we'll discuss some general characteristics of pain. So what are pain receptors? Okay, so they are free nerve endings, also called nociceptors. Nociception is nothing but tissue damage. Nociception is nothing but tissue damage and trying to prevent tissue damage. So nociceptors are those receptors which detect or tissue damage. That is nociceptors, pain receptors basically. Now coming on to the types of pain, how many types of pain are there? Basically the two types of pain. One is slow pain and the other is fast pain. Okay, so pain can be say felt 1 second or after 1 second of the stimulation of the receptors, and fast pain is very fast, lightning fast, 0.1 second. You just prick somebody and then he would feel that you've pricked him, she would feel that you've pricked her. So very fast, the conduction of impulse is very fast. And now also I would like to add that the slow pain is conducted by the C fibers, pain fibers by the name of C fibers, and the fast pain is conducted by the A delta fibers. Now coming on to the pain receptor stimuli, a lot of stimuli can stimulate these nociceptors, mainly the mechanical, the thermal, and the chemical. So proceeding on, we'll study about the neurophysiology of pain, the neural pain pathway per se. So how many pathways are there? How many steps are there in pain transmission? So there are 5 steps in all. One is transduction, one is conduction, one is transmission, one is modulation, and the other one is perception. So what is transduction? We got to understand what is transduction. Transduction is nothing but the process of activation of primary afferent nociceptive fibers by stimulation from intense thermal, mechanical, and chemical impulses. What does it mean? It means that, as the figure which I showed you, say for example, on the skin, you're keeping something hard, okay? Something hard you're keeping in the skin. So they're afferent nociceptive fibers on the skin, and you're stimulating it from intense thermal thing, like hot. It is hot iron, something you're keeping in the skin. So what happens is this heat is converted into electrical activity, also called as action potential. Okay, so after this, what happens? This nociceptive information is carried by the neuron by way of an action potential to the central terminal of the neuron. Okay, after that, what happens? It is the process, transmission. Transmission is the third process. It is the process by which peripheral nociceptors release information to the central nervous system, that is transmission. Basically what happens, if we talking about the fifth cranial nerve, the trigeminal nerve, the cell bodies of the orofacial nociceptive neurons are located in the trigeminal ganglion. Basically the trigeminal ganglion is a second order neuron. We read about it in the beginning of the lecture. Second order neuron. It lies totally in the CNS, no part in the peripheral body. Okay, and projects into the thalamus. Now thalamus, again, they have the third order neurons, and another arborizing neurons, they project into the cortex. Now the next step is the modulation. And what is modulation? Modulation is the mechanism by which transmission of noxious information to the brain is modified. What is the importance of modulation? We got to understand. Say for example, I am giving this lecture to you all, and I'm just keeping my hand, say for say 10 minutes or 20 minutes, very, very cool, calmly on the table. Okay, so after 10 minutes, I would have, if I'm not moving it, not at all, and the lower part of my hand, it is compressed. The blood supply and some portion is compressed. So there'll be transient ischemia there, and following transient ischemia, there'll be release of chemical mediators there. A lot of mediators are there, like bradykinin and so on and so forth. So that would cause a little pain. But if I am conscious enough and I know that if I remove my hand, then that pain will go away, then I will try to influence it in such a way so that I can keep my hand still for a longer period of time, so that when I am delivering the lecture to you all, giving the lecture to you all, I don't find it very, it does not interfere with my concentration when I'm giving you the lecture. So that is what basically modulation means. What the brain is trying to do is, it is trying to modify the nociception, the impulses which are received by it. Basically, it occurs at the cortical level or thalamic level. There are some neurotransmitters which are involved. The names are norepinephrine, serotonin, GABA-aminobutyric acid, and endogenous opioid peptides. They are acting as neuromodulators. Finally, coming on to perception. What is perception? It is called the final step in the subjective experience of pain. What is the final step? You're feeling pain. You need to suddenly, like a reflex, you need to remove your hand. You need to do something, you need to flex your muscles. Okay, your tooth, two of your teeth, they're touching together. Apical periodontitis cases, it's very painful, only dental emergency, they say, apical periodontitis cases. So you suddenly need to open your mouth. So in such cases, you perceive and you indulge in activities which will help you in escaping that pain. That is pain perception. It occurs in the insula and the anterior cingulate cortex, and it has been associated. They have been associated with this function of perception. So now proceeding, I will just make out in this diagram the transduction, the conduction of the action potential. Now this is the dorsal root of the spinal cord, and through this, it is here, it is arborizing. We will see a lot of diagrams like this. Those don't get confused. It is arborizing with a second order neuron in the central nervous system here, okay, basically the trigeminal nucleus caudalis, and then through the anterolateral pathway it is ascending upwards to the thalamus, and again arborizing, it's the third order neuron, and then going to the somatosensory cortex for pain perception. So next, now there are some dual pathways of pain signals in the central nervous system. Now, there are two dual pathways for pain signals into the central nervous system. What are those pathways? One is the neospinothalamic tract, or the fast pain pathway, and the neurotransmitter released the glutamate. And the second one is the paleospinothalamic tract, or the slow pain, and the neurotransmitter released in this case is the substance P. Now coming on to the neospinothalamic tract, or the fast pain pathway. How does the fast pain pathway, which is mediated by the A delta fibers, reaches the somatosensory cortex? What is the pathway? So first of all, mechanical and acute thermal pain afferents, okay, they arise in the peripheral nervous system, and they terminate in the lamina 1 or the lamina marginalis of the dorsal horns. Now before that, I'd like to tell you, the dorsal horn of the spinal cord, it is divided into various laminae. Okay, lamina 1, lamina 2, 3, 4, 5, 6, 7, 8, 9, 10. We are concerned with lamina 1 to 6 as far as our orofacial region is concerned. So lamina 1 to 6, and these lamina, they are basically groups of nerve cells. So these lamina, they are named 1, 2, 3, 4, 5, 6 based on their relative degree of depth. Like lamina 1 will be the most superficial, and lamina 10 will be the most deep. Okay, so like that. Now I hope you've understood now. So they terminate in lamina 1 or the lamina marginalis of the dorsal horns. Now, then what they do is they excite the second order neurons of the neospinothalamic tract. Okay, now these second order neurons give rise to long fibers that cross immediately to the opposite side of the cord, and then they turn upward, passing to the brain in the anterolateral columns. Okay, so most fibers pass all the way to the thalamus without interruption, terminating in the ventrobasal complex along with the dorsal column medial lemniscal tract for tactile sensations. So before proceeding, let us stop here and let us try to understand this. Now, what is the meaning of this? These fibers, they terminate in the ventrobasal complex along with the dorsal column medial lemniscal tract for tactile sensations. See, basically, why do we need nociceptive impulses to terminate with the tactile sensations also? Because the localization of pain is very important. Okay, you need to localize your pain, exactly where is the pain is arising from. You need to alleviate the pain. If you can't localize it, do you want to put liniments over big areas, all areas, or analgesics over big areas? Why do you want to put anything on a bigger area, wherein if you are able to localize the pain in a smaller area? So that is why that is one aspect. Another aspect is, if you are not able to nicely localize it, and more amount of the other receptors need to be stimulated for you to have a reflex of suddenly removing your hand when you are touching a hard thing, then the tissue damage will result. That is why the fibers of the nociception along with the tactile sensation, they terminate together, or they are concomitantly arranged in the dorsal column medial lemniscal tract. Now from these thalamic areas, the signals are transmitted to the somatosensory cortex. Okay. Now you can very well appreciate what I talked to you about. These are 8 delta fibers, the neospinothalamic tract. Okay, peripheral fibers coming, arborizing with the lamina marginalis here. Okay, the lamina 1. Okay, then crossing the dorsal root of the spinal cord, and then through the anterolateral pathway ascending upwards to the thalamus. In the thalamus, you can make very nicely, you can appreciate that from the ventrobasal complex and posterior nuclear group, the fibers finally supply the somatosensory areas for perception. Now we'll come on to the paleospinothalamic pathway. Now, basically, it is also called the snow pain pathway. Okay. The pain transmission for peripheral type C fibers. Basically, the peripheral type C fiber neurons that terminate in the spinal cord almost entirely in lamina 2 and 3 of the dorsal horns or the substantia gelatinosa. Now, this lamina 2 and lamina 3, laminae 2 and 3 are called the substantia gelatinosa. And after that, these fibers, they enter the lamina 5 of the dorsal horn. Now, last neurons in the series, they give rise to very, very long axons which join together and together with the fibers from the fast pain pathway. Okay. Now, passing first to the anterior commissure to the opposite side of the spinal cord and upward to the beginning anterolateral pathway. Now, let me just summarize you. Sometimes we have heard about the dual concept of pain. What is dual concept? You would suddenly feel a sharp pricking sensation, and just 1 or 2 seconds after that, you feel a dull pain. Okay, that is a dual pain because, as you can very well make out, see, the last neurons in the series of these long axons, they join fibers from the fast pain pathway. That is why pain is felt, first pain is felt, which is pricking pain, and then you feel slow pain or dull pain. This is another diagram just showing the same. Okay, pain, and through the subnucleus caudalis, anterolateral pathway, ascends upwards, thalamus, and the somatosensory region. Now, I would like to discuss something which is called the gate control theory. Now, this is very important because we basically, as oral physicians, we are concerned with the alleviation of pain, or trying to provide some kind of relief to the patient when he or she comes with us. So this is that connotation. Now, this gate control theory was proposed by Melzack and Wall in 1965, and it postulates that information of injury is transmitted to central nervous system by small peripheral nerves. You know very well, cells in the spinal cord or the trigeminal nucleus, which are excited by these injury signals, are also, this is the point where we have to stress a lot. They are also excited, facilitated, or inhibited by other large peripheral nerves that also carry other information. Now, what other information are we talking about? That is temperature or pressure. Okay. And finally, the descending control systems originating in the brain modulate the excitability of cells that transmit information about injury. This is what the gate control theory is. Basically, gate control theory is applied wherein we do intentional stimulation of large fiber systems. We are doing intentional stimulation of large fiber systems. So what are we trying to do? We are trying to stimulate the large fiber system, which are carrying forth the temperature and the pressure impulses, and we are trying to close off the short fiber system, which carries sharp shooting pain. Okay, so it results in inhibition of synaptic transmission within smaller pain producing fibers. That is basically gate control. Now, the applications of gate control theory are basically are basically used in your TENS, transcutaneous electrical nerve stimulation, and acupuncture. Okay, we can very well make out that if you're giving touch, then the gate is closed and pain is not felt by the patient. Pain and touch fibers are stimulated together, gate will be closed and pain will not be felt, as depicted in this diagram. Very well. Now let me just show you another very nice pain suppression analgesia system, which is there in the brain and the spinal cord. Okay, another body system which has it. Now we can very well make out the periventricular nuclei and the periaqueductal gray region there in the midbrain region, the mesencephalon. And another very important part in this is the raphe nucleus, and finally definitely the spinal cord region. So at 3 levels, the body or the brain, the central nervous system tries to modulate the pain or tries to decrease the pain before it is even felt. So how does it do that? Well, it does that by the secretion of serotonin, which is a neurotransmitter. And serotonin in turn stimulates the secretion of enkephalin neurons, or the enkephalins, I'm sorry, not neurons, enkephalins. Okay, when that is released, then the synaptic transmission between different neural regions, it is stopped. So that is done in 3 stages. 1 in the periventricular nuclear region, 2 in the raphe magnus nucleus region, and 3 in the spinal cord region. Okay, so that is another analgesia system which is very important for pain suppression system, pain suppression, I'm sorry, and it is present in the brain and the spinal cord region. Okay, so proceeding forward, after having big very long discussion with you all regarding pain and its physiology and its transmission and whatnot and so on and so forth, let us relax a little and talk about a scientist. His name was Thibodeau. Okay, I don't know how to pronounce it exactly. He's probably French, so it'll probably be Thibault. I don't know, Thibault. So he writes, perhaps the capacity of the human brain falls short of the ability to understand its own complexity. Isn't it? The human brain, it's so complex that the capacity of our capacity to understand our own brain, it falls short. It's very difficult. So don't be disheartened if till now it has been a little difficult for you to understand all this. I would advise you to do a lot of revisions and to better draw the diagrams which I have discussed in this lecture of mine. If we visualize the diagrams clearly, then I think it will be quite easy for you to write the answers, because we are preparing for the examinations, and obviously for your clinical, increasing your clinical acumen also. I hope they help. So have a little patience, relax, okay? And there's a little paucity of time, so I hope we are ready for the next part of the lecture. So next part is not very big. I have just consolidated a lot of small know-hows for you, regarding pain. So first thing which I would like to tell you about the applied aspects is, do you know that if somebody feels a pain at the angle of the mandible brought on by exertion and relieved by rest, then we should suspect cardiac ischemia. Yes. Or facial pain symptoms that indicate serious disease. So, we could be poised at a very, important place that we can diagnose cardiac ischemia. And if we do advise a TMT or a ECG, we'll be able to diagnose if anything is wrong with the patient at that point of time, and hopefully save the life of the patient, or, with proper referrals and with proper interventions, timely interventions. Okay, so the next one is, if a patient has earache, trismus, altered sensation in the mandibular branch distribution, well, not always, but sometimes, if we have removed the other, differential diagnosis causes, then it could also be due to carcinoma of the infratemporal fossa. Okay, carcinoma of the please remember this, infratemporal fossa. Now, another presentation is new onset, localized, progressive headache in the superficial, along with the superficial temporal artery swelling, and the tenderness and lack of pulse, and severe throbbing temporal pain. We could suspect it is temporal arteritis. Sometimes a patient would present with new onset of headache in adult life, increasing severe headache, okay, nausea and vomiting. And it could not be, all these symptoms, they could not be explained by any systemic illness or any kind of a migraine, okay, and they would be of nocturnal occurrence. So there we should be suspecting an intracranial tumor. Now, as you see, some cases of headaches, severe headaches, nausea, sometimes they get referred to us. They get referred to us. They might get referred to us because the ENT specialist might feel that, if he sees that there is no opacification of the maxillary sinus, or the frontal sinus is all right, and there are no other presenting symptoms, then he might think that, okay, there might be a dental etiology. So at that point of time, you should consider such pain, if the presentation is such, as a root cause for intracranial tumor, and institute appropriate interventions as and when required. And so, coming into trigeminal neuralgia. The trigeminal neuralgia in a person less than 50 years of age, you should suspect multiple sclerosis, isn't it? It's a well-known fact. We have read about it, but sometimes we tend to forget it. So I just had to put it in front of you all. And then finally, pain associated with altered sensation confirmed by physical examination. Sometimes it could be the harbinger of a neurogenic disorder. So you have to be very careful by doing such examinations. Now, there are a lot of other, things wherein I could have dealt with applied aspects of pain, but because of paucity of time and a lot of other information which is not required at this point of time, I would like to finish my lecture by thanking my respected sir, Dr. Ramesh sir, to have invited me to this platform and given me the opportunity to share my knowledge on pain and its applied aspects with you all. So I really thank Dr. Ramesh sir, and I thank Dr. Anand, and I thank all the other members of the team, VISHNU ADHYAAN team, to have been organized such a nice lecture series, refresher series on basic subjects. And specifically, I would like to thank the organizers for helping me out in the technical aspects of the presentation. So I think with that, we come to the end of my lecture today. But just before the end, I would like to share some references with you for some future studies if you want, or some deep in-depth studies if you want. So I have referred Oki-san, who's the author of Bell's Orofacial Pain, and I have also taken the definition of certain words from Stedman's Medical Dictionary. Along with that, I have referred our Gita, Burkitt's Old Medicine 12th edition. Also, I have referred two textbooks of human physiology, that is Guyton and Hall and Ganong's textbook. They would be beneficial. Out of these two, I felt Guyton and Hall would be a little easier to understand and assimilate rather than Ganong. And then I think that will be all. Thank you very much for your patient hearing, and I really extend my deepest thanks to everybody again. Thank you so much.
Thank you, sir. It's a very great lecture to all the first year post-graduation students. Sir, here is the two questions from the postgraduate students, sir. Sir, could you hear me, sir?
Yes, you are audible, madam, please.
So your first question is that, could you explain the mechanism of the referred pain, sir?
Yes, see, there are one or two probable mechanisms of referred pain. Now, in one mechanism, what has been explained is the fibers which arising from one particular region, say we are talking about the visceral pain fibers were arising from one particular region, and the nociception fibers which are arising from the skin. So both of them, they go and synapse in the spinal cord on the same second order neuron, 1 and 2. In this case, what happens is that when these vessel fibers or concomitantly the pain fibers on the skin, they are stimulated, then the pain is felt in all the neurons which have the spinal cord on the same second order neuron. So that is how you feel the referred pain. That is the explanation of mechanism of referred pain. What was the second question, madam? I have already explained, if you remember, students whom I was telling, I've already explained when I was telling about the tactile sensation fibers in the when they are finally exiting terminating there at the thalamocorticus level. In the tactile sensation fibers, as the pain fibers, they are arising concomitantly. You have pain which is felt in the places where those fibers are supplied.
Thank you, sir.
Pleasure, madam.
So here is the appreciation certificate from the team Vishnu Adhyaayan, sir.
Thank you very much, Vishnu Adhyaayan.
Thank you, sir.
Thank you.
It's my pleasure to introduce our next guest speaker, Dr. Desai Vandana ma'am. She completed her undergraduation from the prestigious Government Dental College, Bangalore in the year of 1984 and post-graduation in periodontics from Bapuji Dental College and Hospital, Davangere, 1988, under the able guidance of Dr. K.R. Devan, who was known for his basic knowledge in medicine and periodontics. As a routine, being a part of several examinership, guiding postgraduates, publications, attending many conferences, DCI inspections, life memberships, organizing CDE has been a general routine till date. Reviewed to several PubMed indexed national and international journals and papers with Google citations of 2020, H index of 21, and ITAN index of 37. These numbers shows her interest towards academics, especially in the field of periodontics. At RGHS, been a chairperson for MDS Periodontics Syllabus Formation, board member of UG, PG, and PhD committees. And she is a PhD guide status is a fresh academic step. And the main areas of research involves periodontal health and disease in dental fluorosis subjects using scanning electron microscopy, various non-surgical procedures, advanced diagnostic aids. The recent area of interest is autologous stem cell research in periodontal regeneration. The collaborative research projects with Professor Charles Cobb, Kansas University, United States, is the most constructive academic excellence, along with the collaborative support by South African University for bone graft. Probiotic project by Italian company, Gingival project by Italian company, and power toothbrush Colgate Palmolive, United States of America. Academic journey is of satisfying and gratifying. Sharing a grain or ocean of knowledge to the aspiring students is on regular basis against all odds occurring. Ma'am is a great believer of today is tomorrow of yesterday. With this introduction, I would like to invite Vandana ma'am for her presentation titled Wonders of Wound Healing. Ma'am is presenting this topic along with Dr. Rupali ma'am, and Dr. Shravani will introduce Dr. Rupali Kalsi Mathu ma'am. Over to you, Shravani.
Thank you, sir. Dr. Rupali ma'am has done BDS from GDC Jaipur and completed MBS in periodontology and implantology under the able guidance of Dr. Vandana ma'am from College of Dental Sciences, Davangere. Currently, ma'am is pursuing PhD. She has teaching and research experience of more than 12 years. Ma'am is currently working as Associate Professor in Government Institute of Medical Sciences, Greater Noida, and has several national and international journals to her credit. Now the topic of presentation is Wonders of Wound Healing. Ma'am, you can start the presentation now. Thank you.
One and all. This is a pleasant afternoon for both of us and to the organizers. And you can see the beautification of the earth from what was wounded gets healed with a good nature's touch. So once again, good afternoon to all of you. Today's topic of presentation. You can go on changing the slides. Yeah, so that is the topic, excuse me, the topic of today's presentation is Wonders of Wound Healing by two of us, Dr. Rupali Kalsi, a Quartz Perio alumni, very proud of her, and myself, Dr. Vandana KL, College of Dental Sciences, as a senior professor. And the topic is wonders, and I hope we do wonders in this topic of presentation. Next slide. Next slide, please. Yeah, the time to thank the organizing committee, because without you, we wouldn't have had this platform. Triple O, I was told, Dr. Ramesh, Kishore, Ravikant, and very fond of Gautami, Girija, Varma, Chaitanya, and Himalingeshwar Rao, sir. And Vishnu Raju, sir, the head of everybody, the chairman. I'm ever thankful to him for the best of the nurturing he does to Bhimavaram Dental College, and to all the staff members who have been going very well there. And Suresh Sajjan, a good old friend, and Ramaraju, also our own BDCH alumni, a friendly soul. Thank you. Next slide, please. And the journey of my academics began from GDC Bangalore as a BDS student, and first batch of postgraduate student from Bapuji Dental College. Perio was my passion now, and is. And in College of Dental Sciences, I'm serving as a senior professor from past 34 years. It's been a great journey for academics, and love to be on this platform. Next. Yeah, blessings from our own city, Davangere, Durgamma, and ever thankful to our management, the father of education, I call him, Shamnu Shivshankarappa, and the earlier support by Mr. VISHNU as a chairperson, and was quite responsible for my academic growth, and my own department, Professor Head, Dr. Prakash, who has been a supportive friend, and all my staff members and postgraduate students who have been always with me for growing better. Next. These are the contents of today's topic presentation. You can see from introduction to references. You would enjoy them as I go from one slide to other, and you can have them. So these are the ways we usually ask one student to learn, and that's how we have presented here. Even otherwise, anyone who would want to enter into the wound healing part, it could be represented like this. Next. So whenever there is a wound or an injury, all of us have realized this. The healing process, the beginning, is never understood. It's never been realized that it has started already, because this process is beautifully orchestrated by highly ordered cellular cascades and chemical regulators from within. And that is a blessing which we have, all of us have received. Not even the human world, even the animal world enjoys this. And this healing process, comprehension of this, the steps or the how this process occurs, is very important, because it helps us to design a proper surgical procedure so that the therapeutic objectives can be obtained from this by a proper designing of the wound, and then it's understanding the healing process. And we also help the patients to reduce the healing period and make it comfortable as possible. Next. When the definitions come, yeah, it's for the one should know. But whenever I would like to explain, when it is called as definition, two words are very important here: repair and regeneration. Because the definitions will make you learn, but sometimes it doesn't lead you how you understand them. So repair and regeneration are the integral part of wound healing. And wound healing is always either by repair or regeneration. Whenever there is repair, we say wound has healed by repair. It has healed the wound that has occurred. But two important aspects of wound healing are restoration of the function and the architecture, which will not happen when there is repair, because a scar tissue is being formed. And the regeneration, both the architecture and that is the structure and the function of the lost tissues which are replaced during wound healing are being restored. That is a very good differentiating point between repair and regeneration. So whenever there is a wound, there is a forcible interruption of the continuity of any tissue. So this either gets healed by the repair or regeneration, or sometimes the combination, depends on the type of wound. So wound healing, as a definition, it goes, it's a process of repair or regeneration of the injured, lost or surgically treated tissue. And when the words or the definition of reattachment and new attachment is called in here, these two are basically, we discussed this in length from the point of periodontics after the surgical periodontal attachment, new attachment procedures, wherein new attachment is a type of regeneration. It's the example wherein all the tissues which are lost as a result of periodontal disease, like periodontal ligaments, cementum, and even the bone, are being restored. So there is a structural and a functional restoration in new attachment, which is attempted in many ways by using many ways. Whereas reattachment is just that the ligament fibers which have been detached due to trauma or some other means, they get reunited. Periodontist feast, or there would not have been way to make the pocket formation. Next. The historical perspective is not very clearly defined for wound healing. However, we know that they say Egyptians, they began in somewhere in 1600 BC, and Greek physician Hippocrates had this said in 460 to 377 BC. But however, I don't think India could be the last here. It could have been the first, because Charaka Samhita and Shushruta, we know that they belong much earlier to these ancient civilizations, and they know that how beautifully the wounds were treated and scientifically, but not presented because of the days that it was known that it works, but it was never been sort of tested for. So as earlier the herbs were the fame, in between the present modern era, started to use only the allopathic agents, which have only one function, I would say, most of them as antibacterial, and unlike the herbal medicines, which will have multi-potential activity, like the turmeric, it's granny's medicine. This turmeric paste, as we have researched, it has antimicrobial, it has anti-inflammatory, and immunomodulatory and antioxidant properties, all in one. So this is what is required during the wound healing to enhance. So the modern era is going back to earlier era of using herbs, and I think that would be the need of the hour to help the wounds to heal better in all aspects. Next slide. The CDC classification of surgical wounds. So all these slides, remember, it is must know, because we are talking about the basics of wound healing. And this CDC classification of the surgical wounds, this is adapted from American College of Surgeons into 4 classes. Class 1 is said to be clean, where there is uninfected surgical wound without any inflammation and closed. Little difficult to believe this, because whenever there is always subclinical inflammation, at least to whenever there is a wound. So, but this is the classification, and sometimes we tend to follow. We need not follow also. Trying to modify it can be modified. And class 2 is said as clean and contaminated, where the wound is present in such an area like elementary or genital or the urinary tracts. The wound, though it is clean, it is contaminated with the bacteria they are present. Bacteria can be commensal or a pathogen. So whenever the pathogen is there, then the term infection begins. But here, that's what basically CDC following this as clean, contaminated, not very clear definition, but nonetheless, they're all coming from a infection control journal. So try to follow it as it is given if it is asked. So the first example for the class 1, you can just think of immediately after the extraction, I would call impaction with the suturing. What happens? It could be uninfected and it is closed. Whereas in case of a class 2, again, it is present in the oral cavity, maybe in the form of an ulcer, which is present, which is contaminated because there are commensals in the oral cavity also. Next. The third, class 3 is referred as contaminated. It's one good understanding of a definition for a class 3. It is open, fresh accidental wound. Naturally, very well suits the class 3. There's no contradicting statement being presented. So the open, fresh accidental wound can be referred as class 3 from CDC. And class 4 is dirty and infected. This is again old traumatic wounds with non-vitalized tissue being present and involve existing clinical infection or perforated viscera. So this is again, as it not directly for the oral cavity. I would take the example of a diabetic wound, apart from the oral cavity, wherein there is a lot of devitalized tissue, and sometimes there is also perforated viscera associated with that. And for the oral cavity, it can be a canker oris, which is usually a dirty and infected. Nearly, I have tried to help with some examples. Next slide. The clot and the granulation tissue. Without these two, wound is never healed. So clot is the first host that protects the wound by forming from the blood platelets, proteins, and the cells which stick together. It's a fibrinous mass basically, and tries to protect the wound. Nature's first blessing. Then followed by, we have granulation tissue. Basically, it appears pink in color and an indicator of healing. If there was somebody who has given a close look at the healing wound, they would have appreciated all this if it was visible. And then unhealthy granulation tissue. Basically, we try to see this every other day in the Department of Periodontics, in the periodontal pockets, and the ultimate attempt is made to remove this for the pockets to heal and reduce in its depth and provide a better function for the tooth. The granulation tissue is nothing but it's a proliferating fibroblasts and the endothelial cells from the underlying tissue, which is the second step or the defense mechanism that occurs during the wound healing. And the clot, imagine if there are some blood disorders, clotting disorders, it is quite a difficult issue for the patients who have been suffering from that. When the clot doesn't form, there is no hemostasis and there's a chance of bleeding as a complication. Right, next. The wound healing has been classified. You are aware of this, but let me repeat. First intention, second intention, third intention. And these intentions are also referred as primary wound healing, secondary wound healing, and tertiary. Now, the primary, these are basically based on the extent of tissues being lost and whether when the tissue is lost, whether the wound could be approximated by the sutures, and whether the wound healing ends with regular tissues that has been lost, or is it by the fibrosis or by secondary intention. So that is the explanation that is given in the table. So first intention, there's minimal loss where the wound edges can be approximated, and usually the healing occurs predominantly by the regeneration and little of fibrosis, not not much at all. And then second intention is the reverse. Wound is little wider, so that the wound edges cannot be approximated, and the healing occurs by repair, and the end result is usually a scar which is formed. You'll enjoy this in the slide, but before I go to the next slide, the third intention is something when the primary intention healing is compromised due to infection and there is a wound gaping, the sutures are given up, and then it tries to heal. There's an option of leaving it open till the infection is reduced, or when there is a presence of some foreign body also, and then allow it to heal. This becomes tertiary or the third intention, and this is not usually spoken about, but primary and secondary are the main goal. And then third is usually when it happens, as I explained. And then this is the knowledge I have tried to discuss with my husband, who is an oral surgeon, because sometimes the books becomes a short of understanding than the clinical experience by the clinician, and I have enjoyed that with my partner, Dr. Rajendra Desai, asking him to define and trying to give me the differences between all these. Okay. Then partial thickness healing is generally we use this for many of the soft tissue grafting procedures, because these definitions are taken from our wonderful book given by Linde, Clinical Periodontology and Implant Dentistry. So this has been added there. So the postgraduate students can enjoy this from periodontics, even others, what is there in learning. And this usually primary by epithelialization. It heals by primary by epithelialization. Next slide, please. So this is the good explanation. Usually the diagrams speak of the lectures that is given. You can see here, the left-hand side is the healing by first intention. And this is for the skin incision, and healing by the second intention is for the deep skin burn. I'm sure this is quite a familiar picture, because one of my first year students, Prerana, she showed me this is already existing in Harsh Mohan ma'am. And of course, that's a good understanding that I'm just repeating for you guys, because you have finished your BDS and then also given NEET exams, and then you have come out very successfully. So when you have to compare, see this typical initial injury, when you have, there is disruption of the tissue, that is tissue loss, which is minimal on with the skin incision, and then with the deep skin burn on the right side, you can see the extensive loss. Burns are most disastrous wounds that to heal, because the first thing is they get dried up to get infected, and then there's a lot of suffering for the patient. And then there's always an attempt from the clinician to help this out. But unless the nature takes the call to heal, there is always a difficulty in healing of the skin burns. And then in the day one, see, day one inflammation, before the day one, as soon as the wound occurs, there's a clot. So continued with in the first 24 hours, you have the clot being formed and the exudates from the wound. And then neutrophils from the adjacent capillaries begin to surround around the wound area. And there is an attempt to control, because of the hemorrhage, it's an attempt to control the hemostasis. And then by all these means, that is how the wound and the nature tries to heal. And by day 3 and 7, granulation tissue stage is being formed, wherein we have fibroblast proliferations, and then capillaries, endothelial cells, which tries to take away the tissue that has been lost there. And stepping into organization of the wound, this is what is called when the proliferating fibroblasts and the endothelial cells begin to take away the lost tissue that is being formed between the wound edges. And then that work is beautifully done by the macrophages. And by day 30, scar tissue is formed. A white scar happens on the skin burn side. It takes a long time than day 30. And then narrow scar is seen when there is a skin well inside the skin wound. And collagen plays a vital role in in the end part of the healing and contraction of these collagens, and then also that leads on to the scar formation. Next stage. So this is healing by first intention. I just now spoke to you all that. So these 3-4 slides are just a repetition for all of you to, which has been given better from Harshamohan. All of you are very familiar with this. I just said for a descriptive aspect, if you have a essay type of question, you can make a tabular column like this and try to follow this so that you have a better scoring for this. And then see, this is where the learning goes. You follow not one book, you tend to have better things, and then you can make your own way of presentation. Next slide. Even here, the same description is followed as a secondary intention. Wherever there is an open wound with large tissue defects, which at times is infected, I told you, it can become, and it heals by secondary intention. And there is loss of extensive loss of the cells and tissues, and wound can never be approximated by sutures, but it is left open to heal. So the secondary intention of healing occurs. Next. Yeah, there again a tabular column. I always enjoy making a tabular column, or this is directly taken from there. And that gives even the examiner to correct better. And even the people who are trying to listen to it, apart from the students, you get a better version of understanding and differentiating what happens from initial hemorrhage to wound contraction. Next. Again, repetition, I am admitting this because more the types the books have been presented, you try to get into. So it's your job to make yourself comfortable. Which one is good to write or good to draw, and then go ahead with that. And also to those people who had just gone away, little away from the computer screen for some reasons, you can enjoy this again. And then see how best the primary intention of healing on the upper part of the slide is descriptive, and the lowermost part is descriptive for the second intention. Next slide, please. A brief comparison of primary versus secondary wound healing. You can see them the same, the version of being presented. Again, you know, Harshamohan, the essentials of pathology, he's been very student friendly, because when we used to refer the other international books, you know, even physiology, Guyton, he used to have baby organs also for this, Osborne for this, and then we also have most of the textbooks which were never had an Indian edition or an Indian author, but they are very friendly to the kids now, and then try to present it as differentiating, maybe helping them to have a better viva answering capacity or a writing capacity. You can, the same thing what has been told, been repeated here. The one differentiating point, the very clearly mentioned for primary healing is no wound contraction. I agree with that. And wound contraction is present. And basically, I'm happy they have taken two examples for a primary healing of flap surgery and secondary healing by the gingivectomy. And the primary healing for oral surgery, I would say the one which is post impaction cases. And then whenever there's a dry socket, it usually heals by secondary healing. Okay, I hope you all agree with that. Next slide, please. So phases of wound healing, there are 4 phases very demarcating, which is better explained from the next slide. I wish to have the next slide. So here you can see the beautiful graph. This is usually taken for the phases of explanation of the phases of wound healing. And from, you can see from the diagrammatic representation from phase 1, representing from day 1 to day 3, wherein it begins with the hemostasis, with the clot formation. And in the phase 2, you have from the 3rd day to 20th day, the inflammation begins and continues. And new framework for the blood vessels growth is laid down there. And then phase 3, this is from the 1st week to 6th week, the proliferation of the granulation tissue, wherein it tries to bring the wounds closer. the wound edges, they tries to bring closer. And then the fourth phase is final proper tissue being formed, which has been lost, which is called as remodeling or the maturation. It takes, see the extensive years from week 6, the 6th week to 2 years. It all depends on how best the healing can occur. Okay, especially some of the wounds, which I would call those patients who suffer, they need to have, and along with their attendees, they should have so much of the patience that the wound has to heal. Even it can take up to 2 years, and it is very pathetic situation. I'll tell you, the diabetic foot or the diabetic conditions. It always, it's always a suffering for the one who undergoes and also one who is seeing it. Next slide, please. Healing patterns of periodontal wound. Yeah, I had to have this because this is my arena, and then it has led me to a beautiful academic growth, all the periodontal aspects. So here the 4 healing patterns of wound healing have been represented in the next slide. And we have to have, see, there is whenever there is a debridement of the granulation tissue is taken care, there is a formation of long junctional epithelium on the root surface that is debrided. That becomes a reparative process. And also along with that, there will be proliferation of the connective tissue. And if this has to happen, I need to have a GTR membrane. Then the long junctional epithelium will not form, and then the connective tissue that is forming can get attached to the root surface. So the predominance of the bone cells, what happens to the bone cells? Bone cells, it takes its own stand. It doesn't happen within 6 weeks. Whereas connective tissue healing and the epithelial healing, within 1 week, and then the connective tissue healing is just about say 4 to 6 weeks, but the bone healing goes up to say 6 weeks, 9 months, and then 12 months. Even sometimes we have followed up to 2 years to have a better understanding of the bone for the regenerative medicines that we have tried. So this is how the whole of the best part of histologic events that is studied is in the periodontal wound, because this is a very different kind of an attachment in the whole body, where the soft tissue is getting adhered on one soft tissue in between and 2 hard tissues on either side. And what we have studied the best from textbook of Goldman for periodontics is, I don't think I have come across anywhere else. That is probably my extent of search may be limited, but I would like to say here, the epithelium healing is the epithelial cells, they move like a amoeba. It's called as amoeboid movement. And then it is very slow because amoeba is very slow. And then it can move up to, say, the per day they have measured also histologically. It can be about 5 micron meter, if I'm right. You can correct me if I'm wrong. And then the beauty of epithelial migrations is from the wound edges. Once they come in contact, each epithelials from either side of the wound edge, it stops, and it is called as the contact inhibition. And that is the best of the step there, where whenever it comes in contact with the tissue, it begins to stop. It doesn't go further. Imagine if that contact inhibition was not there, you could have had a overgrown epithelial tissue at the site of wound healing. See, nature is very kind. Nature is very orchestrated. We think that we are very smart, but no, we cannot go anything to do with the nature at all. And these things cannot be designed, and these are not orchestrated by the human mind. It's only understood by the nature. Why it happens, also we try to get into the learning. So these are the areas we have to remember, that how the epithelial healing can occur and the connective tissue healing can occur. Next slide. You have a lot of time periodontal students, peri-OPGs. I will say these diagrams becomes your basis for understanding any of the healing events, from scaling to surgical events. I hope you will try to get into that. This is from Color Atlas of Dental Hygiene. And now the oral versus skin wound healing is currently presented in 2021. by the biomolecules. That's one of the well-known journals for wound healing aspect by Vastrop et al. But I would say clinical, this is, you have to have desirable to know. You need to have this because if you're asked, you're sailing through in better in your Viva or somewhere in the any other interviews, probably if they ask oral versus skin wound healing, you can say the author's name, Vastrop et al. In 2021 has suggested, given molecular basis of why the oral wound healing is better than the skin wound healing. You can see the representation of the arrow marks for the skin and the oral mucosa, and the criteria to differentiate is on the left side, and a note is given. And now I would say the salivary, because saliva is so, it decreases the clotting time and hemostasis is achieved faster than the skin wounds, which has been depicted from the three arrows here. And then next is, you can see the extracellular matrix remodeling, first to 14th, I'm reading it for you. Here, MMPs, matrix metalloproteinases, I think they'll be a little above your head to right now to get into all these fractions of molecules. So what you do is you can take a snapshot of this slide and try to go through and learn at home. You have a homework also always whenever you listen to a lecture, and you get most of the things I have given it here. And then one thing I would like to say here, the 9th one, the reepithelialization and the keratinocyte migration and the proliferations are being least in the skin, whereas it is highest in the oral mucosa. Most of the three, whatever is marked with the 3 arrows, you say that's the upper hand for oral mucosa to heal better. Okay, in short. Next. Does it play? I'm not very sure. If the video is not playing, let's give them the link and then let's go with the further. Let's not, I mean, I know I should stand by the time. So if it's not playing, it usually happens, videos which are copied. Let's give them the link in their, when our lecture is going on. In the chat, we can send them and they can copy it. I think it's not playing, right? No problem. Thank you for helping us out. Without you guys, I don't think we could have recorded today, and we have had a tough time and do not know, maybe there was a lot of rain and the net is very, very slow and we were unable to get any good recording. Thank you for this. I wish to say this right now. If it's not playing, let's go to the next. I think, as I understand, now my representation of the expression for wound healing, I wish to conclude right now, but I'll be getting back. And now I ask Dr. Rupali to continue with this, with her wonderful presentation.
Thank you, ma'am. Thank you, ma'am, for giving me this opportunity to share this platform with you, ma'am. Now, moving on to the next section, which is preparation and irrigation of the wound. Now, preparation of the wound is of utmost importance for successful wound healing. It is basically a two-step process. In the first procedure, we need to remove the contaminants which are there in the wound. In the second part, the excision of the non-viable tissues is carried out. This is followed by irrigation. Now, while selecting an irrigation agent, there are certain ideal requisites of any irrigating agent which we are going to use. It should have good antimicrobial properties. It should not be toxic to the tissues, and it should be available to us in low cost, and it should be readily available. The goal of skin preparation is to decrease the surface microbial contamination, whereas the goal of irrigation is to flush off the contaminants and reduce the bacterial load, and making the structure conducive to healing without destroying the cells which are necessary for wound repair, which are generally fibroblasts. So the irrigating solution which we are going to use should not be tissue toxic. Next slide, please. The normally used irrigants are normal saline, hydrogen peroxide, povidone iodine, chlorhexidine, and isopropyl alcohol. A fixed volume of irrigant is necessary so as to achieve the irrigation, a thorough irrigation. For a smaller wound, a minimum of 200 ml of irrigant is necessary. But as the size of wound increases, the more volume of irrigant is required. Irrigants are generally delivered by two systems, either by a hydraulic stream or by a sponge carrier. Next slide, please. Now, when we talk about chlorhexidine and wound healing, the literature suggests that chlorhexidine has got inhibitory effects on wound healing. It retards the wound healing. Chlorhexidine has been shown to impair the human fibroblast attachment to the root surface, and it does affect the cellular as well as total collagen production. So in the early stage of wound healing, we should not use chlorhexidine as an irrigant, but in the later part, we can use it. So for the first 48 hours, the use of chlorhexidine should be avoided. Next slide, please. There are certain crucial steps which need to be followed before doing the wound closure. First of them is hemostasis, and second is elimination of dead spaces. So before doing wound closure, hemostasis must be achieved. It is generally achieved by giving a pressure pack, but when the areas where the bleeding is very profuse, we need to apply electrocautery or thermal cautery, and suture ligation can also be tried. These days, topical thrombin and soap with sponges are also acceptable and are easily available in the market, commercially available. Elimination of dead spaces is again a second very crucial step. Pressure dressings and drains are main methods for controlling the dead space. Now, after we have achieved the hemostasis and eliminated the dead spaces, we need to achieve the skin closure, which can be accomplished easily with the help of staples, tapes, tissue adhesives, and suture materials. Polymers of cyanoacrylate, most commonly used as N-butyl 2-cyanoacrylate, can also be used for skin closure of simple wounds. Next slide, please. Vast array of occlusive dressings are available in the market, like foams, alginates. There are certain characteristics of an ideal occlusive dressing which should be kept in mind before their selection. They should be easy to apply and remove without causing any tissue trauma. They should be transparent so as to visualize the underlying wound preferably. They should be semi-permeable and absorption. They should be able to absorb the exudation which is coming out from the wound. They should be flexible and not expensive, comfortable and affordable to the patient. Newer agents like ozone therapy and application of hyaluronic acid can also be carried out so as to accelerate the wound healing. Next slide, please. There are certain recent advances in the field of surgery, which is a boon for wound healing. They are lasers and nanotechnology. I'll be discussing them too in brief. Next slide, please. When we talk about lasers and wound healing, application of low-level laser therapy has shown to have beneficial effect on wound healing. It has been postulated that whenever we are going to apply the laser light, it causes vasodilation, which brings about more blood supply to the area, and which not only increase the oxygen supply to the area, but also greater traffic of immune cells into the tissues. Because of this greater blood supply and a large number of immune cells in the area, they cause acceleration of the wound healing. A study by Lingam et al. In the year of 2019 has suggested that when we are going to apply laser with the surgical procedure, say like gingivectomy, it stimulates the wound healing and improves the overall surface keratinization. Next slide, please. The therapy which is performed with application of laser in suboptimal doses is known as low-level laser therapy, is also referred as biostimulation and biomodulation. It works on the principle of Arnold-Schulz law, which states that whenever we are going to apply a laser beam in low intensity, in low dosage, it is going to increase the activity of physiological processes. But whenever we are going to increase the intensity of the light or the laser beam, it has got an inhibitory effect on the physiological systems. So based on this aspect, we are going to apply low laser therapy for the healing wound, which is going to cause acceleration of wound healing and decreasing. It is also going to decrease the patient level discomfort. Next slide, please. Now, apart from the biostimulatory and biomodulatory effect, laser has also got bactericidal effects. Researchers have shown that lasers are effective in eradication of bacteria, resulting in better wound healing. Laser treatment reduces the amount of subgingival microbiota and lipopolysaccharides from the root surfaces, thus making it more conducive for healing. The thermal effect of laser beam is based on the absorption of radiation by the tissue and subsequent transformation of laser beam into the heat, which brings about its bactericidal activity. Next slide, please. Next advancement is in the field of nanotechnology. Literature suggests that silver nanoparticles can promote wound healing through their anti-inflammatory properties. It decreases the bacterial load by inhibiting both gram-positive and gram-negative species. Wound dressing incorporating silver nanoparticles are available in the market and they assist in wound healing. Next slide, please. So the take-home message is that when we are going to apply these recent advancements in conjugation with wound healing, we are going to achieve better patient compliance as the pain intensity of the pain experienced by the patient is reduced. It is less time consuming and it gives the predictable results. Next slide, please. Now, what are the methods of assessing wound healing? The primary methods used for evaluation include the histological methods. In histological methods, we need to take the biopsy or histological section of the tissue and view it under microscope so as to see if any regeneration has taken place or not. But there are certain disadvantages or limitations associated with histological analysis. First is the morbidity associated with the biopsy. Secondly, it allows only one point time evolution of the area, and it sacrifices the tissue or the tooth, which has got ethical concerns as well. Then second method is the clinical examination. In the clinical examination, we can measure our direct measurement of the bone using radiographs or by periodontal probing or clinical assessment, like by suppose we check for probing pocket depth subsequently after application of laser so as to see that healing has taken place or not. We can assess the clinical parameters like change in the color, inflammation, exudate, like that. We can assess the clinical examination so as to assess the wound healing which is taking place. Then the radiographic analysis for studies on regeneration by viewing films, standardized IOPA, direct digital radiography, digital subtraction radiography can be employed so as to check for any regeneration which is taking place. Biochemical analysis is another method in which we can check taking out the sample using gingival clavicular fluid or peri-implant clavicular fluid or any exudate which is coming out from the wound, healing wound, and we can assess for the biochemical parameters like vascular endothelial growth factors or any other alkaline phosphatase enzymes, MMPs can be assessed so as to check for the success in the wound healing. Then other methods are fluorescent labeling of the cementum. In this, tetracycline and other complex ions can be used and employed, which are known to be incorporated in the newly mineralized tissue. Say, for example, cementum, which later can be viewed through fluorescence microscopy or toluidine review staining. Another method is wound healing indices. So, next slide, please. This is another method which is non-invasive in nature. In this, we can, based on the clinical examination and the parameters like tissue color, response to the palpation, presence or absence of the granulation tissue, how the margins of the incision are looking like, and presence and absence of suppuration, we can we can categorize the condition of the healing wound into good healing, poor healing, excellent healing, and so that we can assess the growth in the healing which is taking place. Next slide, please. Now, there are various factors which affect the wound healing. Broadly, they are categorized into two types, the local factors and the systemic factors. When we talk about local factors, presence of any foreign body or local irritants are going to impair the wound healing. Plaque and calculus, excessive tissue manipulation during the treatment, trauma to the tissues, presence of foreign bodies, all of are the limiting factors for wound healing. Whereas, on the other hand, healing is improvised by a thorough debridement, immobilization of the healing area. If we are going to adequately approximate the wound margins, we are making the wound to heal by primary intention. Hyaluronic administration can also be carried out because it stimulates the angiogenesis of bone. Next slide, please. When we talk about the systemic factors, they also play a very important role in the healing wound. Healing is delayed in the patients with generalized infections like those with diabetes mellitus and other debilitating diseases. But it has also been seen that the patient with well-controlled diabetes mellitus responds similarly to the healthy controls. Healing is retarded by insufficient food intake, bodily conditions that interfere with the use of nutrients, deficiency states like vitamin C deficiency, proteins, and other nutrients. Next slide, please. So their nutrients thus play a crucial role in the healing of a wound. It has been, research has shown that certain nutrients like cantella, aloe vera, copper, vitamins play a role in the wound healing. Cantella, which is an herbal medicine, improves collagen production and angiogenesis. Aloe vera, which is again a herbal remedy, it enhances the cell wall permeability. Copper and vitamin C are helpful in formation of bone healing, in the formation of bone and the collagen production. Vitamin A and vitamin B are important in tissue synthesis and they stimulate the cell proliferation. Similarly, the curcumin, which is again a herbal remedy, it improves the reepithelialization and migration of cells such as myofibroblasts, fibroblasts, and macrophages necessary for healing of the wound site. Next slide, please. That's all from my end. Over to you, ma'am.
Yeah, that's very pleasant presentation for me. I have to continue with that. Okay, I was just sailing through your presentation, Gopali. Now, shifting over to dental stem cells. Why did I add this? Actually, the factors which affect healing, I said the concept which we have worked from the past few years. I said, let me add that. And then just a brief introduction. Dental stem cells are usually, see, they are found everywhere from the extracted tooth, from its genesis, I would call. So you have follicular stem cells, or from the apical papilla, periodontal ligament stem cells, from the gingival fibroblast stem cells, and also DPSCs, that is pulpal stem cells, are very prominently being used, and cells from the exfoliated teeth. These, with the short forms, you try to understand. And this is a beautiful depiction for tissue engineering. We have to have the stem cells along with the growth factors and the scaffold, which is compulsory. And I wish to say why the reason to add this stem cell slide is, kindly show me the next slide. Next slide, please. So here, all of us know that younger the age, better is the wound healing. Yes, that fact has been, we have identified, we have found out a reason why there could be age-related changes in the wound healing. Okay, so we have studied the PDLCs in different age groups. From we have taken the PDLCs from the say deciduous teeth, adult teeth, and from the geriatric patients. And when this was cultured, we have seen that there is a difference in proliferative activity of the stem cells from the deciduous teeth to the age-related. A higher activity was seen in the deciduous teeth than in the geriatric, as expected. And we have found out the reason why, how the stem cells assist in wound healing and why there is a age-related change. Okay, this is how sometimes a bit of innovation thinking out of the box, and how we can try to provide help ourselves from the Indian scene. So that is how we can grow with our subject, and then we can try to do a better concept from, for example, as I told you, CDC has its own shortcomings, but one of you can try to have how best it can be classified. And then this is how we can grow in every subject. Nothing is less and nothing is more. And I would like to say, play with stem cells. They are the ultimate therapeutic modalities way to come, because Alzheimer's and Parkinsonisms have been trying to be tested, scientifically researched using PDLCs. See, how do you like that? So the stem cells which are there from the extracted tooth can become one day an innovation from the Indian scene, the Indian mind, which is always rich. Okay, try to be the present generation. You can try to think on those lines, how differently you can think from just not the dissertation, but you try to have a different outlook and avenues to assist yourself from the people who have been working on it, and then from globally or from within the India, and then you can try to help yourself. Okay, so stem cells will be the mainstay for wound healing, in not only from the dental aspects, the oral aspects, it will be for the systemic effects it has, which it can do so many, it can regenerate collagen, it can regenerate bone, it can regenerate various other tissues which are required as the need comes. Fine. So that is what I would like to say here. Next slide, please. And conclusion, yes, we have what to conclude is that is wound healing is it's a phenomena, and it is a knowledge, and it is a wisdom which you gain, and it has to be understood. It's not just taken into granted, or not just taken into very lightly that any wound heals. No, it is wrong. Wound heals, but you are there to do it either primary intention or the secondary intention, and the knowledge regarding that. This one brief 45 minutes of explanation is just an eye-opener for you, but go into it before you start operating or those surgical areas, and then restorative areas like prosthetics, and then conservative and orthodontics also should be aware of this, because there is definitely some of the tissues which are going to be healed and they are wounded during your procedures, and then you have to have a good knowledge of wound healing. And I would like to say here one issue of not adding the implant healing. I think that is it's a whole probably it takes away, which is a most desired and by many people. But I only remember, I would like to just say osseointegration and fibro integration, but lots to do with that. But probably somebody else can take over that. And then with this note, I conclude as a subject, as a topic from both of us, Rupali and myself. And then another few slides to thank a few people around. So let me have the next slide. References, of course, they're very important. Please don't ignore, because without the references, you saw most of our slides were with reference except one or two. So try to have the references to be more validated, and try to assure that you have not just cut, copy, pasted. Next, it can be from a textbook or from a journal, but you have to get the authenticated one, not just which is flying around in the Google. Please remember that is a very important step in having the references. Next slide, please. Yeah, these are always thanking your teacher is one of its kind, because without them we would not have existed. Dr. K.R. Devanath, who is and who is always my teacher, who is no more, but he's always there with his basic concepts. And Professor Cobb, who is a mentor and always helped me with my academic SEM studies. And these are my parents, of course. Without them, there's nothing more to say. Without their blessings and then vision and mission, I would not have reached here, and I would not have had wonderful students to be taught. Next. Yes, my family, my strength, and my love. Yes, all of them. This is only comes from as a last slide. With any queries to my email, my husband, Dr. Rajendra Desai, oral and maxillofacial surgeon, and my son, Shantanu Desai, they are always a part of me, especially when the technically we are oriented and then subject oriented. Both of them are a very good support for me, and thank you. And I have to thank Divya and the group, whoever has been helping us to today's mystery of getting into Zoom and deciphering the mystery. Thanks a lot. And then also, Gautami, never to forget you, because you are always a wonderful person to bring me on this stage in several aspects. Avalokana to, now the latest is Akshaya, right? And always in between, I have been there on this platform and enjoy being here. I hope you all enjoyed the presentation, and take a good care, all of you, and take good care of others too. Thank you. Thank you all. Thank you again.
Thank you so much, ma'am, for your excellent presentation. We got 2 questions from the PG students, ma'am. The first question is that, what is the prevalence of pressure ulcers in wound healing?
Pardon me, what is the?
Prevalence of pressure ulcers in wound healing.
Pressure ulcers, what are these? Let them answer if they know.
Moving to the second question, ma'am.
Yeah.
What type of wound healing occurs after scaling and root planing?
What kind of wound healing after scaling? Okay, that's a science itself, but it's basically the type of healing after scaling and the root planing. We anticipate changes in the, all the reduction of the inflammatory signs, and it's just a reparative process. It's a repair inside the sulcular, which has been sulcus, which has been hurt or been wounded, can result in the reparative process. Okay, and it doesn't ever, unless and until we attempt for regeneration, it's not a possibility. But scaling and root planing is a non-surgical procedure. So basically, we appreciate most of the times the clinical changes, and type of healing is only referred as, it's just heals by all the signs and symptoms of inflammation gets reduced, and the ulcerated part of the sulcus gets healed like any ulcer. Okay. And it generally generates the new sulcus, which will be formed after the scaling and root planing. Is it adequate? The one who asked.
Thank you, ma'am.
Yeah, I'm interested. Let them give me the answer for pressure ulcers after what is that prevalence of pressure ulcers. I am not doing that. I'll try to learn about it. Thank you. Rupali, anything you know about it, if you can answer.
Yeah, Vandana.
Hi. Hi. Any other questions?
No, that's all. I think it was quite clear.
Yeah, you're the question now.
Yeah. If Rupali want to talk something, she has to unmute.
Yeah.
She is muted, I suppose.
I think that is in the hands of your team.
Sir. Yes, sir. Good afternoon, ma'am.
Good afternoon.
Pressure
Rupali.
ulcers are very rare in the oral cavity. They are generally seen because of some pressure from the endotracheal tube or something like is there in the oral cavity in the patients who are there in the ICU wards. Otherwise, they are not seen in the oral cavity. They are generally seen the patient on the back side, like of the patient, mainly on who are bedridden patients, basically. So in the oral cavity, they are rare.
Maybe
but yes, they are seen. They are seen if the pressure of endotracheal tube is there in the oral cavity in the patient who are admitted in the ICU wards.
Bedridden patients who have got the ulcerations, those unhealing, sometimes ugly, becomes the cause for infection, right, Rupali?
Yes, ma'am. Yes, ma'am.
You're right. Thanks for the orchestrating the answer here.
Our
Anything
denture
else?
ulcers can be put as pressure ulcers.
Which one?
Yes.
Denture ulcers.
And you guys are all, I know, there is always the keratinized tissues with the pressure ulcer, but I'm not sure the prevalence they were wanted to know with wound healing. Wound healing associated pressure ulcers, right? That's the question that was asked.
Yeah, right.
Yeah.
Okay. I think
And wound healing, yes, it's a part of everyone.
That's
and it is, you design it, otherwise you end up with necrotic tissues.
Okay.
Right. Any other question?
No, ma'am. Thank you. Thank you, ma'am. Here is your appreciation certificate from Team VISHNU ADHYAAN, ma'am.
Thank you. That's really wonderful. Very nice. Angelic. Thank you.
Next to Rupali, ma'am. Here is your certificate of appreciation from Team VISHNU ADHYAAN, ma'am.
Thank you so much.
Thank you, Dr. Sajjan. Sajjan, thanks a lot. Yeah, and Gautami, if you are around, thanks a lot. And yeah, we enjoyed being here.
Yes, ma'am, I'm around. And I loved really the presentations of both you and your student.
Thank
They
you.
were very awesome. But I was
Yes.
just typing, loved to see Rupali on the screen at least because I didn't get to meet her.
Yes. That's why I
It was
started.
good, ma'am.
Good afternoon, ma'am.
Yeah, good afternoon, Dr. Rupali. So nice. Both of you orchestrated very well.
Thank
you so much. Yeah, thank you so much on
Thanks for
behalf
your
of Team Adhyaan for really giving a very informative and interesting session. And the last slides on stem cell therapy, I think most of them loved them, ma'am.
Yeah.
They were very nice. They were very interesting.
Yeah.
As
I
it
think
is your article.
Yes. That is the mainstay now. If people have to try with no other agents, but their own stem cells will be the useful therapy for many of the diseases, which is really ongoing. And it should be taken up from most of and I think you can also step into it.
Yes, ma'am. Sure.
Stem cells, yeah.
Okay. Yeah.
Thanks a lot for giving us this opportunity again. Dr.
Thank you once again, ma'am.
Was ours. And then, yeah, see you all again. Bye. We leave the meeting. How is otherwise everything, Sajjan? Going on good?
Going on quite good.
Yeah. Morning, I was there with the inauguration. I think all of you must be tired. We'll catch up again. Take care.
Yeah. Okay.
Bye. Take care.
Thank you, ma'am.
Thank you, dear. Bye.
First day of Vishnu Adhyaan has come to an end. We thank all our first day resource persons, Dr. Vandana ma'am, Dr. Darpan Bhargav sir, Dr. Divya ma'am, Dr. Puneet sir, Dr. Shrutima ma'am, Dr. Sandil Murugan sir, Dr. Prabhanathan sir, Dr. Rupali ma'am, and Dr.
Rupali.
Soumya Verma sir, for their brainstorming presentations with their very good discussions. I hope all the enthusiastic participants had a very good day. Hoping with the same enthusiasm, all the participants, we expect you to join sharp 9 a.m. tomorrow. An important note for all the delegates is that to kindly fill the feedback form shared with the link. Thank you.
Thank you.